Good morning, everyone. Welcome to the second day of DASG. So we begin the day, and to begin the day, today we have a topic, a very important and relevant for all of us, the practitioners in the field of diabetes. Let's learn from Dr. Amit Gupta and Dr. Dhruvi Hasnani how to set up a diabetes clinic. Setting up a diabetes care clinic, that is very important word. I'm so sorry I missed it. So diabetes care clinic. So I invite the first speakers of the day, Dr. Amit Gupta. Dr. Amit, as we all know him, he has done his MBBS DNB. He's a fellow of Diabetes India, director of Center for Diabetes Care at Noida, fellow of Diabetes India and RSSDI, member of multiple bodies working with the field of diabetes, member of advisory groups, executive council member of National RSSDI, reviewer of endocrine practice, ACE case reports, executive editor of Sadikot International Textbook of Diabetes. He is the program coordinator and he has been awarded with multiple awards. So, Dr. Amit Gupta, can we have you here on the stage, please? Joining him will be Dr. Dhruvi Hasnani, another known name for all of us. So Dhruvi has done her MD and diploma in endocrinology from Royal College of UK. She is a consultant diabetologist at RIMS, that is Rudraksh Institute of Medical Sciences, HOD of Clinical Research at RIMS, Treasurer RSSDI Gujarat chapter. So she is winner of the Torrent Young Scholar Award, early career physician, and many feathers to her cap. If I don't read all of it, it's okay. So welcome Dhruvi and welcome Amit. Please take us through it.
Good morning, everyone, and thank you, Dr. Meenal, for the kind introduction, and welcome, Dr. Dhruvi. So we have limited audience to start with today morning, and I welcome you again on behalf of Diabetes India for this first time initiative of Diabetes Asia Study Group School. And we have in the august presence of Dr. Ajad Khan, who is the current chair of IDF Southeast Asia, is sitting here. Dr. Sanjay Kalra is one of the senior endocrinologists of India, past president of ESI. He is also here. So I think in this session, we wanted to discuss how to set up a diabetes clinic. And we wanted not to show you multiple slides, but to have more interaction. That what is your idea of a ideal diabetes care clinic? What are the components? What should be the components of such a clinic? At what level you are already doing diabetes practice, and how can you elevate it and add multiple components to it? So can we have some thoughts to start with? That what do you think? What should be the component of a diabetes clinic? Anyone from the participants, because this is going to be kind of a more workshop rather than didactic lecture. So
First of all, the doctor was confident in managing case of
so I think this is what the DSG school is doing, because for the last you had almost 6 hours of intense session in which you discussed that how to you discuss different nuances of managing diabetes and improved your knowledge. So now it is time to set up a clinic. So when you go back and look back at your practice, so how you what are the components which you are going to change? How you are going to set up such a clinic? So it is just a formal, informal discussion. So you can come up with your thoughts and ideas. There is no problem with that. You may not be right all the time. So Wahid, can you start with your comments and all? Right. So first thing is strengthening and enhancing your own knowledge. And I must congratulate all of you because you have taken efforts and pain to do that. That is why you are part of this DSG school. And learning and strengthening your knowledge is a ongoing process, so it is never going to stop. So every day is a new learning, so it is not going to be complete any day, but at some point you need to start. So you need to update yourself regularly. That is why the importance of attending such meetings, conferences, seminars, and that is why the importance of attending online programs, meeting with the peers, because you sometimes you may not be doing something, but your peers are doing something, and you'll catch up those things from them. So what is your take on this, Ruby? What is your idea?
Uh, so we've only been trained to do medical practice. Once again, good morning, everybody. When I say this, that the idea of setting up a diabetes care clinic not just requires us as medicos to have a training, but also an acumen. But there will be a lot of questions which will help and contribute to setting up a diabetes care clinic maybe back home.
So first thing is yourself. You have to be there in your clinic. Second thing is setting up a team. So what should be the component of a diabetes care team? So anyone? So do you have a dietitian or a diabetes educator in your clinic at this point of time? Yes. How many? Can we see show of hands? Yes. So, so let us ask that how does this having a dietitian or a diabetes educator in your clinic helps you? So, Dr. Bridgeborn, would you like to say something about that?
Thank you, Amit. Uh, Diabetes educator or dietitian helps in number of ways. One, as the name suggests, the diet counseling. Second, when we need to start insulin, telling about the drugs, possible side effects, hypoglycemia. These all things need to be instructed by dietitian or diabetes educator.
So, thank you, sir, for your comments. So, let me share my feedback with you. I have a diabetes educator as well as a dietitian with me, and let me tell you, she does more work than me, because it is like sharing a responsibility. So if you want to set up a diabetes clinic, then please think of having a team where you are educating each and every person in your team. That may be a diabetes nurse, it can be a diabetes educator, he or she can be a dietitian. Then your physician assistant is also a very, very important component. So sometime like you have seen many technologies yesterday, like putting up a CGM, taking data from a CGM, printing reports of the CGM. Sometimes you may not be available for each and every answer. So if you have a team uh, which can work with you, assist with you, and is knowledgeable. So building the knowledge of the team is equally important. So first thing is yourself, strengthening your own knowledge, enhancing your own knowledge, and then building up the team. So a team can have multiple components, but having a diabetes educator, a physician assistant, somebody who can, if you are having some keen research in interest in research as well, then probably having someone for the research will again help you in understanding your own data.
So, sir, if I may, I'll just ask them to answer a couple of questions. So now write down on that paper that we request you to, what is the first thing that comes to your mind when you hear a diabetes care clinic? And that will actually answer what Dr. Amit sir just asked you guys. Just take a moment, take 30 seconds, write down an actual answer, and then, we'll ask your opinions. Yes, please.
Good morning. In my opinion, diabetes care clinic would be a comprehensive place in which all aspects of the diabetes, along with the medical examination, maybe foot examination, physiotherapy, if required, dietitian, and all aspects will be covered.
I agree with you. And these should be component of a ideal diabetes care clinic. Totally agree.
Thank you.
Somebody else wanting to contribute to that answer? What's somebody else? Yes, please.
First thing that comes to my mind is just type 2 diabetes. As soon as we listen to a diabetes care clinic, uh, the approach is always type 2 diabetes when we know there are just too many types. So maybe even specifying the clinics
speciality in it. Even diagnosis, I would say, could be a part of your team in a diabetes care clinic, because it's very difficult to diagnose the kind of diabetes also. So as soon as it's diabetes care clinic, we tend towards type 2 diabetes when we know there much more.
I so agree with you. A lot of us, when we think about diabetes, we think type 2 diabetes. But again, such platforms wherein learning plays a very important role, that diabetes is not just type 2. It could be a varied, different spectrum of diabetes that we need to take care, learn ourselves, and train the team that we are using as a multidisciplinary team in our diabetes care clinic. Amit sir, what's your take on this?
I agree with you because, and I don't think there is anything wrong with that because more than 95% of the people they are going to have type 2 diabetes only. So it justifies that if even if you are uh, uh, making it a type 2 diabetes management center, but type 1 diabetes management requires a totally different skill set. And if you are comfortable enough to, and if you have time to devote, because if you want to do type 1 diabetes care, then it will need a lot of time because handling such patients, people living with type 1 diabetes will require a lot of time to explain the things, to guide them regarding the insulin therapy, to monitor the data. At the same time, they will also require proper hand holding. So if you don't have that kind of setup, probably you will feel that you are not making any difference, and your type 1 diabetes patients are treated just like you are treating type 2 diabetes patients.
May I add something to that? Time and again, it was Banshi sir and Dr. Vipul sitting over here. They have had this discussion. You have to come out of the physician mindset. I've heard this so many times. Even Rajiv Chawla sir, Amit sir, he's been telling us that coming out of that mindset and then trying to focus on a disease aspect, which is a chronic care disease, thinking from a point of view that the person coming to you requires a lifelong management, and not thinking of it from just an acute therapy modality, is something that will take a little training, that will take a little time. And that's the first thing that you have to train yourself with, is the mindset. Do you have the mindset to practice chronic care medicine? And that is where the first thought of diabetes care clinic, plunges up, sir.
And it is not necessary that it is your private practice, because we encourage you, if you are working in a government institute, you are working in a government hospital, in a government medical college, again, you can set up a diabetes clinic there. And many of you, I believe, are working in such kind of setups where you are in public sector as well. So you can set up a diabetes clinic, and I believe Dr. Ajad Khan is one of the best person to ask, because there is a dedicated diabetes hospital in Bangladesh. Sir, would you like to comment something on your experiences and message to the DSG school members?
Oh, well, thank you for asking me to see what we do in Bangladesh. You see, number one, I think diabetic clinic should be a part of a general hospital. You see, if it is isolated, then people with diabetes, they also may have other disease, number one. And diabetes, you can call it the mother of all diseases. It affects all systems of the body. You know, in our days in our medical college, we were taught that learn syphilis, then you will know medicine, because it affects all systems. So that can be said for diabetes today. So that's one thing. So there must be facilities for looking after other things. All this focused on diabetes. Or there should be a referral, pre-arranged referral, that if you come here, if you have other disease, we have links. That's one. But anyhow, I will not make a speech, but I will just word one thing. At the present day, with what you call electronic communication, there should be a method of looking after diabetes, including his education, nutrition, online. Because at one time, even in Bangladesh, we were counting success, that how many times the patient came to the clinic. Now we measure success that at no visit, whether we can keep them in good control. So that's it, because it is possible, it can be done. If you educate and you have got the things to electronic linkage. You'll of course need high-speed internet connection, you see. I had the privilege of visiting in Calcutta one of the clinic in Sundarban, and they were saying that they can't find any doctor there, you see, there. So I advise them, you just ask the government to put a high-speed internet. And even a paramedic can look after, and the doctor in Calcutta can supervise. I hope that I haven't taken too much time. Thank you.
I think your feedbacks are very important because telehealth is again a very important component. So now I will request Dhruvi that you proceed with your presentation. Then we leave next few minutes for the discussion. Maybe we will have more discussion after your presentation.
Sure. Thank you. Thank you, sir. Thank you. That was a wonderful insight. Yes, yes, yes. Sir.
Well, I don't know about detail about in India, you see. In Bangladesh, main inhibition or block is from physicians. They don't want to refer patient to the educators, you see. Education is a special art or science, whatever you call. I'm not saying the doctor don't know it, but they may not know it as well as a good educator. That's number one. It's how to deliver the message, number one. And neither the doctor has the time, you see, to do it. So this is one really what you call the innovation that, and we have not been able to uh, get over that in a private care setting, you see, where doctors are concerned that they don't lose patients, you see.
Thank you, sir. It was really enlightening. See, these are some examples. If you're here in Ahmedabad, if you're in Delhi, if you're somewhere else, there are examples of diabetes care setups which you can physically go visit and have a feel of how they have been set up. My next exercise for all of you, again with a paper and pen, is going to request you to define your vision and mission. Think about it. Again, take a minute, write it down. What, as a diabetologist, let's call ourselves that in the entire group. What is your vision? What is your mission? Take 30 seconds, write that down on a piece of paper. Go back home and execute that. I'll give you 30 seconds till then. And in the meantime, again, if somebody wants to, just stand up and share that, again, by attending this school, has the vision changed for you from what it was previously? Generally, with diabetes care setups, again, the first significant point that all of us think about is the person with diabetes. We no longer call them patients, but still the scientific and the medical terminologies everywhere talk about a patient-centric approach. And that's the first scientific focus or a vision or a mission that you should have. Like we all just discussed, like Sir just gave his insights to us, incorporating education, having a diabetes educator who not just takes care of that person with diabetes, but also unloads. You delegate your task of education to a diabetes educator who can have the compassion, not sympathy, but empathy towards that person with a chronic care disease. Again, look at the last two words. They are prevention and advanced management. Science is always evolving. We can never be in the same place every year. You have to always update yourself with every evolution that is taking place in the field of science and the field of medicine. Read, collaborate with people across the world. We are the entire Asia Study Group population over here. Learn from each other. And let us also talk along with that about preventive medicine. Type 2 diabetes, like we just discussed, is one of the major preventable conditions which can, when given proper education, the person with a high risk of diabetes can be prevented from any sort of complications or onset of diabetes as well. The next exercise, again, for all of you, there is something known as a market analysis. With a raise of hands, how many of us from the Indian diaspora? Yes, please. I'm not asking you to make a noise, it's just a raise of hands, right? How many from the, other, let's say Middle East side? How many of us from the Southeast Asian population? How many of us? Yes. One, two. So market analysis of your particular geography, of your particular area is going to matter for all of you. We need to identify our target demographics. We need to know what is the prevalence of the condition that we are going to treat in our population. We need to have a geographical specific for India, west, north, east, south. For somebody from Bangladesh, for somebody from the Southeast Asian population, you need to have the know-how of your own geography and understand what is the best place and the location for you to initiate a center which is going to not just benefit the current population, but also prevent the next upcoming population from having the condition that we are all talking about. Understand your competition as well. We don't much talk about that, but as a person who is taking care of such a large diaspora, you have to think of your competition as well as who else could be your team. Like sir said, a diabetes care clinic needs to be in a general medicine hospital. You need to know what are your other unique service opportunities. As a diabetologist, you will need referrals of the other super specialty as well. How many? I'll start with this row. What do you think would be the first referral point that you would require? Just say cardio, nephro, neuro, what else? Speak up. Yeah. Just one specialty, one word, one specialty. Ophthalm, nephro, primary care disease, okay. Surgeon, okay. Cardio, nephro, dentist, wonderful. Next. Psychiatrist, yes. What else? Sorry? We got the ophthalmologist on board now. Everyone. So that's the unique opportunity that we are talking about. We are going to need all of these in spite and despite of taking care of the hyperglycemic status. We know that these people are going to develop complications come what may. The more you're doing your job better, the lesser will be, the unique service opportunities that we are talking about, but they will require screening. They will require specialized services. And this are the specialities that you can collaborate with and work with, again, to have a proper diabetes care setup. Now look at these slides. I don't know why this is being cut off over here. This is the slide which is in entirety. Just look at the market analysis. These are all older slides from, if you guys know, there is an entire diabetes digital market analysis. You just have to Google that and you will get all of that analysis on, just one click. These are huge analysis which tell you why opening a diabetes care center is not just in the favor of us as clinicians, but also for the other super specialties that we just talked about. You just look at the numbers, they are in billions. That is why diabetes is also a public health issue. As a person with diabetes, he or she is expending huge amounts of money per month and also per annum and contributing to the economy in a negative way. In the public healthcare sectors, it is a burden for them to take care of a person with diabetes. The figures are in billions, and again, these are older statistics. Let's write a second thing. Just write what location you are thinking about when you want to open your diabetes care center. Let me also request you to name your diabetes care center. On the top of your paper, write the name of your diabetes care center. You may or may not change it later on. Think of the location you want to set it up in. Think of the first basic requirements that you will have. A cabin, yourself, a stethoscope, a glucometer. What else? These are the first four things in my mind. Somebody else wanting to. BP instrument, a sphygmomanometer. Yes, that's the BP instrument. Weighing machine. Ma'am, somebody else. A stadiometer. Yes, from this side, from the back side, please. Height, yes, stadiometer, ma'am said that. Next, monofilament, yes. Pulse oximeter, yes. A measuring tape for the waist circumference. Next, ophthalmoscope. Then you'll require special training to look at the fundus. There are biophysiometer, yes. Weighing machine, we got that first. Handheld Doppler, okay, fair. Again, you have to train yourself. These are special modalities. Now AI has made it possible that there are non-dilated ophthalmoscopes. There are proper handheld Doppler wherein you might or may not have a proper training for that. Anybody else with anything? A PC, an ECG machine. Then, sorry? Pen and paper, absolutely. Next, all right. So there are a lot of एक receptionist भी चाहिए एक receptionist भी चाहिए एक educator also you need a nutritionist you need a proper housekeeping staff as well you when you open a clinic you will need a proper person for the biomedical waste also you'll need proper bags for that also proper disposal of sharps also you'll have to talk about these are all very small things that you come to know when you are starting to pay the bills for all of this technicians you will need. So all of these are your points that you can, note down, go back home whenever you think of executing those. The second thing is a space requirement. What is the smallest space can you think of to open a diabetes care setup? What is the largest space you can think of? I understand it in square feet. Or sometimes, I just ask my partner, how much do you think is that square feet in terms of our house? And he'll tell me that this is the square feet. 500 to 600, fair enough. So one OPD, one another small one, and one, say, examination couch and diagnostic area. All right, fair. What could be the largest one that somebody can think of? Largest has no cap. Exactly. So we've seen diabetes care setups which are 3 floor, 4 floors, 5 floors, and then we've seen very composite and a comprehensive diabetes care setup like Dr. Vikranti will, maybe if you're interested and you request her, she'll take you to a setup like that. And even in 500, 600 square feet, you can have a very comprehensive unit. The next thing is healthcare regulations. Registering your clinic with the appropriate authorities in your country, in your state, and getting it properly licensed. You need a C form when it comes to Gujarat. I think with the other parts as well, you require that. Registering yourself, maybe getting it accredited or collaborated with a center of excellence, having a mentor that can teach you to have the center in a very systematic manner, having a SOP, having a protocol for your newly diagnosed type 2 patient, for your newly diagnosed type 1 patient, for your females with hyperglycemia. All of these are very small nitty-gritties that you have to consider when you open your own center. Anybody would like to, somebody who's just recently opened their diabetes care center? Nobody? Anybody who's thinking of opening it in the next 6 months to 1 year? Yes. 2, 3, amazing. 4, nice, nice. See, these are the control protocols because everywhere the medical legal things are the first thing that you want to look at. First, go back home and look at all of those regulations and all of those protocols that need to be executed and do not ignore that quality control and quality check for our staff, for ourselves, for the regulatory authorities. There are regular renewals of all of these which need to be looked at. Sometimes what happens is you never know when to renew it and it is just lying around there. Now, this is another exercise. List 3 essential features of a dream diabetes care clinic. Don't restrict yourselves. Write down the first 3 essentials that come to your mind when you think of a state of art, your dream diabetes care clinic. Patient, patient, patient. That is very important. That is very important. Somebody else with another dream idea or dream essential? AI driven. Okay, amazing. Patient research and education. Amazing. Okay. That's your diabetes care clinic. You can have a mermaid in your clinic and it's fine. Somebody to, you know, say, call the people up for follow ups. Like, that is covered in the patient, like Kareena Kapoor. Good looks, good looks, good looks.
I would want a summer camp.
You would want a summer camp. Amazing. Okay. And summer camp for who? For the type 1s, for the type 2s, for the adults, for the kids, for the mothers?
Summer camp बच्चे के लिए and mothers maybe, but
Okay.
weekends या फिर long holidays for type 2s.
Well, great. Weekend camps. Her diabetes care center. That's her essential. Go back, look at these, and aim for the highest always. Aim for the best always. This is what is going to drive you to set up the best diabetes care center for yourself. Some essential services to offer. Number one is diabetes screening and diagnosis. It's not just the people with diabetes coming to your center, it is also their relatives that need education. It is also their parents, their kids, their spouses who require diabetes screening and diagnosis, who require the education that you might equally be at a risk of diabetes, and please screen yourself. And that screening technique, maybe through a point of care, just a glucometer, getting an HbA1c done, educating them, or there is a diabetes risk score. Just calculating that diabetes risk score is also something that is important. Another thing, like somebody already contributed, technology. Making it the latest and the most advanced tech center could also be one of the essentials for people. But learn how to use that. Whenever we are prescribing a certain technology to a person with diabetes, you yourself need to justify the use of that and that person for the management. Insulin management, lifestyle counseling, nutrition management, exercise, stress management. Somebody said we need to have a psychiatrist, we need to have somebody who's a counselor, and also complication screening, monofilament, biothesiometer, handheld Doppler, or fundoscope. All of these are some very basic things that you can keep a technician in your place, train him or her. There are point of care urine ACR devices, there are point of care A1C devices, which you can include into your center. This is a simple pathway, look at the equipments that are there here. Sir already told us about an EHR usage. A simple Excel sheet also works. Not expending, there are a lot of EHR that are freely available, but if not, there are simple Excel sheets, putting in basic data set, the name, anthropometric data, number, email address of that person for your own purpose. The first baseline reports, the first baseline, say, body composition, what prescription did the person have prior to your clinic visit? What did you prescribe? How did it make a difference after 3 months or 6 months? All of these are some very, very basic things that you can use in your OPDs. There are a lot of patient care pathways. I've also taken it from the internet. These are very easy to follow pictures that you can replicate into your center. You can have a consulting center. Starting from a reception, you can have a consulting center. The person can go to a smaller diagnostic unit, get the point of care or actual lab blood collection. You can recommend an ECG, you can recommend a fundoscope, you can recommend a neuropathy screening, you can recommend all of these into a diagnostic center or a smaller unit also, or a smaller space also. At our places, we have a smaller section specifically dedicated for these screening purposes. The person can come back to an educator or a counselor who explains the importance of these reports, who explains the importance of these screening. When do they need to repeat this? That is also more important. It's not just for this one moment, it's not just for this one today. When do you need to get yourself repeated for a fundus examination? When do you need to repeat your foot examination? When do you need to repeat your ECG? When do you need to repeat your urine ACR? All of these are important to be educated or counsel to the person with diabetes. And then, of course, you being the most important person of the entire system, explaining, reinstating the entire importance of the system to that person is going to give you better patient outcomes, better follow-up. The person in a democratic country like India, they are free to go, window shopping for doctors also, and we see that quite often. What you have to have is the correct empathy and the correct scientific approach to that person. Give your all in, and just have the patient do a proper SMBG, and self-care is what you have to teach that person. How do you take care of yourself at home is what you have to teach that person. Again, another answer for all of you to write down on your papers. What service do you think your person with diabetes will find most valuable? Out of the entire advanced AI technology, the plethora of screening tests that we talked about, what is the most valuable service that your person with diabetes will find? Easy access to doctor. Do you think you will be easily accessible? I don't know. I have a question to that. Would you be picking up phones when that person is trying to talk to you? My opinion, yours can be different. Somebody else? Free blood sugar screening. Okay. Okay. Write it down. That's your own notes. Somebody else? Diet and lifestyle management. Okay. Okay. Somebody else?
Explain all strategies to give time to the patient to explain all the strategies.
Giving time to the patient. I have an opinion on that, a very strong one. I feel on an average, if you are able to see, say, 25 or 30 patients per day, you will not be able to spend more than 5-10 minutes to the max with a person. Is that going to add value? Because people sometimes have so many questions. They will want you to answer, "Can I apple kha sakta hu? Can I have a banana?" They'll want you to answer that. Offering the best prescription and leaving it onto the patient whether they want to follow it or not. Fair. Okay. Somebody else? There's no right answer. It's just for all of us to understand and learn from each other. Yes. I learned that the very hard way. You have to listen. You can't just be writing that. You have to listen, give them the time. So across different, times of years of practices, she also said time, you also said time, he also said listening. So we are coming to a consensus that time is very valuable. Yes, sir? Post effectiveness of treatment. Well, sir, you haven't. Sanjay, sir.
What is most valuable is the human touch, because if that's why people come to us. If you don't have the human touch, if you don't have empathy, there's lots of places to get treatment from online.
Thank you. So I think the most valuable then, according to the consensus, is time, human touch, empathy. Use that into your practice when you go back home. Write that as the biggest valuable thing that you have to incorporate when you go back home. Something else, and we are, completely skipping the entire thing and going to technology, which is inhuman, but integrating technology along with that empathetic doctor who is seeing and understanding the situation. Somebody coming to you is, pouring in their most vulnerable part, telling you their most, weakest signs and symptoms. You will have to show them that you understand what they are saying. You will have to reassure them continuously that you are understanding what the trouble is, what the sign and symptom is, and then looking at it from a scientific point of time. It requires a lot of, mental exercise on our part as well to not get that personal with that person that you are showing sympathy, but yet have that actual empathy to make the person comfortable in your presence that he or she can come back to you again. This is one of the market surveys again, which is telling that integrating of technology is going to increase your revenue. A very important word which we shy away from talking as doctors is revenue. We are very uncomfortable talking money. I understand that it is a very noble profession, but we also need to earn our bread. We also need to talk about the revenue system. So one of the market surveys does talk about that integrating technology is going to contribute or accelerate your revenue by almost 10%. So again, don't shy away from maybe going to a senior practitioner and asking him or her, how have you increased your revenue? How have you increased your patient flow? How can I add to my existing system to help myself generate a certain number? Don't shy away from talking that. Another thing is a team building. What we are doing right now is interacting with each other, learning from each other. You will have to do the same when you go back home and you build your own team. You will be the leader of that team. You will have to talk to those that you are hiring, maybe from starting from the receptionist to the counselor to a physician assistant to a housekeeping staff as well. You will be a leader of that team that you're leading. All of these are your core strength. A person might come to you because you're a good doctor, but a person might go away if your reception staff is not good, if your nursing staff is not responding properly to the queries. You might have an extended team, the specialists, the super specialists that we talked about, the ophthalmologist, the pathologist, the psychiatrist, the neuro, the nephro, the cardio. Everybody is your extended team. And continuous training. I so often hear, sometimes I complain about my own team to my partner, and he says, you need to train them. You cannot complain about them if you're not training them well as to what you're expecting out of them. You will have to tell them that this is a 100 IU syringe, this is a 40 IU syringe. You will have to tell them on not reusing the insulin syringes. You have to tell them that you have to teach the same thing to the people with diabetes whenever you're prescribing insulin. Rotation of sites, storage of medications, rechecking the medications when they come back from the pharmacy are all a part of continuous training for your staff, for the team that you're building. Again, another question, and we've got just a couple of minutes left. So now write down what are the digital tools that you have seen so far yesterday and today that you are so impressed you want to incorporate them in your diabetes care. Very quickly, 10 seconds, we'll write that down and we'll move on. CGM, the newest glucometers. There is an AI stethoscope as well that tells you that this is a murmur, this might be the diagnosis. The handheld Doppler, the non-Midriatic ophthalmoscope, all of these. But we end and we come back to the one simple thing. You have to have a patient-centered approach. You cannot cook the same food for everybody. You need to communicate yourself well. You need to have some amount of empathy, but still keep that distance. In our community as Southeast Asians, across our all geographies, that is very important that you have to be strong in putting your point. I just read a very important thing that do you think that your person or your patient is coming back to you because you were just empathetic, or were you very sure enough of the prescription that you were writing, or because you gave what he wanted? Sometimes patients go to other doctors because they feel that you were not strong enough or you did not believe in yourself when you wrote that prescription. So make sure that you have that confidence in yourself, learn, educate yourself, and train your staff as well. This is an ongoing process that never stops. Another important thing is patient education workshops and some community outreach programs. Like we had the idea of those camps. There are different community workshops that you can do in the periphery of your geography for, again, good inflow of patients. And we cannot, again, shy away how they are going to contribute to the revenue system. A very important thing, again, we don't talk about this often, the financial and the operational planning. We have to accept it that we are not trained for this. We are not the best people for it. Get help. get a team member who understands finance, or just hire somebody for a ad hoc basis and talk to them about how budgeting and funding sources can help your system. Talk to people about insurance partnerships that can be made. Talk about proper billing systems. Talk about proper taxation systems. And talk about sustainable pricing models. You cannot be doing charity all the time. A lot of people have told me that charity begins at home. Again, my partner really differs. We are two people practicing in the same place. And he tells me that do not do charity in your own place. You want to do it, do community outreach programs, do educational workshops, but do not do it in your own place. So sustainable pricing models for sustenance of yourself as well as your system is something that we all need to accept and do. Marketing. There are a whole lot of medical legalities when it comes to marketing of doctors for everybody. Look at social media, have your own website, talk about customer reviews, do your own blogs, talk about telediabetology, but put yourselves out there in a manner that you are doing a proper marketing of your own system. I end with talking about research collaborations. We are a huge group of people with varied interests in different sectors of diabetology. Collaborate with each other, talk to each other, share your research ideas, and you can come out with best of the best research for diabetes. This is almost one of my ending slides. Plan, provide proper services, have a good team, incorporate technology, keep the focus on the patient, and also do not forget the operation and the planning. Diabetes care clinics are more than medical facilities. They are centers of hope because you are taking care of a person with a chronic care or a chronic condition. They are going to come to you day in and day out, say at least 3 times or 4 times a year. Make sure you are building some sort of a bond with them. With the right foundation, your clinic can make a lasting impact. So with that, I am going to request Meenal ma'am to take it up again.
Oh, absolutely, absolutely.
Amit, see him around. So that was wonderful. I am sure we all are ready to have our clinics, or maybe we can revamp our existing clinics. So there are a few points. I'll just quickly revise with Dhruvi what we learned. I have my own center by the name of Sashakt Endocrine Center, and of course, I am also working for a corporate heading the Department of Endocrinology at Manipal Hospital. So, talking about the corporate or the hospitals, endocrine department is still a referred department. We have very few patients under our direct admissions. Mostly it's a teamwork, and we are the backbone of every department. No CABG happens without us. No ortho surgeries, knee replacements, hip replacements, gynec surgeries, or anything happens without us. So we get the first call. Please give us good sugar control so we can operate. So we are the backbone, the showcase department. Initially, endo was a showcase department, but now we have made ourselves a backbone department. So that is how endocrinology, the diabetes department works. And as she said, be a good physician first. This is what I learned from my mentor, Dr. Arpandev Bhattacharya. I think he will be here in the conference. So he taught me first be a good physician and then be whatever you are. So we treat patient as a whole and we just don't treat diabetes. We treat patient. So we have to be a good physician first. It's always a teamwork and the team should sync. It should not happen, as Dhruvi said, Kela khau ya nahi. Your dietitian is saying something else, you are saying something else. So the team has to sync. Another point that she took up was revenue and technology. I agree that integrating technology will increase your revenue, but please take out time to explain that technology to your patient. Patients will come and tell you ये CGMS लगा दिया क्या था क्या देखा आपने उस ग्राफ में हमें तो बताओ we have paid but that we don't have time to explain to the patient. So please take out the time for that. And so from here, thank you Dhruvi once again.
Thank you, ma'am. Thank you, everybody. You've been a wonderful audience.
We move now to our second session. We will be learning from the learned people, Dr. Sanjay Kalra and Dr. Atul Kalhan. Sorry. We will have Dr. Helena Teeth from Australia to accompany Dr. Sanjay Kalra on the dais. Dr. Sanjay Kalra is again another leader of one of the private setups, and we have learned from him the Bharti Hospital at Karnal. He will teach you one of the pioneers of setting up a diabetes clinic, maybe. He's the treasurer of the International Society of Endocrinology, president, Association of Longevity and Anti-Aging Medicine, that is geriatric medicine, past president ESI, past president of SAPS, past president of IPATH, and vice president of South Asian Obesity Forum. I also invite Dr. Helena from Australia. Madam has done her MBBS, FRACP, and she's a PhD, graduated from Monash University, a very senior practitioner since 1989. She's a clinician, academician, endocrinologist in Australia with a professorship and NHMRC Investigative Fellowship in Women's Health, Director of Monash Center for Health Research and Implementation, Monash University, and a team of 120, and leads the Center for Research Excellence for Women's Health in Reproductive Life. She has over 700 publications, world leader in PCOS. She's the president of International Society of Endocrinology, chairs WHO Task Force, and has many accolades and feathers in her cap. So we welcome you, ma'am, here. Sir, all yours.
Dr. Meenal, but the actual leadership is yours. So thank you for leading the way and starting the first DASG school. To everyone who is here with us from India, from beyond, across Asia and Africa, a warm welcome. And you are the leaders of today, the leaders of tomorrow. But before we ask Dr. Helena to begin her talk, what is special about today? Today is the 14th of February. Anything special about that? Valentine's Day. So in Nepal, Dr. Robin, how do you say Valentine's Day in Nepali? And Dr. Yadav, is that right? Is the translation correct? Yes, okay, so that's fine. So we've got off to a good beginning. Now that's what leadership means. But the sun rises in the east, so let's begin with the east. Anyone from East Asia, would you please raise your hands? Anyone from east of India? Bangladesh is also east of India. Dr. Zadghan sir, raise your hand, sir. No, we are bhai. Okay. So, same blood. But anybody else? Yes. Where are you from?
Kolkata. Kolkata.
Kolkata. Okay. So that is the eastern part of India. So warm welcome. So in Bengali, how do you say Happy Valentine's Day?
তোমাকে বড়ই ভালোবাসি।
Okay. And anyone who can vouch for the translation, is that right? Dr. Khan sir, is that right translation? Okay. Anyone from the Middle East? Central Asia? Yes. Where are you from, madam? Uzbekistan. So warm welcome. And actually, Uzbekistan has a very important place in Indian history because the entire Indian history was changed by one particular gentleman from Uzbekistan. Anybody knows who his name was? So there is something known as the butterfly effect. We'll ask Dr. Helena to talk about that. And let's take the butterfly effect as our theme for the next 35 minutes. The butterfly effect states that if somewhere in Uzbekistan, a butterfly flaps its wings, that can create a tsunami or a cyclone in East Asia. So one action leads to another. This is what happened in Uzbekistan when a gentleman called Babur was orphaned actually. He moved from Uzbekistan, found his way to Iran and then Afghanistan and then India, and he created the Mughal dynasty for us. So that is butterfly effect. If he had not been orphaned in his village in Uzbekistan, we might not have had the Mughal dynasty. Our history would have been totally different. That's what butterfly effect is. What does butterfly effect mean for us today? What it means is that all of you are here with us. We are here together with each other. The key word is together. When you saw Dr. Dhruvi talking about how to set up a diabetes care clinic, she never said you can do it alone. You need many people with you. That togetherness, how do we add leadership to that? Whom should we lead? What should we lead for? If we can understand that, then we can create a butterfly effect for diabetes care, for healthy diabetes outcomes. With that, let me invite Dr. Helena. Dr. Helena looks after the International Society of Endocrinology. So, madam, the floor is yours. What do you think of the butterfly effect and your career in endocrinology? And what advice would you have for all of us?
Thank you, everyone, and thank you very much for the invitation to come. I have to say it's a lot easier to come to India from Australia than it is to go to Europe or to North America. So thank you very much for the invitation. So the butterfly effect, what has that meant for my career? I'm sure there are many times that minor things happened that then had longer implications. And then there were major things like my young children that had very big implications in my career. But I think for me, one of the things that happened very early is that I was offered an opportunity to do leadership training. This is not something I would have normally done in my career. And at the time, there were very few female endocrinologists in Australia. So it was an opportunity, perhaps one of those butterfly effect moments, Sanjay, that led to a much greater focus on leadership. And most of my career, I still do clinical practice and have led in fact, the largest diabetes unit in the country. But I have very much and increasingly focused on leadership, bringing groups of people together across the world to make a difference. I believe from Sanjay that the audience in this forum are people who have significant leadership roles and influence in your region, and I'm going to assume that when I'm talking here. So one of the problems we all have when we want to improve healthcare, and we've had a really nice example of what you can do in your own practice and how you can set up multidisciplinary care in that context. Obviously, there are many other players in that context. There are community health workers, there are hospitals, and in every different health system and country, that is different. For example, having done studies with Dr. Nikhil Tandon from AIMS across Bangladesh, Sri Lanka and India, I know that your health systems are all very different, even within the South Asian region. And I'm sure from one region to another within India and in other countries, they differ again. But one of the problems we often make when we try to drive improved healthcare is that we just think of our own practice or our own hospital or our own team. And what we know is that's not enough. For example, I've had the privilege of being involved in many global alliance of chronic disease projects that have been funded in India, Bangladesh, Sri Lanka and Pakistan. And the learnings from those large projects are the same as the learnings from all other projects around the world around diabetes and diabetes prevention, which is you cannot do it alone. And the projects that work because the leaders who are working in diabetes work with their community, work with their health services and work with their government. And when they start to work with other people, they can make a difference. So we're going to talk a little bit about thinking about the parts of the system that may not be your individual practice or your individual hospital service. What is the real system that you are working in? Because if you don't understand it, it's very unlikely you're going to be able to change it. If you want to make a change or you want to situate your practice or your health service in that system and make it an integral part of that system. So it's not just about your patients as your clientele, but also about how you work in the healthcare system. You need to understand it. You need to bring all those teams together and make sure that everyone agrees on the problems and the priorities. For example, you all wrote down before what the 3 top things you think are most important in your context for good diabetes care. The challenge is that is our perception of what we think is most important. But if we don't know what is most important to our patients, if we don't know what is most important to fit into our health system, if we are not part of the solution, we're just another part of the problem. So understanding what the collective problems are and responding to them means that you will be personally in a better position, but your service will be better and your outcomes will be better. The next thing is to make sure we use best evidence and that we understand how to drive change. So one of the challenges we have, and this little cartoon down there is an understandoscope, meaning we all look at a problem and understand a problem from our own perspective. And presuming most of the people in the room are doctors, We think we know what it's like to live with diabetes. We think we know what optimal diabetes care is, but that may not align with our funding system, our government, it may not align with our health system, and it may not align with all of our patients. If we only think about it from our perspective, we will not see the big picture, and we probably will be struggling or fighting against the system. These are silos, these are wheat silos, and they're all across Australia. We've decided to paint them to make them look nice, but they are still silos. And that's what much of our health system looks like to our patients. If they're going to a different place for their pathology, to a different place for their cardiology, to a different place for their diabetes care, they can spend a full-time career going to all the disparate places that they're trying to get their care provision. The other problem is we often will look at a problem very much from our own perspective. So we go down a rabbit hole, so to speak. In other words, we only look at the problem from a very narrow perspective. There's a strong argument that what we need to do is flip the paradigm and not necessarily see the problem always from our own point of view, but actually see the problem from those who have diabetes or are at risk of diabetes. So flipping the problem so that we understand the problems and we understand the solutions. So the first thing in diabetes is understanding the problems. I'm sure we're all aware of the global burden of diabetes. In 2021, there was 529 million, the vast majority with type 2 diabetes. The prevalence was 6.1%, and 52% of that burden was due to obesity and rising BMI. By 2050, it's projected that will be 1.3 billion, and most areas around the world will have a 10% prevalence of diabetes. It is incredibly unlikely that we will be able to continue to provide individual health care in the way we are currently doing it to 10% of the population, let alone being able to focus on or not focus on prevention as we currently do. So we need to address this problem at a very big public health level, and I won't address that here today. But if we understand the problem from the patient's perspective, almost every hour, waking hour of every day, they're living with diabetes. They're the ones who are moving or not moving, eating well or not as well, testing their sugars, looking after their complications, administering their medications. They will see us for a very small period of time in a total year. And to think that we are largely responsible for the control of their diabetes is a problem of that understandoscope. So this is a condition where it is largely up to the individual with their social support networks, education and health services as part of that on how they control their problem. And increasingly we're seeing a move to all sorts of support strategies for diabetes that will involve us, ideally, but are also additional to us. That includes using digital technology. We've seen continuous glucose monitoring. We've seen insulin pumps emerge. We've seen a range of new digital tools to help our patients. Those are much better used if they're used with us, if they're integrated into our care, which means, again, we need to see that perspective from the patient's point of view. And if you think about what happens when a patient has a diabetic emergency, now some of them are very good at this because they may have many of them, but the reality is if you have an immediate diabetic emergency, from our government point of view, this little box over here is what they think happens. The patient has a problem, they come to the hospital, they get managed by the hospital and they go out again. And we know that's completely not what happens to the majority. In the ideal case, they would get support when they first became unwell. You could be part of that network. It could be a community health. It could even be family. But there is a range of different complex providers that person can go to. And if we don't think about that system and optimise the way they engage and become part of that system, then they will keep going in and out of hospital. And indeed, diabetes is now the #1 preventable cause of hospital admission in most countries in the world, largely because of this mess, because we haven't thought about a way to address the system. And there are places that are doing that. There are places that are integrating healthcare, social care and medical care and actually coming up with much better outcomes. But if we're going to drive a change in our system, and this has been shown very well in India, as I said, in India and in the South Asian region, that we need to understand all the people who are important in changing the system. That includes the individual, which is the patient and their family, but it also includes ourselves as doctors and providers. It includes the organisation, which is our health services and our community care providers, and it includes the system that we're working within. If we don't understand those things, even in the context of our practice, it's unlikely we're going to be able to offer an integrated care program for our patients. So if we think about that, the outer setting or the system is what is the culture in the area you're working in? What is the practices around diabetes? How is it perceived? Do people actually seek and can they access care? What are the policies and systems and things that offer opportunities for those patients? The inner setting is what your organisation is like, which might be your local health service, hospital, outpatient or private practice. What is the structural characteristics? How does that actually function? Is it an all-in-one stop shop like we saw in the example in the last talk? Or is it a sole provider who just provides consultations for diabetes? So what is the nature of the service that you're working in? And then the individuals involved. Again, if we don't understand and work on improving their knowledge, beliefs and attitudes and looking at how we can help support them, that's going to be a problem. Our patients may, as we heard in the last talk, want to talk about whether or not they can eat a banana. And I'm sure they've got a lot of questions they want to ask us. But again, if we seek to do that one-on-one, individually for every patient, that's going to be very challenging. But if we can link into evidence-based, reliable, simple, accessible digital education tools, and we can make sure they're reputable and refer our patients to those, our patients will get a lot of the information they need without surfing the internet and misinformation and just be able to raise the critical questions they have that emerge when they see us next. But if we don't understand that context, we won't be able to support them. Then we need to know what actually works, what is effective in terms of being an intervention, and then how we adapt it to our context. For example, artificial intelligence was mentioned before. It can be fantastic. It can also be very challenging. And if you are going to look at artificial intelligence interventions, you're going to need to know that they work and that they are effective. So if we think about what that means you need to understand who the people are that are stakeholders. You need to understand and be able to link to your community, and that's not just your own patients, but your patient support groups as well. And that includes things like local government, other health services that you may wish to integrate with. So what are the policy contexts that you need to fit into? What is the opportunity within your organisation to improve the systems? And always, always see this from the person's perspective, not your individual patient's perspective, because you have a doctor-patient relationship with them. If you ask them to come in and tell you about how to improve your practice or your health service, you may end up talking to them about their own HbA1c and their own private diabetes management. This is about community members who have diabetes who come in as experts in the lived experience of diabetes, and having them involved, for example, being an advisor to your service or your practice, is completely different to just asking a patient to come and tell you what you wanted or sending out a survey. So respecting that patients can bring, or community members can bring a great deal more is really, really important. And you will now see this in all the best centres that are in most of the high income countries will have a patient advisory group, and they'll bring those experts in to give them that understanding scope, different perspectives to their own patients. And then when they go to drive an initiative of change, they make sure it's evidence-based, they set their objectives, and they work through driving that systems change. One of the problems is even if you understand the system you're working in and you bring in your patient and community to know what to change, it's hard to know how to make change. And this is one of the challenges we were working on with groups around the world about how you effectively drive change. So we have undertaken a very large project on improving health outcomes, and we've used a big focus on data. If you can't measure something, you can't show it's improved. And that's what we do with our patients with their HbA1c and their cholesterol and their blood pressure. But we need to do it on a practice and a health service and a regional level to be able to show that that's actually changing. So we set up a governance model which had international experts. We undertook best practice evidence synthesis to look at every example in the world for any condition where people had looked at a learning system on how to improve healthcare and had shown a benefit. Surprisingly, there are not that many of them. And from that, we adapted a learning health system model which essentially said we were going to bring those 4 quadrants together: evidence from our stakeholders, our patients, our community, and our context, evidence from research and guidelines, evidence from what we currently do in practice, so our data, and then evidence from improvement when we try to drive change. If you bring those 4 things together in that order, there is very good evidence that you will make a difference. However, if you just go and drive an improvement initiative without knowing that it's important to your end users, without knowing what is evidence-based, without knowing what your starting point was so you can't measure if you improve, then it's very unlikely you will make a difference. So those 4 very simple steps, always starting with what's important to all those around you, is the recipe to make a difference. And there are many publications around this. Indeed, our group are now one of the leaders in learning health systems, and we're working with Qatar, New Zealand, the US, the UK, and Canada around implementing these systems in diabetes. But the principles are simple. So what is the problem you're trying to address? Are you trying to provide better integrated care for patients in your area, or even your region, or your country, or your practice even? What is it from those stakeholders that they would need and want, not one-on-one, but from a more collective group of people? And therefore, we need the advice of that patients and community involvement so that we all know this is the problem we're working on. Once you understand the problem and make sure you've got all the stakeholders, you can then set priorities around what you're going to tackle next. Critical to use evidence. Most quality improvement initiatives around the world are run by accreditation or quality improvement people, and they do not necessarily use best practice evidence. But there's really good evidence about what works, so really good to use evidence first. But in India, the evidence may have been produced somewhere else and may not work for you. So you will need to adapt that intervention to the culture, to the context, and to the system. The third one is evidence from practice. What are you trying to improve that's met the priorities of your stakeholders, that is evidence-based, and how are you going to measure it? Because you're going to need to start with that measurement when you start. And then finally, when you drive your change, putting in digital education to enhance your healthcare, integrating other aspects of healthcare into a one-stop shop, integrating artificial intelligence, whatever it is, make sure you measure it to start with and make sure you measure it as you go along so you know you are improving and driving change. If you measure it, you can also show that it works not only in your own practice, but you then become a benchmark for a quality practice or health service that can teach others and bring others on the journey on how they can improve. It's also a lot easier to get funding from other agencies, including government, if you show that you use a system that actually drives improvement and you can measure it. So we've done this now in diabetes, in stroke, in cancer. We've done it in gender equality initiatives, in community involvement, and improving access in remote regions. It doesn't matter what you apply this very simple metrics to, it works. So just finally, I'll give you a bit of an idea of a case study. This is the Monash Health Diabetes Service, where I was the director for about 10 years and he recently stepped down. It has 8 hospitals. The big brown one at the top there is Australia's first dedicated heart hospital, which is only for cardiovascular disease. 65% of those patients in there have diabetes. It has a large quaternary hospital, a children's hospital, an aged care hospital, a mental health care hospital, and multiple other large community hospitals. And it's the largest health service in Australia. We provide, probably small for what it is in India, we provide about 50,000 episodes of care directly in diabetes each year, and that's from pregnancy to paediatrics to adolescents to adults to older age. And the most important thing is, whilst we provide those directly, we support care for hundreds of thousands, if not more than that, in the community without directly providing that. And so to work out what our model of care was going to be, because we had 18-month waiting lists to come and see us, and care should not be based in a hospital if you have diabetes, is that we got everyone together and identified our problems: delayed diagnosis, poor prevention, significant diabetes burden. That squiggly line I showed you before, very complex services for our patients to penetrate, very poor integration, wasn't really focused on what the patients needed. And so we got everybody together, set up partnerships, and aimed for the priority that we all put together, which was to have much better integrated care. We pulled out the best evidence of integrated care in models that hopefully would mean that in our hospitals we would see as few people as possible. So our objective was we would succeed if we had as fewer admissions as possible. Doesn't work in a private system, but this is a public system, because they were being well cared for in the community. The next level down was our chronic disease management clinics, and again the aim was for us to only see the bare minimum. Then we had support services where either community endocrinologists or diabetologists or general practitioners or physicians could refer someone in for intensive short-term management. We only saw them twice. We were never allowed to see them more than twice. We got them back on track and sent them out again. And then the other ones were supporting care in the community and then educating other care providers and then educating our community. And by structuring it like that, with clear measurable targets on what we wanted to achieve, we were able to transform the whole service. But we measured everything first, looked at how our patient journeys, our integrated care, our admissions, our wait times, our numbers in all those different levels, adapted it for our context, and then actually put it into practice. We made sure we had primary care data, hospital data, and government data, and we kept continually looking at what we were doing. We set up new models of care, we partnered with all the different agencies, we set up networks, very focused on supporting care for diabetes in the community and linking them into the support whenever we needed it. We had community-based models of care, very limited tertiary care, and we did have some acute services expansion because our population was increasing. Australia has 40% of its current population are immigrants. In my particular area, 65% of people who attend our health services were born overseas. So first generation Australians, and the majority of those come from India and South Asia. So we have a not dissimilar population in many situations to many of you. In doing that, in taking that approach round and around and around that cycle of improvement, we have managed to show a very significant improvement in models of care. And it wasn't about which drug we were choosing, and it wasn't about what was new in obesity management. It was about taking a much better systems approach so that our private practice endocrinologists could link into our services if they really needed them, so that we were only doing the work we needed to do and we were supporting everybody else, including our patients, to have what they needed. So we made sure that the outcomes were co-designed, we did it in partnership, we improved both public health and primary care programs. It's actually much more than 30,000 now, it's up to about 40 to 50,000 directly, but much broader a reach in the other services that we now put out there. And we have less use of acute services. In fact, the patients that come in with diabetic ketoacidosis now or hyperosmolar coma are either new diagnoses or they're recurrent offenders where there are social issues. They're homeless, they have mental health challenges, they don't have a job, there are other issues. And in fact, now the current model of care that we're establishing is in collaboration with Canada and the UK, and is based on social prescribing to support those who just cannot manage their diabetes. So I'm going to leave it there, and Sanjay and I will have a discussion with all of you. But what I was trying to encourage you to do is not just see your practice or your health service or your patients or yourselves in isolation. Unfortunately, as doctors, we are trained for patient-doctor one-on-one interaction, and we don't always think about or understand the system and the service in which we work. It doesn't take long to spend a bit of time understanding that, and it will, in the end, give you much better care and much better practices. Thank you.
Thank you, Dr. Helena. And you've put things in perspective for us. So yesterday we learned about various aspects of diabetes. Today we've talked about our practice in the morning, how to set up a practice. But now suddenly we are thinking beyond the box, beyond our practice, and we are thinking about the community, the country that we serve. Any questions, any thoughts coming to your mind, any comments? Any butterfly thoughts? So what does the systems approach mean to you? Professor Hamid, any thoughts coming to your mind? When you work in your institute, do you work in isolation? Are you dependent upon other people? Are you independent of everyone? Or are you interdependent with others?
So this is very important from our own perspective. If you talk about the management of diabetes in India, uh, the current scenario is that everyone is independent of each other. We don't talk with each other. We don't have, a two-way communication with each other. We being a government set up a tertiary care center do get a lot of patients from referrals from those doctors who know us personally. They are sending that with that, but we don't have any system in place. Because if you talk about management of diabetes, then definitely a large number of patients, they can be managed at the primary care level very well with minimal training of the doctors and the paramedical staff. They can be managed very well wherever they are. But a certain subset of patients, they do need specialized care. When to refer, whom to refer, where to refer. And as ma'am has already talked about data, another thing which we lack in our country, we don't have an organized kind of data. So definitely, if we look at the management of diabetes from a country level, then definitely we need to do a lot of new things. We need to have some kind of command where we can have from state level, central level to the PSC level, that is our primary health care center. So definitely, I think if we will be organized, then the outcomes will be much more in a better way. So that's what I want to add.
Thank you. So we need to focus on data and we need two-way communication between all the various levels, primary, secondary, tertiary. Professor Maski is from Nepal and he's a member of the executive committee of the International Society of Endocrinology.
Hello, Dr. Elena and Sanjay Kala sir. So I'm Dr. Kala has already told me. So in BP catches, what we are doing for diabetes care is like we are focusing on student, MBBS student. So we have made a wing, student wing for. We are told them to write a motivation letter. We have started with diabetes food care team because that is neglected and in the Nepal. So we started with that. So students have written motivation letter and we have got 100 of applications. So we will be selecting 20 out of them. So we have to target from the student level, MBBS level. So not only teaching them and not only giving a lecture to them. So we have to make them a team and they will help us in every aspect. So whether we are conducting conference, whether we're doing a community outreach program. So we are doing on that. So within 2 or 3 months, we'll be starting that. So we have to focus on the course and curriculum of any medical college should have that. I think we have to start from that and definitely we have to have a government support and system whatever the Dr. Helena and you have told. So this is my comment and feedback on that which we are doing in Nepal.
So
Thank you.
that's a nice take on leadership. So as a leader, you engage the medical students, let them work
Yeah,
in diabetes care prevention, and also they become leaders for tomorrow.
yeah.
Dr. Helena, I have a question. You used these simple words, co-design, work together, interact with each other. How do you get two alpha men or two alpha women together at the same table and ensure that they do not fight with each other or fight against each other? They fight together against diabetes. How do you do that? And I see smiles from many alpha men in the and from some of the alpha ladies as well. Thank you for your smile. It's a beautiful smile, Dr. Meenal.
It's an important question, but it's not that much of a secret answer. So again, in medicine, we are trained very much one-on-one. We think we're very intelligent. We work very hard. We see our patients. We have a problem in front of us and we fix it. And we generally do it usually by ourselves with the help of a few other people. Our training does not really train us to do things as a team or collectively. And as I said, I had the opportunity to do an MBA early in my career, and it really made me realize that leadership is a recipe, and that if you follow it reasonably structured, you'll be okay. I don't think it's so much alpha males or alpha females. I think it's any group of practitioners from any background or stakeholders coming together for the same reason. When everybody is in the room focused on themselves, their practice versus my region versus their region, I'm a diabetes nurse versus, in fact, the worst ones I've had to work with are obstetricians and midwives because they fight over the fundamental territory of who should be delivering a child. And that's really challenging. But in For many decades now, the way I bring people together is largely around making sure we're there for the right reason, which is the patient story. So that's not our patient, that is a patient journey or a patient representative or a lived experience. If you have, we start every meeting with a patient story, not necessarily tragedy, sometimes a really good patient story, but putting everyone in the room around the table to make sure we all know why we're there.
Yeah.
People are still going to have their vested interests, but patient stories are really important. The other thing is accountability and transparency. People need to be in a room collectively when decisions are made so they can influence that decision. But when they walk out, they know it's a collective decision, which means you need governance, you need committees in terms of reference, you need process. It's not bureaucracy, it can be very efficient. In fact, I'm in the middle of leading one of the toughest things I've probably ever done, which is we are changing the name of polycystic ovary syndrome because it's not an ovarian disease, it has a male phenotype and it's not just about ovaries. Get everyone together for that was incredibly difficult, but we managed to get everybody together and are going through a formal process to do that. So it can be done, politics can be overcome if you have all the stakeholders in the room, you break down the power barriers, you make sure the patients and their outcomes are at the centre, and you use governance and process and transparency to get there.
Thank you, Dr. Helena. So process is accountability, but keep the person with diabetes at the center and make sure you repeat that again and again. And I was just discussing with Dr. Hamid, we are now working on a risk stratification tool for patients living with diabetes and chronic kidney disease for Ramadan fasting. And how do you get different people together? You just remind them, who are we doing it for? Not for ourselves, but for the person living with diabetes. And once you keep on repeating that, which is the truth, automatically everyone aligns. Dr. Helena, before we conclude, any questions, any comments for the audience?
Only one, just to encourage you to think bigger than yourselves and your practice and your immediate region, because almost always someone else has tried to do what you've done. They may have failed, they may have succeeded, but you can learn from them. We just finished our Ramadan policy for our health services. I'm sure there are many, many more, and looking at those and then seeing how you need to adapt them might be an easy way, for example, or us looking at yours. So you don't have to do it alone, and the best thing about learning from others is you don't make the mistakes that they've made before.
So we work together. Thank you. Now, the funny thing is I come from Punjab, from Haryana. So when we talk of butterfly in Punjabi literature, our songs go like, you know, why don't you be a butterfly? Let's go together to the farm. And it's very naughty, romantic kind of thing. But suddenly when you come to Ahmedabad, your hormones change. And now the butterfly effect for all of us means that we all, when we go back, we become leaders in our countries, in our states, in our cities. And we lead together with each other. And the final aim, just remember, that is health of the person living with diabetes. Thank you and Jai Hind.
Thank you so much, Dr. Sanjay sir and Dr. Helena ma'am. So one thing was made very clear and very interesting, that it is not we who are important, it is we all are here for the patient. So what we expect from our clinics is not important. What is more important is what our patients expect from our clinics. So it said that before opinioning about somebody or making an opinion about somebody, walk a mile in their shoe, right? So walk a mile in their shoe has two benefits. One, you are already a mile away from the patient and he already has his shoes. So he can't chase you. Fine. With that, we move on to the interesting case sessions, case reports, and we will have none other. We'll have Dr. Atul Kalhan with us and we will have Dr. Mayur Agarwal. Dr. Atul Kalhan is FRCP, MD Cardiff University, MD MRCP. He's a consultant diabetes and endocrinology from Royal Glamorgan Hospital, Wales, visiting professor of South Wales, honorary consultant endocrinologist, University of Wales, Cardiff, course director for postgraduate diploma MSc endocrinology in the University of South Wales, regional advisor, Royal College of Physicians, Edinburgh, certificate, he has done a CCST, MD Cardiff, he has prizes at the European Neuroendocrine Tumor Society. So it's a lot more for you. I can go on reading this, but I invite you here and to join Dr. Kalhan. We have Dr. Mayur Agarwal from Bhopal. He's MBBS, MD, DM, endocrinology. First position, rank holder, gold medalist, all accolades to Mayur. So Mayur and Dr. Atul, the stage is yours.
So, good morning. Good morning, Ahmedabad. It's a beautiful city, nice riverfront. I went for a run this morning feeling totally rejuvenated. To begin with, how many of you were in the session yesterday? Because it's going to be a revision. How many attended the sessions yesterday? Brilliant. So, when me and Mayur were given this clinical scenario revisiting, we had two options. Either go very complex, and I had a list of things, mitochondrial diabetes or insulin resistance, which is not improving, lipodystrophy, or keep it very simple. In clinical practice, 99% of the things are ordinary, simple. If you're thinking of rare diagnosis, you are rarely right. It doesn't mean that you don't need to be aware of it. So we decided mutually that we'll keep it very simple. It will be a recap of what we went through yesterday, and then we'll let you interact. I did ask you questions yesterday to write down the answer. I didn't give you the answer because I wanted you to find it out. So without saying much, this is the beautiful Ahmedabad pictures. On top right corner is Brecon Beacons, which is not very far from where I live. Occasionally, when I'm in an adventurous spirit, I go for a trekking over there. It's a beautiful place with no noise pollution and clear skies. So similar to what we did yesterday, there is a clinical scenario. I'll let you read it. Based on what we went through yesterday, I want you to give answers. As I said, diabetes is a huge burden. Dr. Teed mentioned about, Prof. Teed mentioned about it's going to be 1 in 10 adult individuals having this, and probably more common in Southeast Asia. So rather than making things complex, we need to remember very simple, basic principles related to its management. So a 47-year-old, should I call 47 old? I'll say it's 47-year young patient comes in. My definition of old is somebody older than me. So 47 is young, right? Type 2 diabetes, which was diagnosed 6 months ago, needs to be on metformin. Most of the guidelines say metformin, data supporting metformin use from UKPDS. If I compare it to the robustness of their data for CVD protection with metformin, I'll say based on the time and everything, it was good enough. We are not going to change metformin's position as the first line therapy. It's economical, it's time tested. Complaining of osmotic symptoms, BMI of 30, blood pressure of 150 by 90 millimeter of mercury. So these are the investigation results. Anything which stands out? Do you think the control is optimum? Triglycerides are high. LDL cholesterol is high. So happy with the scenario? Had I given you a different option in which the BMI was normal, patient was younger, I would have asked you for type of diabetes. I could have asked you or tested you on, is it type 1, and I'll do the islet cell antibodies. You need to be aware of what is important in monogenic diabetes. What are the phenotypic features? I could have gone and asked about mitochondrial, in which there is a maternal kind of transmission, story of sensory neural deafness also running in generations, but I kept it simple. I could have asked you about C-peptide measurement, when to do it, how to interpret it, right? But we covered these topics yesterday, so coming on to it. I want a volunteer to come in now to help me out with this story, or couple of you. Target blood glucose, HbA1c. I've already individualized this patient. I've given you information, 47, fit enough, young enough. You tell me and we'll have a discussion about what should be the HbA1c target, how you want to control the blood pressure. Is there any difference in ambulatory blood pressure monitoring and home monitoring, or in the office monitoring, and your targets for LDL? It's very simple message, but I think what I've learned in 3 decades of practice is if you keep the thing simple, it's easy to interpret the results also. So let's stick to the basics. Anyone brave enough to tell me how? Yep, you want to? Yeah. On this unit wise, Mayur, you want to say anything? Yeah.
Yes. So almost close. See, again, we go back to the case, I would say. Just few more points I'll add here. So we have here, see the age, that is how you decide. So this is 47-year-old. Then whenever you see a patient, always reconfirm the diagnosis. Already we have made it very simple, type 2 diabetes, but you have to take into consideration other things also. And now we see all type of diabetes irrelevant of age. So type 1, all those young onset, all those things you need to see. Okay. Then this patient has some features of catabolism, so that you need to address. And very important, which we often forget in our clinical practice, is to ask about lifestyle modification. Whether the patient is actually following or not, whether the patient is following some dietary restriction or not, or whether the patient is eating sweets every day. Without that, kindly do not modify treatment very, very quickly. Okay. And then the compliance of the treatment, that also often we don't ask. And that is relevant for everything, whether you talk about diabetes, whether you talk about hypothyroidism, anything. So before chasing a target, please see whether the patient is compliant to treatment or not. That treatment includes lifestyle modification. So all those things are of practical importance. That is how we have created this. And sometimes considering this higher BMI, even if you reduce it, then the patient may respond to same medication. And as you have rightly said, the target would be somewhere less than 7%. And what the standard guideline says is fasting somewhere 80 to 130, PP somewhere 100 to 180 is good enough. If you can make it less than 6.5 without hypoglycemia, that is also considerable, no issues, provided the patient does not land up into hypoglycemia. So that way it is good enough. And for the BP, the targets with the recent guideline 2 years, this has been changed to 130 by 80. Okay. So that is regarding that.
Ram wants to say.
Whenever I see a patient with high blood sugar, my first question is, when did you take your last dose of OHA or insulin? That's very essential. And most of my patients, they'll say, I'm using medicines regularly, and they'll say, I stopped 4 days back. They think 4 days is not a big time, which is very crucial. Thank you.
Totally agree. So compliance is something which you should be asking, and then the lab test. See, ultimately you cannot say by seeing a patient, okay, his sugars are that. So the standard, what the patient has got the report. In India, this is again very, very important. Whether you're getting this HbA1c from an HPLC method or not, that is again an important thing. Whether these sugars were done just by glucometer, which may be inaccurate, maybe he's using an expired strip, something like that happens. This is common in clinical practice. So all those things you have to keep in mind before prescribing anything. Just don't keep on seeing the report and change the medication. What is important is to treat the patient, not the report. Just remember this line. You have to evaluate the patient in toto. You cannot just treat a report, whichever he is bringing, right?
So I'll add on something interesting here, and thanks Mayur for reminding me. When I teach my specialty trainees or registrars in diabetes and endocrine, and especially coming from an era in which I took up the training 20 years ago, I usually considered diabetes as a boring condition because I thought, as compared to endocrine, the challenges for diagnosis are not as much. Now, if I share some stories with you, oldest patient with type 1 under my care at the time of diagnosis was mid 70s. Anti-GAD antibodies strongly positive in a 75-year-old. Nothing will prevent autoimmune disease to happen second time in life. I've got Graves thyrotoxicosis patient presenting in their 70s and 80s also. In fact, my mom has Graves disease, which I diagnosed 3 or 4 years ago. So autoimmune disease have two peaks, one early in life. There is another resurgence later in life also, after age of 70. Just be mindful. Another important thing, latent autoimmune diabetes of adulthood, LEDA. Normally, if you go by the classic book definition, 30 to 50 age group, normal BMI. My question here is, what prevents an autoimmune disease to happen in a patient with increased BMI? Nothing. People with normal BMI or increased BMI are at equal risk of developing an autoimmune disease. So just because a phenotype suggests type 2, yes, you are likely to be right if everything else correlates. But if the patient has history of primary hypothyroidism, celiac disease, SLE, rheumatoid, something else, please think out of the box, right? So a very simple message.
Yeah.
And last thing, sorry, endocrine conditions. Occasionally, I've seen Cushing's presenting with high blood glucose, but there are other telltale signs there. And acromegaly once every 1 or 2 years.
Yeah, so there are now newer concept of dual diabetes. Somebody who is having type 1 diabetes, but now getting obesity also, right? So it's like both the pathophysiologies are going together. Okay. Similarly, we have something called digenic body also. Somewhere two gene mutation, two allele mutation, which itself would have not caused MODY, but then two of them are causing that. So now the diagnosis is totally different and you have to evaluate in toto and accordingly, that is what we are talking about the precision medicine.
So he's saying that he will probably go for insulin initiation. I think it will be
From
clear.
Nepal. So since we have to see I always follow the RSD therapeutic wheel, A, B, C, D, E, F, G, H. So F means financial status of the patient. So in India and Nepal and every country, I have seen the financial status. So because in Western countries also, insurance is very important. So in this patient, since if he is from Nepal or Southeast Asia, first you have to see the cost. So if he is affording, we can go ahead with GLP-1 agonist. If he is not affording, but this patient has catabolic symptoms, insulin is the best therapy. Later on, to reduce his BMI, SGLT2 is the best, and we have to decrease his weight, lifestyle, along with the lifestyle, stress relieving, sleep habits relieving, mental status, everything has to be there. And along with that, if affording, the GLP-1 agonist should be there. Thank you.
So again, a bit of revision from what we discussed yesterday. What will you do if he starts to develop diabetic nephropathy? Is your medication regime going to change? Are you going to stop metformin, SGLT2 inhibitors? Think about Finrinon. Yeah. Any volunteer for it? Yeah, Dr. Ram coming to rescue.
If Pheneronon is useful, we tried in some patients, but we added to SGLT2 and we got some good results.
So SGLT2 remain the treatment option. You can use Finrinon. You have to be careful about monitoring the potassium. You need to make sure EGFR is more than 25 to begin with and monitor potassium after starting it also. Remember, we are dealing with lives here. And some of the most traumatic things you go through is if things go wrong in clinical practice. I've seen somebody develop liver failure with PTU, propyl thiouracil. It will haunt me forever, although it's extremely uncommon. So similarly, if you're giving Finrinon and potassium you're not monitoring it, a high potassium can lead to arrhythmias and sudden deaths. You don't want to end up with things which are more complicated. So Fantastic.
I want to ask you if the patients see that creatinine is going up, I think we have to add some other drug in addition to SGL2 because SGLT2s won't work if the creatinine is high or that
So the
EGFR.
yeah, the only single point you need to remember, SGLT2's efficacy as glucose lowering medication
Yes.
reduces as the
The
EGFR goes down, right? The efficacy as the non-glycemic benefits continue. So there are two aspects for glycemic improvement. In renal failure, my first choice, I'm talking about CKD stage 4 and end stage, is insulin. The insulin is metabolized in the kidneys, it stays longer, and these patients are vulnerable to hypos. I'm very careful about using sulfonylureas. I'm very, very careful. I'm not, you can kill a person with hypoglycemia.
Yeah, just to add for the all the delegates here, whenever you see a patient in India, what we have in reports is just the creatinine. Please don't go with that. You have to calculate eGFR. So kindly make note that you have to calculate eGFR. Most of the reports will not be showing it. One important message from today's is calculate eGFR. If you see the trials, see, if eGFR is beyond 20, above 20, you can use AMPA. Above 25, you can use both AMPA and DAPA. So we have trials for DAPA up to 25 and up to 20 we have for AMPA. That thing is to be noted. Then whenever you start an SGLT2 inhibitor, irrespective of your HbA1c, irrespective of your glycemic control, if the patient has a low eGFR, you have to initiate an SGLT2 inhibitor, and that is not because we want his sugars to be controlled. When I'm saying irrespective, that means let's say a patient had an HbA1c of say 6.5, that is what you're targeting. Still you have to add because you are not adding this drug for the glycemic control. In fact, when the eGFR goes below 30, the drug is not acting much as an anti-hyperglycemic drug. We are using the cardio and the renal benefit of this drug. Okay, so that's an important consideration. And then another very important concept to be discussed is because this drug decreases the intraglmerular pressure, this will lead to a fall of eGFR at whenever you start, right? So let's say you have started at 20, the eGFR may fall by 5 further and the patient can have a further worsening of creatinine. Your eGFR would be dropped to 20 to 15, something like that. Kindly do not discontinue. That's the starting point. It's not for discontinuing. If the patient is already on that drug, you have to continue. And there are data that definitely there would be a drop in eGFR. That means there would be worsening at the beginning, but in the long run, it would be beneficial for the patient. So that thing also you have to keep in mind because these patients, whenever you say that, okay, your kidney is not working properly, that is why we are starting, probably the patient would get an again creatinine after a week or so, and that would be worsened. So do not get afraid of it. That's a normal course, but in the long run, the patient would be beneficial.
So another important point is how do you assess somebody's insulinopenic? There isn't anyone wants to shed some light on it. So, pardon? Fasting, postprandial, HbA1c test different aspect of glycemic control. Fasting, postprandial is normally the first one to go. Fasting more related with the glucagon and gluconeogenesis, and HbA1c is just the average kind of. With CGM, we are learning a lot. What used to be defined as abnormal is within the remit of normal also now with continuous glucose monitoring. So, anything else apart from fasting? So let's, pardon? Symptoms are important, osmotic symptoms. So if they are waking up multiple times in night to week or feeling thirsty all the time, anyone else? So the key thing you have to remember that type 2 diabetes patients may run out of their insulin store as the life progresses also. So if the glycemic control remains suboptimal, people are losing weight, muscle mass, it is a catabolic kind of state, right? So that again is a clue that people may be insulinopenic. So anyone for metabolic dysfunction associated liver disease?
Just to add, whenever you talk about insulinopenia, the first thing which I was looking for the answer is look for the signs of insulin resistance, which nobody mentioned. If you have a patient obese, BMI high, acanthosis nigricans, skin tag, probably patient have more of insulin resistance and is not insulinopenic. That is something you have to see. We see patients like 12-year-old or 15-year-old having type 2 diabetes, right? Earlier the concept was if you're seeing a patient say 12 or 18 years earlier than that with diabetes, probably it is type 1. But now the concepts are totally changing. Somebody at 55 years can have type 1 diabetes. Somebody at 12 years can have type 2 diabetes. Though we don't have much drug, only two of the drugs are approved. That is metformin and recently the empagliflozin, which is approved at 13 years later. So these things you have to see, right? And firstly, as already told, see, treat the patient. You just the basic thing: history, examination, followed by investigation. So history, features of catabolism, probably the patient have insulinopenia. Then examination, signs of insulin resistance, acanthosis, skin tag, BMI, all those things are important. And then followed by investigation. That is your C-peptide. But again, there are fallacies, right? If you get it at very high sugars, probably the C-peptide can be rock bottom. And maybe later on with controlled diabetes, the C-peptide can be again normal. So every report has some fallacies. Every test have coefficient of variation. The same test repeated again can vary results, right? So all those things you have to keep in mind to come to arrive to a diagnosis.
So as we've got only 2 minutes left, I'll run through some of the slides here. These are the glycemic goal individualized target. That's for a fit, healthy individual. I showed you this algorithm yesterday also. That's from Diabetes Care 2025 Jan. It's ADA criteria. You can go through it, endorsed by ESD also. Very useful. You can, there are details in there which will be helpful in clinical practice. These are the blood pressure targets again, and I think we are providing you with some kind of study material, so I'm not going to repeat things in here. CVD risk categories, we did cover them yesterday. We did mention that type 2 with end organ damage, anything is high risk or very high risk. And duration more than 10 years for diabetes, again, puts them in high risk. So most of our diabetes patients are at high risk to begin with. LDL target, we did cover yesterday again. I am not going to, go through the things. So the LDL targets need to be more stringent. If people are having recurrent events, you need to keep it under 1 millimole per liter, which is around 38.5. And think about doing LP little a and think about the genetics of it also.
Any question from the audience? Also, I'll just move on to the last slide. Just to add a point, kindly take a picture of this because this is something important. Most of the reports, whatever you see for LDL, the normal value would be written as less than 100. But that less than 100 is for non-diabetic normal patient, normal person, right? So whenever our patient, the diabetic patient comes, that is not normal for him. The normal values is this. Okay, that is what you are targeting. This is what you want. Not that less than 100. That is for population. That is not for a diabetic. So that is important to tell your patient. Because once you increase the dose, probably somebody else would say that this report is normal, your LDL comes 90, do not increase. So that you need to address, that you need to tell your patient.
Okay, thank you.
So thank you, Dr. Mayur and Dr. Atul. And that was really wonderful taking us through one simple case, but teaching us the basic take-home message that every patient of diabetes needs individualization. Be it cholesterol value, be it sugar value, be it blood pressure value, the BMI, the age factors, every patient needs to be individualized. So with that, we come to the wrapping up of the DASG session. I invite Dr. Amit, and interestingly, Dr. Bansi is also here. So Dr. Amit, can you wrap up the session and give us a message for next phase of the DASG?
Thank you, Dr. Meenal. I think we have a full house of DSG school, and it has been a wonderful teaching for last 2 days. So before I wrap up, I would like to invite all the faculties on the stage for this final concluding remark. Dr. Mayur is there, Dr. Atul is there, Dr. Meenal there. Dr. Shashank sir, please, Dr. Bansi sir, you can also come here so that we can have concluding remarks and give the, and we can take some feedbacks also, some of, few feedbacks from the international participants, and then a couple of feedbacks from the national participants also.
So one, what we are thinking of doing a online diabetes Asia school to get the doctors from all across the Asia. So yesterday I was talking to Atul that it may not be possible every time, and this one is school of a physical which we can always do with along with our national congress or with our international congress of diabetes Asia once in a year, but definitely would like to have one online program that can be once in a year. And this cannot be only for 2 days, it may be for a month time. So every alternate day there can be a fixed time, 1.5 hour, which can, because the countries, different countries have a different time zone. This is in Asia, so we want to include the people from Philippines or Far East to all Middle East and up to Jordan or North Africa. So that's what we are looking for, so a convenient time, and then again it should be convenient to Atul, who will be joining from UK. So that is what we are thinking of doing, even online program. We will also like to have few more faculties from other Asian countries also, because there is some regional variation in managing, and there may be some other guidelines too. Then which book and all those things we will be discussing. But one, I would like to ask the faculty one, their experience too. But those top 10 students I would like to felicitate them with Sadiko textbook of diabetes. So that you have to find out those top 10 students and just ask them to be present in inauguration session. We would like to give them a Sadiko textbook of diabetes. So as we choose always the best teacher, we always try to choose the best student also. So the best teacher always we choose. So whatever you decide, it can be on your 2 days experience with those people who are good or in any way, but all of you will be getting, those who are registered for this school, there will be a dedicated certificate by Diabetes Asia along with Diabetes India as an organizing partner, and with all the faculty members' name, and that will be written to you. You will get that school certificate, and we will see that how we can engage you continuously in next 10 months or 12 months till we do our next meeting. So that's our plan, but definitely I will request them to choose the top 10 students, and all of you will get a dedicated separate certificate, those who are registered directly from our event RX event. Thank you.
Vanshi, you put me on a spot. All of you who attended the session and are still awake deserve a prize. This is what I say. Human attention span is 6 minutes. I was a very lazy student, used to be a backbencher. There were lots of proxies in our medical school, Maulana Azad, I remember. So somehow I managed to clear all the professionals, probably got a bit better, and in NHS I've got no option apart from, Saraswati Puja. So, any, raise hands who like to have this book? Fastest fingers, yeah, all, please come forward.
No, those who should be registered.
Yeah. Fastest fingers first. Yeah. Anyone from overseas who would prefer to have this book? Overseas guests? Atithi Devo Bhava. So,
Nepal. Nepal gets really happy. Uganda.
Please come in. Our overseas guests will get the preference.
No, they always get by all.
So can we have some feedbacks also? So please raise your hand for the feedbacks. Please come forward, and you can come on the mic and. Yes, so we have DASG school attended from the Jordan, Maldives, Nepal, Bangladesh. So meanwhile, may I request you to share your feedback?
Thank you very much for inviting us to this conference and giving us this opportunity to be part of it. From the modules, actually, we have very young doctors who have come to attend, but we work very closely with diabetes patients with an NGO, Diabetes Society of Maldives. So all the information that we have gotten has been very essential for our treatment of the patients. So thank you very much for this opportunity.
See, what I liked most about this school was that continuous interactive lectures, which made us possible to learn about diabetes and day-to-day, even like a basic topic like diabetes care clinic, how to set it up. So it was really a wonderful experience for me, which I'll try to inculcate in my personal life. Plus, I'll teach our colleagues in Oman about this.
Thank you, Vahid, for your feedback. Any comments?
I'm from Uzbekistan and I'm participating for the first time. And it's a very amazing conference and I'm very proud to participate in it. And I like that you are sharing your experience and your knowledge to all of us. Thanks a lot.
Sir, I am out of DASG school, but I enjoyed it and I learned a lot of things, particularly from case discussions from Atul and Mayur. Thank you very much. It was interesting, even for old people. Thank you.
Format. It is there in your that, and you can interact directly to your faculty. Should I give in that, USB drive, all your mail IDs are also given. So you can interact with your faculty. With this, I close from my side, but they can continue whatever because I have to go to the.
So, sir, I would just like to make an announcement. So we have distributed these 10 books randomly, but Sadiko textbook is really a gem to have in your library. So it is available for sale on Amazon also, and it is also available in the JP stall. So those who want to have the book, they can buy the book also. So it is available in the JP publisher's stall. So with this, any comments from the faculty? Mayur, would you like to say something? Dr. Meenal?
So I think this was one of the best part of the conference because it's an structured program. And here you had an experience from how we do it, what not to miss in diabetic patient, how to go about the evaluation, right from the basic of the definition of diabetes to the best of best, the recent treatment, the insulin pump, the GLP-1, everything was discussed in great detail. And the best part is it was interactive. You could ask your question. Everything is available online, but the reliability of the data, how we do it in practice, that is what is missing. And for that only we have created this program. Thank you for attending this.
And many of the faculties, they are not here, like Dr. Helena Teed, Dr. Sanjay Kalara, Dr. Inge, they also had taken some wonderful sessions. Dr. Meenal, any comments?
First of all, I must congratulate the very concept, the conceptualization of the idea of DASG was wonderful. So Dr. Amit, Dr. Bansi, Dr. Atul, it's really a good, wonderful concept. And with this house full, I can congratulate all the learners here available, the keen interest in learning about diabetes management. So it was a wonderful beginning. And the next time, whenever we plan, we can have a still better improved structuring of it. Maybe we can go case-wise, as one of us asked that individualizing type 1 care or GDM care or pregnancy diabetes, we can have different case studies also. So that was really wonderful. Thank you so much.
So, before I close, I would just like to mention that please remain in touch with your faculty members. If you have any doubts, any queries, if you want to learn more, get more material, please feel free to reach out to them. It is a constant journey. Learning is a continuous process, so it doesn't end here. So it is a beginning, and we look forward to have a long-term association with all of you. So be in, and also get connected with Diabetes India so that you get all the information in time, and enjoy next 2.5 days of conference. And you are most welcome to attend all the sessions. I know. So I request all of you to join the inauguration after this, and then you can enjoy the rest of the meeting for the next 2.5 days. So thank you very much. Thank you everyone for your attendance.
Check, check, check. ये तो आवाज आएगा ही इससे तो आता चेक 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 इससे नहीं आता कौनती वाली
एक मॉडल बन सकते
बरोबर आहे का एकदा फॉर्म घे
संतोष संतोष चेक चेक हेलो चेक हेलो चेक चेक हेलो चेक नंदन चेक चेक एक मिनट म्यूट म्यूट कर इसको
Good afternoon, everyone. We shall begin the session. We have Dr. A.K. Azad Khan, sir. He's the founder, General Secretary for Asia Network for Research on Anti-Diabetic Plants, a chairman, and from Bangladesh University of Health Science. Sir, please can I have you here?
Program. I think we should start. I think. I will stand up. I feel greatly privileged to chair a session by Vishwanathan Mohan. I don't think Mohan needs any introduction to any audience, not only here, but all over the world in the field of diabetes, and to many countries in the field of medical sciences. But anyhow, it is customary to say something about you. And Mohan, as you know, he is Padma Shri awardee. I will just select out. And he is the founder of the Mohan Diabetes Specialist Center, not only in Chennai, all over the country. He showed the way how it can be done. I dare say, Mohan, that we started this before you in Bangladesh. And he had many words, many awards. I will specially mention B.C. Rai Award, because Bidhan Chandra Rai was a Bengali, was a great Bengali. Yes. And I'm from Bangladesh, I'm from Bengal. So that's why I'm very selective. He received Harold Ripkin Award, many awards, you see, and published over 1,730 papers, which I wonder when he gets so much time to write those papers. And he had presented many orations, many papers, and he is fond of writing. He can't sit idle. He writes not only in medicine, but many aspects of medicine, like history, and make them really interesting reading. Professor Mohan, glory yours.
Thank you, Professor Azad Khan. It's a great honor that you are chairing this session and that this is a DASG session, of which we are two people who have been long in this field. I'd like to thank the organizers for inviting me to present. So I'm going to talk about a subject called as early gestational diabetes. And we'll talk about what that early is. I have no conflict of interest to declare. There are two major studies which I'll be talking about. One is a STRIDE study, which is funded by the UK and the Department of Biotechnology in India. And the other is a Tobogum study from Australia, for which we had no funding at all, but we are part of it. So getting straight into the subject, what is early GDM and why is this term early GDM used? Gestational diabetes for many years was considered a type of diabetes which comes during pregnancy. It's actually, the strict definition is first diagnosed during pregnancy. That could also include people who did not know that they had diabetes when they became pregnant. But strictly speaking, gestational diabetes is something which comes due to the gestation. And therefore, it was believed that the baby has to grow, and therefore only in the second or the third trimester they develop diabetes. And therefore, most of the international organizations today, including the Indian organizations, suggest the screening for GDM between 24 to 28 weeks of pregnancy. However, more recently, there has been evidence that gestational diabetes can actually occur in the first trimester of pregnancy itself, and that is why we call this as early GDM. So if you call this as early GDM, then what would you call the one which you use to diagnose? Obviously, late GDM, isn't it? So therefore, based on the type of the gestational diabetes, based on the timing of the gestation, you can have early GDM, and for convenience, we have called it as less than 20 weeks of gestation. There's no strict rule for that because in the toboggan study we use 20 weeks, and therefore before 20 weeks, if a woman who's pregnant is diagnosed to have diabetes, which is occurring for the first time, we call it as early GDM, and if it occurs later, 20 to 28 weeks, we call it as late GDM. So you have the early GDM and the late GDM. How do you diagnose early GDM? That's a good question because we still don't have the answer to that. Many years ago, in 2010, based on the HAPO study, the International Association for Diabetes Pregnancy Study Group, the IADPSG for short, they came up with a definition that if the fasting plasma glucose of a lady during pregnancy is between 92 to 125, that can be called as early GDM during the first trimester of pregnancy. Now, the 125 you can understand because 126 become diabetes. The fasting blood sugar of 126 is diabetes. So then that's diabetes complicating pregnancy or diabetes in pregnancy. But where this 92 came from is actually from the HAPO study where they had used the 1.75 cut point to see the fetal outcomes, various fetal outcomes, and there the fasting came as 92. But the moment this was proposed, there was a lot of opposition. They said this 92 is too low because too many women will be diagnosed to have gestational diabetes. So they withdrew it. They withdrew it and they said, well, we don't know what is the diagnostic criteria. So this 92 always was debated. And I'll tell you later that it seems to be slightly higher, and I'll come to that later. Now, one of my PhD students, Hannah, when she joined for her PhD, we gave her this topic of early GDM and told her, you work on this. So the first thing a PhD student should do is to collect all the literature on the subject so that you know every paper published in the world. So that's what Hannah did in this paper we published in Acta Diabetologia, the systematic review of every paper published in the world on early GDM. I'm not going to go through everything. I'll show you one or two things. But what we found was that it's a total mess, as one would expect, because there's no diagnostic criteria. There is no treatment suggested. Nobody knows what it is. So everybody who had said early GDM, anybody who had diagnosed something in the first trimester called it as early GDM. So there were 58 studies which were included. And look at the prevalence rate of GDM. One study had said it's 0.7% of all pregnant women. Another study said it's 37%. So you can imagine the wide variation. If you look at risk factors, obvious risk factors came out, BMI and previous history of GDM, family history of diabetes, multiparity, etc. And there were studies which reported on birth outcomes, and just like the late GDM or what we earlier used to call the conventional GDM, there was macrosomia, cesarean delivery, shoulder dystocia, and so on. But there were some interesting points which came out. In the limited studies which are available, it looked as if this early GDM was a little more severe than the conventional or the late GDM because the need for insulin is higher. And when you looked at the conversion rates of those who later became diabetic, it looked as if the early GDM people seemed to convert more. But as I said, it was just a systematic review of published studies, and there were a lot of discrepancies in the data, but this is what it seemed to suggest. So it was very clear that a lot more work was needed on early GDM. Before Hannah had started her work on early GDM,
we've already started a study with the UK, and that is called as a STRIDE study. STRIDE stands for Indo-UK-Kenya study. So it's the 3 continents and 3 countries involved, India, UK, and Kenya. So Europe, India, or UK, India, and Africa were involved in that. STRIDE stands for Stratification of Risk in Early Pregnancy. Now, what is the aim of STRIDE? The aim of STRIDE, that time we didn't bother much about early GDM. We didn't know much about that. So we said, okay, women are going to get diabetes in the 2nd trimester. Why should we wait until then? Can we start looking at them in the 1st trimester and predict who is going to get in the 2nd trimester rather than get a shock, oh, you got in the 2nd trimester. Can we start looking? Can we look at their age or BMI or glucose or whatever, HbA1c or whatever, and say these are the women who will develop. So that is the whole aim, to develop a risk score. And indeed, we have developed a risk score to predict who will develop as a part of STRIDE. And STRIDE was a large study. Normally the GDM studies are 50, 100, 200. Here we had 3,000 women between the ages of 18 and 50. There were a lot of sites. I'm talking about the India sites now. So Chennai was obviously the center. And we had Sitapati Clinic where Dr. Uma Ram, our obstetrician, who also runs the EV Kalyani. Then to get women of different socioeconomic status, Uma Ram's clinic is a little higher income group. EV Kalyani is slightly lower. Andhra Mahila Sabha is even lower. VHS is even lower. So we had all the women from the lower to the middle to the higher socioeconomic status. Then we had Fernandez hospitals in Hyderabad, which is middle to upper class. And then we had JIPMA, which is the lowest, people from villages, the lower SCS. So it's a true representation of early middle class, lower middle class, and you can find the people there. That's Umaram in the green sari, and Saravanan Ponuswamy is there, and he was the leader of this particular study based in UK, and all my other team members, including Hannah, are shown there. So what we did was, we took these 3,000 women. Some of them did not come for proper follow-up and so on. They didn't enter into the study, so we had to exclude them, 300 of them. So we had 2,700 of them. So what we did was, since there's no other accepted criteria, we followed the IADPSG criteria itself. So we said, okay, let's do a fasting glucose and we'll do an A1C. Now when you did the fasting glucose, few of them, I don't know if this will work. Let's see. This one. No, it doesn't work. Okay. So a few of them had a fasting glucose above 126. So they are diabetic. Okay. So we excluded them. Interestingly, we had only 8 of them. So we excluded them. Then some had below 92. So they are normal. Then there were some between 92 to 125. Now that's early GDM. So we had this group of early GDM, about 566 women whom we could study. So it's one of the largest series of early GDM in the world literature actually. Then if you had fasting less than 92, they are normal. Now what do? We wait for 2nd trimester and then we do the GTT again. We again use the ADPSG criteria. Now 2 things can happen. They can still be normal and therefore they are normal. And then we had late GDM because they did not have early GDM. Now they have late GDM. Okay, so now we have 3 groups now: normal, early GDM, and late GDM. Now this gave us a chance to compare early GDM and late GDM in the same study. So if you look at this, it's just been being submitted for publication probably this week. So what we found was that if you look at the early GDM, forget about the normal women, look at the early GDM and the late GDM, you'll find that the BMI is slightly higher, the waist circumference is slightly higher, 89 and 87. The glucose level, fasting, is slightly higher. Look at the A1C, 0.1 higher. So this is not diabetes, because some of you will say, well, they're all diabetic. No, they're not. 5.3 is not diabetes, okay? But they are slightly higher, definitely higher than the normals, but also higher than the late GDM. And the glucose and the venous A1C, we also did point of care A1C in case we had to do it in rural areas later and so on. So it confirms that these early GDM women are slightly more severe in their glucose intolerance than the late GDM. Now we are able to look at the risk factors. Who are these women who develop this early GDM? Those who had higher BMI, those who had higher A1C, and those who had GDM earlier in a previous pregnancy, these were the risk factors. A series of papers of STRIDE are being written, but the first one was published last year in Lancet Diabetes. And here what we tried to do was, we set out with the question, how can we predict who will develop late GDM? That is the whole idea behind doing STRIDE. It turned out, and in the UK, they don't like to do GTT at all. They hate GTT. Okay, and the US, they completely hate GTT. In India, we have no problem. We can do GTTs, no problem. Women will come. But apparently the UK women won't come. We heard recently at the Gates Foundation meeting 2 weeks ago in Copenhagen that Swedish women will come, Danish women will come for any GTT, Indian women 100% they will come, but UK women will not come for GTT. So the first thing that Saran and Purnasamy wanted to do was to say, how many GTTs can we avoid? So it turned out that if you do the HbA1c, and the advantage of HbA1c, of course, you can do it at any time. You don't need fasting, you don't need anything, you can do it any time of the day. And you can do it with point of care, you can do it with lab, you can do it with anything. So it turned out from this paper, a very important paper, which says, okay, if you have HbA1c of 4.9 or below, they will not get GDM. So you don't need to screen them at all. So that way it's useful. If it's 5.4 and above, they almost certainly have GDM. So probably they don't need a GTT because they're already in the GDM range. So only those who are between 5 to 5.3, they need to go for a GTT. So they are very happy that 50% of all GTTs you could avoid. But just doing a non-random, non-fasting HbA1c helps them to eliminate. We also found out an equation here. In the paper, if you read it carefully, we have found out an equation. If you use HbA1c, age, something, 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 and do a formula, you can predict who will get GDM in the second trimester. So that is a major contribution of STRIDE, but many more papers are being written. But now let's come back to early GDM. Okay, so there is an entity called early GDM. Is it safe to treat these women? That's something we don't know. There's no proper randomized study has been done. You picked up these women. There is no study which has done looking at treating them or not treating them. How do you know that treating them is safe? Suppose you go and treat something, a new entity, and then you go and treat them and they do worse. Then you should not, you should have left them alone in the first place. So there were small studies which were very non-contributory and small sample size. So we had to do a proper randomized study to show that treating early GDM is safe and it is effective. So that study is called a Toboggan study. Toboggan stands for Treatment of Booking Gestational Diabetes Mellitus. So what we did was, in Australia and also in India, where we participated from Chennai, and then in Sweden and in Austria, we collected women, and this is published in the New England Journal of Medicine. I'm very happy that I was also part of this 2023 project. This is the first and major publication of the Toboggan study. Just to show you the Toboggan investigators, this is led by the famous David Simmons, who also did the HAPO study. And most of the centers are from Australia, but we have, and Helena Tade, who's here, you might have met her in the inaugural function. She also referred to the study. She is very much part of this. And then we have also Sweden, Austria, Vienna, and India participating in the study. So what we did was, we screened a large number of women in these various centers in the early part of gestation. And we did a GTT actually. We did the same IID-PhD criteria which we use in late pregnancy. And we identified 800 women who had early GDM. 800. Out of these 800, this is a randomized clinical trial, RCT. So 400 we treated, that's called as the intervention group. 400 we did not treat at all. Okay? So you may say, is it ethical? You found out that they have early GDM. Now we are not treating them. Well, there's no evidence that it's safe. There is no evidence that it is good. This is the first major study. If you have to do an RCT, you have to do it that way. You may say, how do you know that the physician will then start treating? We didn't tell the physician that they had these 400 women. We didn't tell them that they had these 400 women. We told the physicians. Those 400 women just went through as if they had nothing. The women didn't know. The physician didn't know. Nobody knew. So it is a proper controlled study. And then, of course, we had other groups normal women, just to compare. And we treated them like we treat GDM women anywhere. Okay? The good news was that by treating early GDM, there was a significant reduction in the bad outcomes, the composite primary outcomes, which included preterm birth, birth trauma, shoulder dystocia, neonatal deaths, even NICU admissions were reduced. So those who needed admission to the ICU, that was also reduced. And this was highly significant statistically. So the first part of it, that treatment is effective and beneficial, was established. What about, is it safe? There were no significant side effects. I'll come back to that. If you treat them too early, when they have that 92, 93, they actually, babies became small. So that is the only thing. Otherwise, there's no adverse effects. There were no, we looked at hypertension, neonatal body mass, all that was not different between the groups. Now we came back to this question. You remember I said that 92 was criticized as being too low. So we had pre-designed it that we will look at women, we'll treat everyone from 92 onwards, but when you analyze the results, we'll divide them into a high band glucose and a low band glucose. What is a low band glucose? That is 92 to 94. And then 95 to 109 is a high band. Similarly, in the 1 hour value and the 2 hour value, we had a lower cut point and a higher cut point. The question is it worth treating these milder women also, or is it better to treat those who are a little more severe? And the answer was very clear. If you had a high band, high glycemic band, you benefited the most. The ratio is 7.78. That means it is 7 times better than the women whom you don't treat. Now, those who are in the low band, it was 2.48 better. So it is obviously good, but it crossed the midline. So it didn't reach statistical significance. So if you look at, is there evidence that it is beneficial to treat the low band? No, it's not statistically significant. But if it's high band, yes, clearly so. Next question we asked was, we said 20 weeks. Now, some of the women had developed before 14 weeks itself, the GDM. Others had developed between 14 and 20 weeks. So we said, is there a difference between the two? And we found that if the women were diagnosed before 14 weeks, that means the earlier the women developed the GDM, they did much better. Of course, the others also benefited 5 times better, but it touched the line. So it didn't reach statistical significance. So 2 messages came out very clear from the main findings of the NEGM paper. For the first time in the world, we have evidence that treating early GDM is beneficial. There are no side effects. And the more severe you have, the better the results. The earlier the women get it, the better the results. So these were the primary findings. But toboggan gave us an opportunity to do many, many more things. The first question which any government will ask or anybody will ask is, we already have so many late GDM women now. Now we are adding early GDM also. Is it cost effective to do that? That's the first question anybody will ask. So we did a proper cost effectiveness study. This is published in the Lancet eClinical Medicine. Each of those papers you can read. About 14 papers have already been published from toboggan. And we have been happy to be part of all of them. So, in fact, there is one issue of Diabetes Care published in February 2025, where Hannah's drawing is the cover of Diabetes Care, and there were 5 papers of toboggan in the same issue. They had a separate section on toboggan in Diabetes Care. Many of you would have seen that. I think 5 papers were there. This is a separate one where we looked at cost effectiveness. We found it's cost effective. So we should go ahead and treat with all the costs involved. The NICU admissions you save and everything else you save makes it cost effective. The next thing we asked was, okay, now we've got early GDM and late GDM. What happens if you just look at the outcomes of the late GDM women who did not have early GDM? Earlier, we are not looking for early GDM, only late GDM. So everybody was mixed in that group. And we know, okay, treating late GDM overall has benefit. But what if you remove those who had early GDM and look at only those who had late GDM and treat them? Is there any benefit? What we found was there's no difference, which is not surprising to me. You diagnose somebody at 28 weeks and 6 weeks later or 8 weeks later they're going to deliver. What's the big thing of treating them in the last 5-6 weeks when the baby is about to come out? You go and now treat their diabetes. What do you expect? Nothing you'll get. So all the results of the GDM so far has been because of the early GDM, which is missed all along. So in this paper we say that early GDM is in fact more important than the late GDM. The next thing we did was a recent paper where we looked at the postpartum conversion rates, how many women actually develop it. So overall, the early GDMs seem to convert more. And the good news was that if you look at the underlying ones, those who were treated and those who were untreated, if you didn't treat them, they developed the diabetes further. So treating these women early seemed to reduce the conversion to type 2 diabetes also. That means there's even more reason why you should treat the early GDMs. Now you may ask, all this is fine, but as an Australian study, is it relevant to Indians at all? That's what they said when HAPO was published, because Indians didn't participate in that. That's the reason why we participated in this. That question should not come. So the obvious thing is to break it down by various ethnic groups and see which ethnic group had more of early GDM. Surprise, surprise, it's the South Asians who had the highest prevalence. Look at the odds ratio for eGDM, highest. If you look at South Asians, compare them with Southeast Asians, East Asians, Middle Eastern, Maori, and the reference group is a white European population. So we are 2.43 times higher, and we have the highest risk. And this is not just Indians in India, it's Indians in Australia as well, South Asian, because Bangladeshis and Pakistanis would have been included as well. So this message about early GDM is most relevant to us, and therefore we are the ones who should be screening for this. Okay? The next question is, why are these women developing early GDM? And why are they different from the late GDM? We are also looking at it. In fact, we are trying to collaborate with Russia for this, and we have Dr. Polina here from St. Petersburg. We have a collaboration probably going with them, but we also have another study which we are looking at. Our results are not ready, but there are two papers which have already come, and I'll just refer to one of them. Now here are insulin secretion studies represented in different ways: C-peptide, insulin secretion, secretion rate, beta cell function. L-GDM is late GDM and E-GDM is early GDM. This is a separate paper. This is a Western study. But you can see that whichever parameter you take, the early GDMs have less of insulin secretion. And that's why they're more severe. That's why they're converting more after their thing. And that is why they're developing it early. Because the beta cell function is more severe, so they don't have to wait until second trimester. By the time baby starts growing, first trimester itself, their diabetes comes out because the beta cell function is not working properly. So now I'd like to conclude by saying that the earlier paradigm, which we have all been following, is, yes, do a blood sugar in the first trimester, but that's not for GDM. That's to rule out pre-existing diabetes, type 1 or type 2. That's the only reason why we are doing, not look for GDM. GDM you look only in the second trimester. That's what we used to do. Now it's changed. Now you start looking in the first trimester, yes, to rule out type 1, type 2 diabetes, but also to look for early GDM, which in fact seems to be more important than the late GDM. And of course, if you don't have it in the early GDM, then you still repeat it once again because you'll still pick up late GDM. Now you have to do a lot of studies doing early GDM and late GDM. Are they the same disease? Do they have the same genetics? Is the epigenetics the same? Is the metabolomics the same? The proteomics the same? This has opened up a can of worms, and so we have next 10 years we have to study all this to learn more about early GDM and late GDM, and we hope to do that. Meanwhile, has the world accepted this? Thankfully, yes. The first to accept it was Belgium. So the Flemish consensus, they've accepted, and they said, our country now, we will screen for early GDM. And what cut point did they use? They used the high band cut point. They said in toboggan, 95 and above was taken, and therefore we will use 95. If you're interested, they even tell you 95 what you should do, 126 what you should do, 95 to 125 is early GDM, and what you should do for that. They have made it their national guidelines. Australia followed, An Australian association has said, screen for early GDM. If you have GDM, you do this, you do that. Otherwise, you again screen for late GDM. They've also come out. ADA in 2025 has already said, yes, screen for early GDM, but they didn't use the word GDM. Americans want to be different always. So they said early glycemic dysmetabolism, some other word they use. They don't want to use the word GDM, okay? Essentially, it's the same. A rose, whether you call it by any other name, is still a rose, okay? So they're not using the word GDM, they're saying it's glycemic something, dysmetabolism, something they call it, but they're saying yes, screen for it, they're saying. So 3 associations have already accepted this. So here are my take-home messages, ladies and gentlemen. Early pregnancy blood glucose screening is mandatory as it helps not only to identify pre-existing diabetes but also early GDM. Early GDM has a more severe insulin secretory defect, and that's why they're developing it compared to late GDM. Toboggan has shown for the first time that it's beneficial to treat, and particularly those in the higher band more than 95. So my prediction is that 95 will become the cut point in the future. And earlier you diagnose it, I understand that in Russia, even in 5th week and 6th week, they are diagnosing early GDM. We are saying before 14 weeks. When the lady says she's pregnant, do it then, because they may have that little glucose metabolism. No significant adverse effects of treating eGDM. It's cost effective. Indians have the highest prevalence of eGDM, and many countries are already accepting it. So if there's one message you must learn from this talk, I have 1 minute 46 seconds left. So early GDM or eGDM must be identified and treated by all of you. Every one of you, remember early GDM and do it. If you want to follow me on any of my social media, you can do this. If you take a QR code copy of this, you can join my WhatsApp channel. The advantage of joining WhatsApp channel is that every single day, 365 days, you will get a message from me. And if there's anything new which is coming out, you will be the first to know. Thank you.
I think you'll all agree with me. It was an exciting finding and also exciting presentation. And, it's customary that invited, speaker are not questioned on the dais. But I take your permission, Mohan.
Yes,
that
there are one or two questions we can take.
He will be around for
okay.
For a day or two.
Yeah.
Yes. So anybody has any
they've already
question?
come. Can we accept
Anybody
that
has
question?
any question? Ask him personally after the meeting.
Okay.
Because it's customary that they are not questioned during the meeting. Thank you all. And I again emphasize that I think we have all been benefited. It has been exciting finding and presented clearly in exciting way. Thank you.
So, welcome friends for the another session. So, there is some change in talks and schedules of the session. Our two of the speakers are not being able to reach because of the flight schedule is changed. So, Dr. Sunil Gupta shall be speaking on hyperglycemia in pregnancy, what's new in the management. Dr. Sunil Gupta is a well-known physician and diabetologist at the Nagpur, and I think most of the people, those who are in this hall, may be knowing him well. So without wasting much time on his introduction, right? We would give the time to Dr. Sunil to talk us.
Yeah.
Good morning, everyone, and thank you very much, Anuj, for this introduction. It was a wonderful, once again, listening to Dr. Mohan sir on e-GNAM, and when I got an opportunity and honor to speak somewhere where there was empty slots, so I said I'll talk on the same topic, so we have a continuation on the same concept and something on something original on the management issues or management learning on gestational diabetes. Is it working? Yeah. Thank you very much, Bansi Bhai and the whole team of Diabetes India. I don't know. It's not working? Okay. So there is no conflict of interest for this particular session. I'm going to talk on introduction. Some newer concepts and classification has already been discussed. We have one or two more things on the just summarizing those points. Recommendations in the Indian data on pharmacotherapy in gestational diabetes. I feel everyone knows that the prevalence of HIP is increasing. Almost 85% are going to be gestational diabetes. Around 15% are going to be pre-gestational diabetes. And pregnancy has been considered as a stress test to the beta cells, and they are likely to develop diabetes in future. I feel everyone is aware of this particular slide. Important is this is one of the window of opportunity that we can unfold these women who have compromised beta cells and are likely to develop diabetes in future. So that is why recommendations said that every woman at the first given opportunity, and that also Dr. Mohan said that the first time when they are being diagnosed that has to have pregnancy should be screened for by GCT or OGTT, so that you can unfold this mystery of hyperglycemia and pregnancy. This is a classification by FIGO that it is HIP has been divided into two: DIP, which is diabetes in pregnancy; gestational diabetes, which is diagnosed during pregnancy. So DIP is one category where you have known type 1, type 2 becoming pregnant, or those who are diagnosed for the first time during pregnancy because they have never tested it, but it matches with the cutoffs of the known of the diabetes, like 200 post glucose, or fasting more than 126, or random blood glucose more than 200, or HbA1c more than 6.5, then they are known or pre-existing diabetes, but they have never tested it, and that is again DIP, because the treatment strategies they change as per the classification of hyperglycemia and pregnancy. When GDM is typically coming, which has been told to you. So your GDM, which refers to hyperglycemia between 24 to 28 weeks of gestation by the standard criteria, either in go for DIPSI guidelines or the Government of India guidelines, or maybe the international guidelines, and that can be called as conventional GDM. So it's CGDM now. Overt GDM is those, as I told you, pre-existing diabetes but never tested but diagnosed during pregnancy. They are overt diabetes. EGDM has been just discussed, that you are diagnosed hyperglycemia in pregnancy before 24 weeks. Mild GDM is another terminology where you do 2-hour test between 120 to 140, because your cutoff for targets, glycemic targets, is 120. So anything above 120 is going to be abnormal. And pregnancy is being celebrated in our country, so one should know that if you tell the women that your blood glucose is 135, you don't have diabetes, she is going to do this GCT on a daily basis by having sweets, because we celebrate pregnancy, and that might cause a problem to the baby, and that's why mildest form of hyperglycemia should also be respected. So it's an epidemic, and these offspring of diabetic mother, they are also likely to develop diabetes, and these women are likely to develop diabetes and future cardiovascular disease risk. This is very important, a new thing which I wanted to share with you. There's a parental contribution of programming adult obesity or diabetes in the offspring that start pre-conception. So pre-conception, you have oocyte maturation, follicular development. During conception, that is fertilization of the embryo growth, and gestational sucking, that is lactation. These are the critical windows of the maternal and obesity and diabetes. And this is an animal study. There's also important message that pre-conception period, even the quality of the sperms, that also important for the outcomes. So pregnancy is a multiplier of unfolding pandemic of diabetes and NCD, And we should know that it's a crossover and it's a vicious cycle which may continue. Is there any role of gut microbiota? So there is some data now, we call it as gut dysbiosis, which might have, which has been shown in GDM women. There's some good bacteria which are less, some bad bacteria which are more, and they might increase the maternal fasting blood glucose, maternal BMI, and they are pro-inflammatory to the baby and may cause obesity in the offspring. And this is a wonderful diagram showing you multiple, some good as well as good bacteria, microbacteria which are becoming less, and some of the inflammatory mycobacterium which are going up, and they are causing some changes in the milieu, and they might be responsible for the childhood obesity in these babies who are born to these mothers. Now, and this is a vicious cycle, as I told you, which might continue. You have got a woman who's obese, delivering a obese baby, and if this turn out to be a female, will again become a obese women and obese pregnant women. Their next generation, and this vicious cycle has to be taken care more aggressively and more seriously, which we are not doing at this moment of time. I'll have just 30 seconds on screening. So we have this ADA criteria, IADPSG, WHO, and most of them, they follow IADPSG criteria now, that you do fasting more than 92, give 75 gram glucose, 1 hour is more than 180 or 2 hour more than 153, we call it as. Now you have Government of India guidelines updated almost 8 years back. And they have simple criteria of DIPSI that gives 75 gram glucose irrespective of the time of the meal. If the 2 hour blood glucose is more than 140, you diagnose it as GDM. But if it is between 120 to 140, you can call it as a borderline case or a GGI, gestational glucose intolerance. So they need to be kept very close follow-up. When it comes to the management part, glucose traverses the placenta with the passive diffusion, so it directly goes inside the fetal circulation. Same is the amino acid, same is the ketone. So if the mother develops ketosis, ketone will enter into the fetal circulation directly without any hindrance. Triglyceride partially will need some receptors. Insulin doesn't cross the placenta. My message is, insulin doesn't cross the placenta, but all other oral glucose lowering therapy, they do cross the placenta. Glucagon also doesn't cross the placenta. And that is why that insulin becomes a drug of choice. So you have insulin drug of choice. Oral drugs, we are using metformin. Glibenclamide has also been approved. And of course, diet, lifestyle modification is one thing. The insulin, we have now, except glulysin, most of the insulins are being approved. As far as glargine the debate is concerned, we know that the glargine, now they say that if a clinician has already put the patient on glargine before conception, women comes to you with pregnancy, and if you feel that by withdrawing glargine, it might affect the glucose control of a woman, in that situation, on clinician's perspective, we can continue glargine. Degludec has also been approved recently, last year, for use in pregnancy. Their target should be 90, fasting less than 90, 2 hours should be less than 120, HbA1c should be less than 6.5. And this TIR model has been shown yesterday also in the technology meeting, that for GDM and type 2 pregestational diabetes, the cutoff actually has been kept in pregnancy 63 to 140. I repeat, 63 to 140 is the TIR values. For GDM and pregestational type 2 diabetes, should try to achieve more than 90% of TIR, while for type 1 diabetes, up to 70% TIR is acceptable. Your targets, as I told you, will be target for pregnancy, I told you. Then we have, this is one paper which I wanted to share, because there's the Indian data where we are going to have some guidelines, some message that how should you proceed once a person with women with GDM comes to you after diagnosis. So it's a neonatal maternal outcome in women treated with insulin or diet, and it's a propensity match analysis. The highlights are that women receiving insulin had a low risk of preterm babies, low birth weight, and macrosomia. So they had less risk of having LBW and macrosomia. Neonatal hypoglycemia was more common in insulin treated women. 2 hour glucose tolerance test of more than 162.5 and the fasting of more than 90 are likely to require insulin. Individual with the propensity score of more than 0.7, that I'll tell you what it is, require higher dose of insulin versus others. A study has concluded that individual with bad obstetric history, family history of diabetes, obesity and elevated baseline glycemic parameter, that means fasting, postprandial, post-glucose or HbA1c, are likely to require insulin. These are the baseline characteristics. So those women with higher age, having bad obstetric history, having positive family history and having pre-existing BMI high are likely to require more insulin versus others who are managed only on diet. And neonatal hypoglycemia was found to be higher in women who were on insulin therapy. PIH was more common in women who were receiving insulin. And this is again then after we did the propensity score and the adjusted risk of neonatal and maternal outcome, almost everything was similar. That means whether you give diet or insulin, if you select the patient properly, it is the only risk of with hypoglycemia is neonatal hypoglycemia, which is expected because these women are having severe hyperglycemia and they are requiring insulin to achieve the glycemic control. Rest all other things were similar. That is another very important message. People have an apprehension that if you give insulin, women might end up into hypoglycemia and you might end up with having IUGR, and that was one of the concern which was raised, that are we over treating these women? But the study has shown if you properly select the women and treat them effectively to achieve your targets, you will not cause over treatment. There is no increased risk of low for gestational LGIs. And then preterm birth, so what we have is the preterm birth, low birth weight, microsomia due to insulin were close to 1, that was statistically not significant. Neonatal hypoglycemia 4.43 higher. LGA was comparable, rather lower in the patient who received insulin. IUD was also found to be lower and PIH was little higher in insulin treated group. Now, we also did initial and the full term dose required for these women during use, and the first to the third, they have divided these women who are 386 have been divided to 4 different groups, and this 4 quartile, the first to third quartile signify a low and moderate risk, while the 4th quartile has higher risk factors. And that's why this is a love plot. This love plot is, if you see on one side, this is I'm sorry it's not working, but then I can use this laser pointer if I can. Yeah, if you see this, I don't know, no, it's not. Yeah, I'm able to not move. Yeah. Okay, so this is the if you see this is unadjusted, this is adjusted. In all of them, after adjustment, this plot seems to be more overlapping, and that is called as love plot. Yeah. So what they have done is this first, second, and third quartile. What they have adjusted is the age of the mother, parity, BOH, family history, pre-pregnancy BMI, HbA1c, fasting, and 2-hour postprandial. These 3 quartile having less than 0.7 versus the 4th quartile had a propensity score of more than 0.7. Now these have required almost 10 units of insulin on an average in the initial stage, which ended up with almost 18 to 20 units of the insulin at the time of delivery. While this group having higher risk factor, these risk factors requires around 17 to 18 units here mean, which went up to 25, which was statistically significant. So this is another message that a 2-hour has highest discrimination power at 162.5 and the fasting as 90, almost 90. So we can easily say that these risk factors, they determine the dose of the insulin also and requirement of the insulin also. So discussion from this particular paper is it has been observed that mother with over 25 years history receiving were predominantly receiving insulin. Those younger women were commonly prescribed diet therapy. Presence of family history, then you have 2-hour postprandial HbA1c, higher rate, positive BOH, positive family history, they all require insulin therapy. Now, beta cell function declines within 2 years postpartum in women. So we say that 6 weeks, 6 months, and the once in a year, we should be following these women for developing type 2 diabetes in future. But within 2 years, if they say there is deterioration in the beta cell function. And what are the risk factors? We have fasting in antepartum fasting hyperglycemia, early gestational age, postpartum weight gain, decline, and the postpartum OGTT. All of them they actually determine the chances of having or predicting the postpartum diabetes, and these are the risk factors. Antepartum, if your blood glucose more than 200, requiring insulin therapy, more BMI, and the diagnosis of GDM less than 24 weeks, that's eGDM, they are likely to develop diabetes in future. And higher is the risk factors, more risk factors, higher is the risk of developing diabetes in future. And this is our own paper, where are 16,000 total patients, out of them almost 30% women. 6.6% had past history of GDM. They are type 2 diabetes coming to us. We have taken the past history of GDM. So then we saw the onset of diabetes in these women were around 40 years, and there was a 10-year gap after developing GDM. But then we further went into detail. We found almost 51% of the women of them developed diabetes in the first year after they developed GDM. And the risk factors were those who require insulin were postpartum BMI, and those who required insulin during pregnancy have developed type 2 diabetes early. There's metformin plus insulin for pre-existing diabetes on GDM in early pregnancy, and this is a MOMPOT RCT trial where they have used metformin along with insulin, found to be safe as far as use of metformin is concerned. And that's why after these few trials, European government has approved metformin's use from the preconception till delivery. Of course, still we have little pros and little cons of using this drug. Metformin still have a little risk of having low birth weight and catch up growth after the birth. So we have to be attentive. We have to be screening every woman. We have to be focusing on fetus for the future of future generation, because if you detect them early and if you treat them early, possibly we'll be able to save future generations. And that's why we have National GDM Day, which is 10th of March. It's coming very soon next month. And we have 9th of March. We also have the National Dipsy at Hyderabad. So this is a national awareness day, and India is the only government in across the globe. Indian government has put this as a National GDM Day for awareness, and I'm happy to share that we have started this Prega Talk. We have almost 23 languages in the Indian Constitution, and we did almost in all the languages have been covered this Prega Talk. We use regional faculties and do this work. Like if you have Marathi, we utilize the services of Shashank Joshi, and if you have Gujarati, we utilize Bansi and his team. So we do this program for the regional awareness about gestational diabetes. We started now the second cycle. We already have completed almost 19. Very next is going to be Manipuri and then Urdu. So no single period in the human development provides greater potential than pregnancy for long-term payoff by a relatively short-range period of enlightened the metabolic manipulation, and that's why we should be aggressive in achieving screening and achieving the good glycemic control in these women, irrespective whether you use diet, whether you use lifestyle modification, metformin or insulin. Wish you all Happy New Year, Happy Valentine's Day. Stay safe, stay healthy, and keep smiling always. Don't cut cake today, even if it is for your Valentine. Cut the watermelon, or you can cut papaya or some other fruit to celebrate your occasion and give a strong message to the society. Thank you very much, Chairperson. Thanks.
Very nice and elaborative, and really enjoyed this 20 minutes capsule of gestational diabetes. Any question from the audience? I think it was so clear. You are there.
Thanks for the talk, sir. I'm not a doctor, so I'm an engineer trying to work on insulin delivery devices. I was wondering what is the recommendation in the terms of treatment? I saw some protocols which require insulin. Do you recommend insulin being given multiple times a day, or insulin pump therapy is more recommended?
See, this is when it comes to gestational diabetes, there are two types of patients: yes. Pre-gestational type 1 or type 2, or gestational diabetes. Yeah. When it comes to pure GDM, it usually comes as a postprandial hyperglycemia. Right. So you require 3 times a day prandial insulin. Basal insulin may not be required. Right. Like in our own study, we have required hardly 10-20% of requiring basal insulin. They all were managed only on prandial insulin. Well, they achieved 90 and 120 targets. When it comes to pre-gestational, either any of the DIP category, type 1, type 2 or DIP, they might require basal bolus therapy aggressively. In those situations, yes, they require 4 to 5 times pricks per day, and they might be benefited through pump. But the pump has been used only in type 1 pregnancies. Up till now, whatever trial we have has shown the good clinical outcome, better clinical outcome in type 1 diabetes pregnancy. We don't have data with type 2 pre-gestational or gestation diabetes.
All right. Thank you so much.
Thank you, Dr. Sunil Gupta, for the nice talk. Now we shall be moving for the another.
Thank you very much.
Session. Dr. Shashank Joshi is the speaker, and he will be speaking on Asian phenotype. Are we different for diabetes prevention strategies? Dr. Shashank Joshi is well known for all of us. He is a reputed clinician, Padma Shri from Mumbai. He is consultant endocrinology at Leelavati Hospital, also at Joshi Clinic. And I think as far as the publication, honors and achievements, very difficult to count, innumerable almost. So without wasting much time in introducing him formally, I would request Dr. Joshi to start his deliberation.
Thank you so much, Dr. Anuj, and I must thank Diabetic Asia Study Group, Dr. Basit, Dr. Bansi Sabu, Dr. Nadima, and everybody for keeping the topic of prevention and involving the phenotype. We had a very, very elegant presentation by Dr. Kunti on phenotypes. And we know that Asian phenotype is different. We are similar and dissimilar in many ways. I don't have any duality or conflict of interest for this talk. I hope what you listen, you will learn. What you learn, you will adapt. It's a postprandial time, and we know diabetes in Asia particularly has moved from an epidemic to a pandemic. We are thin fat in many ways, at least in Indian. Asian is a much broader term, and I'll allude to that a little later. Is it genetic or familial? Probably yes. Is it linked to sedentarism or activity? Probably yes. Is it linked to too much of calories? Probably yes. Do medications respond differently in Asians? Possibly yes. Are there transcultural algorithms? Probably yes. So we have clusters and recommendations, but today our goal is to look at various prevention trials which have been done and how are they different in the Asian population, and we have a few of them. So when it comes to phenotype, we did a screening program called Screening for the Twin Epidemic much before the ICMR INDAB, where we screened 8 states of India, 16,000 population, primary care, first 10 people who walked in the clinic for any complaint, cough, cold, fever, and we found that 80% of them had either type 2 diabetes or hypertension, and the single most common factor which was determining or driving hypertension or diabetes as a twin epidemic was the waist circumference or truncal obesity. So when we moved from village to town to city, the driving gradient was abdominal obesity, and therefore our phenotype, at least in the Indian geography, is we have more fat, less muscle. We have sarcopenia, which is muscle mass is less. We have abdominal obesity. It's probably familial. It's clearly environmental. We are becoming more and more affluent, and we are becoming more and more sedentary. And this was seen in the New York City when Marianne Banerjee with Harold Lebowitz published this paper almost 30 years back, where she showed that people from Pakistan, Bangladesh, India, who were cab drivers, when she compared their body fat, and normal people between 20 and 45, compared their body fat with African Americans and Caucasians, the Asians from our geography, or Southeast Asia, and Professor Azad Khan is here from Bangladesh, who's our Southeast Asia chair, clearly showed that we, in the non-obese Asian Indians, we had more body fat in our body composition. So clearly the thin fat phenotype or the Asian phenotype carries more fat at the same BMI, whether it is total or abdominal region. They have less lean muscle mass and bone mineral compared to other ethnic groups. So if you have a person with a BMI of 32, and if red is the lean mass and yellow is the fat mass, person A, person B and person C, clearly person A is probably of Asian ancestry, while B and C is probably of non-Asian ancestry, is a conclusion which people alluded to. So clearly different BMI, same lean mass also, a similar application can be made. And therefore the face of the Asian phenotype is a face of the modern malnutrition. And this is a global graph that the low lean mass present across all body weights and BMIs is the new face of our phenotype from Asia. And therefore, if you look at the low lean mass of sarcopenia in Asia, not just south of east of Asia, but even if you look at east of Asia, studies from Hong Kong, Taiwan, China, Korea, Japan, and then of course from India, Bangladesh, Pakistan, and our geographies, Nepal, Sri Lanka, clearly there is an underpinning of a sarcopenia or low muscle mass. So clearly our phenotype is central obesity, obesity at a lower BMI. What is driving it? Probably too much of food, mainly too much of carbs and too much of fat and very less protein. This was the start study which we published almost a decade back in the BMJ Open then, where we showed that India has excess fat and carbs and very less protein in the non-diabetic as well as the diabetic population, and compounded by a sedentary inactivity, whether it's watching any gadget, television was a classic one, or a computer screen or a mobile phone, and then of course we are less fidgety. So we have dropped down our non-exercise activity thermogenesis or NEAT, and therefore a typical agrarian Asian who was always an agriculturist has dropped down a NEAT of 2000 kilocalorie per day to a non-activity exercise thermogenesis of 700 kilocalorie a day. So clearly our phenotype has more fat, less muscle mass, mitochondrial defects and insulin resistance. And that actually leads to a lot of heart disease. And this was replicated by Dr. Manisha and Nicole Abate from Texas, Dr. Anji Raji from Boston and Harvard, and they clearly showed that at a comparable value of body fat, Asian Indians had higher insulin resistance, and typically our phenotype has thin fat or more abdominal fat, more insulin resistance, lot of inflammation or meta-inflammation, low adiponectin, typical dyslipidemia of low HDL, high triglyceride, and clearly we can recognize that we have more susceptibility to coronary artery disease and type 2 diabetes. Do we respond better to drugs? This was a study which our student from pharmacy did, typically presented long time back at IDEA Montreal, now published. Pioglitazone, 7.5, 15 and 30. The glucose reduction is the same, but the Asians respond better even at the lower dose. So study done in a gliptin, because we eat more carbs, the Indians and Koreans drop the A1C in a gliptin like sitagliptin by 1.36 because we have a higher carbohydrate exposure. In the Caucasian world, gliptins are not popularly used. They drop the A1C maybe by 0.6 or 0.8, but in our world we use a lot of it. So therefore there are need for ethnic specific guidelines for prevention, and many of us tried to look at different cut points, and we had physical activity guidelines, which is not 30 minutes 3 times a day. It is 60 minutes of physical activity every day. Then we had dietary guidelines of less carbs, less fat and more proteins. And then we had this consensus statement which came out for Asians on physical activity, medical and surgical management. We also see that in Asia and worldwide, due to use of ultra processed foods, we are fibropenic. And we are having less and less fibers. Again, Dr. Sabu was the first author of this paper. Many of us published this, that we are having less and less fiber. We are also getting clusters now, because type 2 diabetes is very heterogeneous. And many of us compiled this paper, but predominantly coming from Professor Mohan's group. And you could see that we have severe insulin deficient diabetes, insulin resistant obese diabetes, combined insulin resistance and deficient diabetes, and mild age-related diabetes. So clearly you can see, and they have a differential complication impact from the cluster, and therefore we can sub-classify that. So we are having adiposopathy, and we clearly recognize that when we are treating people with diabetes in this part of the world, phenotype matters. We cannot just be glucocentric. We need to look at the weight, the obesity, the fat, the ectopic fat, and so on and so forth. And therefore, global guidelines and Asian guidelines vary because we see spectrum of people in our clinic: malnourished, lean, thin build with central obesity, normal weight, normal build, overweight, obese, and morbidly obese. So we clearly see that global guidelines are not necessarily suitable for Asian population because we see a lean and non-obese person with diabetes. We see people with ketosis proneness, and we clearly see that we definitely have other drugs like alpha glucosidase inhibitors. So one size doesn't fit all, and therefore we need to tailor it. So when it comes to prevention of diabetes, which is my strategy for Asian phenotype in the last 10 minutes, I will allude to prevention strategies. And in the Asian phenotype, are we going to be different? 1921, more than 100 years back, Professor Elliot P. Jocelyn wrote this paper in JAMA on prevention of diabetes mellitus. And I don't think there is much change between what he wrote on 8 January 1921 and today. In type 2 diabetes prevention, there is a slow progress in population in RCTs, and robust research is lacking. There is a lack of agreed upon definitions. Early studies hindered by absence of standardized definitions. Behavioral change is tough, and clinical settings to adopt these trials are not easy. Evidence-based guidelines only came up in the 70s, and by that time diabetes had exploded as the population exploded. From 1972, where world was 4 billion, today in 2023 the population doubled to 8 billion, but we have an explosion of type 2 diabetes population of almost close to 1 billion. 1 in 8 people on planet Earth are living either with diabetes or pre-diabetes. So for a successful disease prevention, the prerequisite is an agreed diagnostic criteria, understanding risk factors and natural history, affordable and acceptable screening, and modifiable risk factors which are acceptable for a strategy change. And therefore we need to look at explanation from North China in 33 clinics, 4 groups: diet alone, exercise alone, diet and exercise, and control. Clinics, no individual participants, randomized to different intervention protocol, robust intervention supporting lifestyle modifications, work. So Asian evidence here, robust Asian evidence in clinic practice to show that in North China, 33 clinics, it's possible. The Finnish diabetes program also then came out with a similar protocol with lifestyle outcomes on healthy diet, physical activity, and weight reduction. And their first year results were compelling, and after interventions their 4-year results were more compelling from the Finnish diabetes program, which looked at less consumption of lower fat, sat fat, high fiber, looked at aggressively looking at weight regain and various other strategies. The most compelling prevention trial on planet Earth is the DPP program, which is the diabetes prevention program in United States funded by the NIH, and that program, which came almost 2 decades back, had intensive lifestyle, standard lifestyle with metformin, standard lifestyle with placebo, and 58% reduction, just like the Finnish program, showed type 2 diabetes risk during intensive lifestyle, and this risk was reduced to a large scale. Professor Ramachandran designed the Indian diabetes program, and in that program we were able to show that the lifestyle intervention was not as robust, and he had an IDTP 1 arm and IDTP 2 arm in which there was metformin as well as there was pioglitazone in the second part. Lifestyle worked, but it was not as robust as the Caucasian data or the Chinese data because of the low lean mass. When we looked at the Japanese trial of men with IGT, again when we compared a 4:1 randomization of standard intervention versus intensive lifestyle, you could see a compelling impact. So when we look at the Daiqing study in China, the Finnish study, the DPP program in the US, the Japanese trial and the Indian trial, clearly you can see what is underpinning: lifestyle, dietary change, weight change, and the sedentary habit going away. And there was a long-term follow-up for Daiqing, which is available for Finnish study as well as DPP4 program. Unfortunately for the Japanese and the Indian trials, we didn't have long-term follow-up, which is something which we need to recognize. So when we compare these various RCTs in the type 2 diabetes prevention trials, we clearly see what are the common denominators. And the common denominators are very, very clear. Energy restriction, fat reduction, increased fiber. Weight loss varied significantly, and I don't like the word weight loss now. Fat loss is more important than weight loss across trials, with notable success in DPP4 and DPS, the Finnish and the American trials. Clearly, the physical activity was emphasized across goals, including the daily walking habits in the Japanese trial, and the long-term follow-up looked at assessment of sustainable intervention. The relative risk reduction varied, and the Japanese IGT program had the highest reduction of 67%, with lifestyle interventions consistently outperforming all other methods. If lifestyle reduced or prevented diabetes in 2/3, all other drugs reduced it by 1/3. It remains to be seen whether the new ticket drugs like SGLT2 inhibitors, which are generic now, or the GLP-1 receptor agents, which are coming in now, if they are used in the prevention space, what will be the outcome? But there is no funding for that. The other key important things is the risk reduction from all these RCTs, which I alluded to, was consistent. The prevention effect in lifestyle was quick and fast. It was gender neutral, and it was across all ethnicities. So it really didn't matter whether you were Asian or non-Asian. But when we looked at lifestyle intervention, independence from initial body weight, multifactorial benefits, postponement of type 2 diabetes, residual risk and genetic risks are varied. And that's something which we need to recognize. For example, if you look at a 30-year follow-up of Daiqing from the Chinese cohort of North China, you can see this paper that people with impaired glucose tolerance who reverted to normoglycemia or remained with IGT had lower risk of cardiovascular disease and microvascular complications. So you could actually see the impact of metabolic memory, which was seen in UKPDS in overt type 2 diabetes, was also exploited in the Asian population. So clearly you can see that in the post-trial follow-up in the long term, at least there is a 20% risk reduction of type 2 diabetes. The DPP outcome study showed only a 6% reduction. The Daiqing 30-year follow-up showed 49% reduction. And the Finnish program had a differential effect. So ethnicities do matter, phenotype does matter, and the fat to muscle ratio does matter. This is again an impact of 10-year follow-up of the diabetes prevention program outcome study from the DPP group. The other focus point of intervention is fundamentally the youth. The Yale Bright Body study and the US Latino study again underpin the same thing, as well as the Finnish DECO program and Fin-Do-Do-Do program had the same impact. And you can clearly see that the impact is very clear, and probably you need to have a practical tool. And Jacko came out with this practical tool to predict the risk of type 2 diabetes, and now many people have integrated that, and it's been translated across it. But the challenge in low and middle income countries is global disparity of high income focus, emerging studies, implementation approaches, and stakeholder participation. And therefore we need to keep doing work which are landmark trials, which have a global impact, which have sustained benefits, and there is an ongoing challenge. From the ICMR Index, I borrowed this cutting from Professor Mohan, we are a part of it, that you can actually look at remission. Remission is a reality. Just by reducing carbs and adding proteins, you can do remission. We have shown it in RCT, and you can clearly see that. And therefore, if you want to make a change in our phenotype, we need to hard hit mantras of prevention, like eating slowly, eating less, eating on time, eating it right, walk more, do some yoga, sleep well, and clearly look at just not outcomes of health, but also look at outcomes of happiness and do some digital detox. My final slide is that the fat to fit debate, because we are in a fit India movement, and the fat versus muscle debate is time is muscle. The more muscle you build, the more muscle we build, the better is a chance of our phenotype to burn that little extra fat from either the ectopic side, and that's the key. And if we are able to do that, we'll maybe able to make an impact in our phenotype, in our Asian phenotype, because the world's population of diabetes is predominantly in the Asian continent. And therefore, let's not waste muscles, but activate them with exercise, mainly resistant exercise, and that's the key to diabetes prevention apart from eating less. Thank you so much for a patient hearing.
So every time it gives a new message. So this time I can say that your old mantra is becoming a final mantra with the exercise. Exercise is the most important part of the mantras. Sleep well, eat right, and walk more. So now exercise, we should give this message that exercise is the most important. One thing I was coming in my mind when you were presenting that, score what you have shown that, does it really work for us also?
So there are Indian scores. Dr. Ramchandran has devised a score, Dr. Mohan has devised a score. Many people have devised a score. They need to be validated and replicated. But some of the scores can work. For example, we had a Framingham risk profiling score. So we should have, say for example, you are in the leadership RSSD. I would like you to develop an RSSD risk score during your leadership, so that we can have an evidence-based risk score as a screening tool. And just take two factors like family history and waist circumference. Simple. And if it's positive, then screen and intervene. So, because the score has to be simple, it has to be replicable, and it has to have some evidence behind it.
So let's start working for RSSDI score.
Sure.
You guide RSSDI for the same. Any question from the audience?
Sir, Kamlan here. I want to ask how this phenotype has evolved in this Asian region. What are the reasons? Doesn't it make a sense that the centuries of having the avoidance of non-vegetarian foods among society due to cultural and beliefs, all those things have resulted into this kind of phenotype? And can it be reversed back towards the Caucasians or European phenotype by taking more and more proteins and non-vegetarian foods?
So I think, Kamran, that's a good question. In the last bench, I can see a lot of last bench, Professor Yagnik there. He will say everything starts in the womb, and not the womb now, he says everything starts in the ovary. And probably evolutionally, your question is on the thrifty phenotype.
Yeah.
We have been storing these fats because हमारे यहाँ सूखा होता था. It used to be famines, and therefore we were storing this fat as a fuel. And our community was predominantly agrarian.
Yeah.
And because they were agrarian and they were storing fat as a fuel, that was not detrimental to poor health. But that time the longevity was 30 and 40 years or maybe less. Human longevity. Today the lifespan of human beings across the world, including India, is crossed 60 and 70. So I am not so sure whether we have done high impact work in that science. We need to, that is still hypothetical. Professor Yagnik has done work in multiple generations. And therefore, he has live cohorts of children who have now become adults and are delivering children. I am certain that he will actually throw a point or two of what you're saying. The second point which you're making about the, all human beings when they were born were eating everybody except humans, or maybe they ate humans too. And then there was suddenly a disruption of a vegetarian movement. Whether it is detrimental to health or not, we don't know. It could have an impact. It's an interesting subject for good research. but we don't have good evidence-based answers on that right now. I would say that it is partially speculative, partially backed by evidence. Professor Yagnik, any comment from you, sir?
Thank you, sir. Vegetarianism is very true. India became vegetarian 2500 years ago when Samrat Ashok became Buddha's disciple.
After the Kalinga War.
Kalinga War. So that bloody war, Buddha told him ahimsa, and ahimsa means not only not killing humans, but not also animals. And that's how our vegetarianism started. That of course I cannot not mention vitamin B12 actually brought in, and today I don't think we need to test B12 vegetarian Indians, we can just supplement it. And in Pune we have done the world's first primordial prevention trial to reduce DASG spring by improving the B12 status of adolescents. The trial is called PRIA, Pune Rural Intervention in Young Adolescents. I started in 2012. Last delivery was in February 2020. And now I have very rewarding results that within this population, the 200 grams heavier. They have a larger head circumference. They have larger abdominal circumference, that the organs are bigger. And in the intervention groups, there is no corresponding increase in body fat. So for the first time, I think we have demonstrated that a preconceptional intervention with vitamin B12 has actually started changing the phenotype in utero. I consider this as my top result over the last 30 years because it's intervention and it's a reversal of the phenotype. And we are now following up these children at 8 years of age to see whether we can see any change in the risk factors for diabetes. Thank you.
Thank you, sir. Thank you so much.
Thank you. Really very insightful session and feeling lucky to listen to this wonderful conversation. Thank you, Dr. Shashank.
Thank you, sir.
And now over to the organizer. Pardon? क्या करते हैं?
Chairperson
Announcement करना है. Nice to see you. I was just seeing you this morning, but could not speak to you. Anuj Maishar. Chairpersons for the next sessions are Dr. Kamlesh Kunti, Dr. Atul Kalan, Dr. B.M. Makkar. Please join us on the dais.
Good afternoon, everyone. We're running a little bit late, so we'll make a quick start. If we can have the first speaker slide there. I'm not going to read through everything like they do here. It's a huge amount there, as you can imagine. Good friend of mine and colleague, Sam Griffin from UK at Cambridge. He has been working in the prevention group of the MLC unit since 2005, published huge amount of publication on prevention, particularly of diabetes, and has a great interest in behavioral change of people to improve their lifestyles. And Simon, today you're going to be talking about metformin and cardiovascular disease, so we look forward to that.
So, can you hear me okay? Yes, at the back. Great. Thank you, Kamlesh. Thank you particularly, Bansi, for the invitation to make my first visit to your beautiful country, India, and to talk about the impact of diabetes prevention on cardiovascular disease, and in particular focusing on metformin. So if you want to reduce cardiovascular disease relating to diabetes and metformin, you can do that. Thank you. You could do that by focusing at one end of the disease trajectory, where people have got existing cardiovascular disease or they're at high risk. Or, as Yajnik suggested we do this morning, you could go further upstream and target dysglycemia earlier in the disease trajectory. And I'll give you a spoiler alert that one of my main conclusions is that the quantity and quality of the evidence diminishes the further upstream that you go. So some context, the association between hyperglycemia, in this case glycated hemoglobin, and cardiovascular disease is linear. So even below the somewhat arbitrary diagnostic threshold for diabetes, there is no threshold for cardiovascular disease in HbA1c. And so it's reasonable to assume that interventions to lower glycemia would lower your risk of cardiovascular disease across the whole trajectory. So let's look at some data, mainly from trials and meta-analyses. So first thing I want to provide some additional context is that, as the CINO trial demonstrated, and you've seen this slide earlier, among patients with type 2 diabetes and microalbuminuria, intensive treatment of multiple risk factors halved risk of CVD and premature mortality over 8 and 13 years respectively. So this reminds us that actually you get a bigger bang for your buck by treating blood pressure and cholesterol rather than trying to lower glucose. So what about the prevention of diabetes among those at high risk? So several studies have shown that diabetes is preventable or can be delayed. This was the Finnish diabetes prevention program. And it can be prevented or delayed if you take people with impaired glucose tolerance and you allocate them to intensive lifestyle approaches targeting diet and physical activity. The behavioral interventions have a sustained or legacy effect beyond the end of the active intervention period, which in the case of the Finnish study was 4 years. So did the prevention of diabetes through lifestyle interventions then result in fewer cardiovascular events? Well, over a 10-year post-trial monitoring period in the Finnish study, the Finns followed up about 97% of participants, and the intensive behavioral intervention was not associated with a reduction in cardiovascular risk, albeit the participants in the intervention group did have a modeled cardiovascular risk that was equivalent to the background normoglycemic population. However, in the 30-year follow-up of the DASG Chinese cluster randomized diabetes prevention trial, in which people were allocated to diet, physical activity, or diet plus physical activity for around 6 years, there was a significant reduction in cardiovascular disease and a number needed to treat of only 9, with larger effects among women than men. So as well as lifestyle, it is possible to prevent diabetes through the use of medication among people with IFG or IGT. Now, by definition, any drug that lowers glucose will reduce diabetes incidence because diabetes incidence is defined by glucose. So participants are effectively taking a diabetes treatment that lowers glucose to prevent the onset of diabetes and the need for diabetes treatment to lower glucose. So it's philosophically challenging. Nevertheless, the question is whether the use of medication to prevent diabetes has a sustained or legacy effect and whether it reduces cardiovascular risk. So for rosiglitazone, the reduction in diabetes incidence disappears the moment that the medication has stopped. Furthermore, if you believe Steve Nissen's meta-analysis, the rosiglitazone actually increases the thing we're trying to prevent by preventing diabetes. In other words, it might increase cardiovascular risk. So what about metformin? So its history is linked to Galiga officinalis, or goat's rue, which is a hardy perennial which blooms in summer. It was a traditional herbal medicine in Europe, and it was found to be rich in guanidine, which in 1918 was shown to lower blood glucose. But it was discontinued due to toxicity and the increased availability of insulin after Banting, a family doctor in Canada, discovered it. Now, metformin was rediscovered in the search for anti-malarial agents in the 1940s. And during clinical tests, it proved to be useful to treat both influenza and lowering glucose. So this property was pursued by a French physician called Jean Stern, who first reported the use of metformin to treat diabetes in 1957. But metformin received limited attention as it was less potent than other glucose-lowering drugs, such as fenformin, and it also was associated with fenformin's adverse effects. So fenformin tended to cause lactic acidosis, and metformin got labeled with that risk, and so was dropped. The ability of metformin to counter insulin resistance and address adult onset hyperglycemia without causing hypoglycemia gradually gathered credence in Europe, and so metformin started to be increasingly used. It was finally reintroduced into the USA in 1995, so they took a little while to catch up. Long-term cardiovascular benefits of metformin were demonstrated in the UK PDS trial in 1998, providing a rationale to adopt metformin as initial therapy. And 60 years after its introduction to treat diabetes, metformin has become the most prescribed glucose-lowering drug in the world, with the potential for further therapeutic applications, such as in reducing cancer recurrence. It has multiple mechanisms of action, and I've listed some on there. And for some of those letters, I even know what they stand for. So, what about the Indian Diabetes Prevention Program, which you'll know better than me? People were allocated to metformin 250 milligrams twice a day, as well as the lifestyle arms, and that reduced incidence by 26% among 531 people with IGT, based on 2 oral glucose tolerance tests. So the metformin was similar to the lifestyle intervention. And the trial had 95% follow-up with 6 monthly OGTT, so robust outcome assessment. However, the trial was clearly too small to demonstrate an effect on cardiovascular events, although it's notable that there were no cardiovascular events in the metformin arm. So what about in the US, the Diabetes Prevention Program? Over 3,000 people with both IGT and IFG were allocated to placebo, lifestyle, or metformin 850 milligrams twice a day. And diabetes was diagnosed by annual oral glucose tolerance test and semi-annual fasting glucose tests. And it required confirmation by a second test. So metformin reduced diabetes incidence by 31%, which is an NNT of 14 over 3 years, and was described as cost-saving in the health economic analysis. So unlike rosiglitazone, both lifestyle and metformin appear to have legacy effects in terms of prevention of diabetes. And that was in spite of the lifestyle intervention being offered to the other groups at the end of the initial trial period, and also in spite of a degree of crossover of metformin that I will come back to later. So the question is, does metformin reduce cardiovascular disease among patients with diabetes and among patients with people with so-called prediabetes? Well, there have been a number of trials in people with diabetes and also in meta-analyses of these trials. And these trials and meta-analyses differ in their patient inclusion criteria, in their comparison groups, in their sample sizes, and in their duration of follow-up. The trials are very different to the more recent cardiovascular endpoint trials of glucose-lowering drugs. And for many trials, cardiovascular disease endpoints were actually reported as adverse events rather than the primary outcome of the study. Most of the studies didn't have a placebo group. And unsurprisingly, the meta-analysis is quite dominated by the UK PDS trial. So I'm quickly going to take you through the examples of the meta-analyses in date order. So Selvin reported a significant 26% reduction in cardiovascular disease mortality and a non-significant 15% reduction in cardiovascular disease morbidity of the use of metformin in people with diabetes. Lamana reported a non-significant 6 point in the US diabetes prevention program. There was no effect on cardiovascular outcomes. The diabetes prevention program observational study featured unmasking. The lifestyle intervention was offered to the other groups in an abbreviated form, and metformin was offered in an unmasked way to the other groups. So all groups had intensive treatment of cholesterol and blood pressure, and much more intensive than compared with the UK PDS. 70% of participants took at least 80% of the pills assigned, but this fell to only 49% over the whole of the observation follow-up period. So by the end of the DPOS, 33% of the placebo and 27% of the lifestyle intervention groups were treated with metformin by their healthcare providers. But there was still some degree of differentiation in the trial. So the metformin arm had 10.7 metformin years. The placebo group had 2.3 metformin years, and the lifestyle intervention group had 1.7 metformin years. So much fewer than might have been originally intended. And as I mentioned earlier, the metformin trials are different from the more recent cardiovascular endpoint trials. Metformin is, of course, off patent and the recommended first-line diabetes treatment worldwide. So it's a real challenge to try and set up a cardiovascular endpoint trial for people who haven't got diabetes, where the key uncertainty lies. So in the absence of a metformin trial unit, lowering of HbA1c, that was associated with a 37.8% lower risk of coronary artery disease. So the Mendelian randomization fans would argue that it looks like metformin would reduce coronary artery disease in people who haven't got diabetes. We did try and do a trial of metformin in people with non-diabetic hyperglycemia, and Kamlesh was one of the investigators. We completed the feasibility study, and it was going to have a cancer and cardiovascular endpoint, 24,000 people. And we were only asking for around £13 million to do this trial, which would cost a drug company more like 500 million. But unfortunately, the funders wouldn't give us the money. One thing that we did note was that metformin was associated with a reduction in B12, which one should bear in mind when prescribing a preventive drug to people who haven't got a disease. Fortunately, the American funders in the Veterans Administration system were more enlightened, and a metformin cardiovascular endpoint trial called IMPACT is underway, albeit it's different from GLINT in that participants have established cardiovascular disease, which will increase the event rate and mean they can have a smaller sample size, and they also have pre-diabetes. It's due to report in 2029. So to summarize, type 2 diabetes can be cost-effectively prevented by lifestyle interventions and by metformin in people with IGT. The effects of lifestyle interventions and metformin on diabetes incidence were sustained and are associated with a range of improved outcomes that I didn't cover today because my focus was cardiovascular disease. The long-term impact of diabetes prevention by lifestyle change, the long-term impact on cardiovascular disease, were seen in China, where perhaps people adhered to the lifestyle intervention better than in America or Finland, but they weren't seen in the other diabetes prevention programs. Metformin is the recommended first-line treatment for type 2 diabetes, and it's licensed worldwide for the treatment of diabetes and, in some countries, pre-diabetes. The impact of metformin on cardiovascular disease risk among people without diabetes does remain uncertain, but evidence from observational studies and from Mendelian randomization studies would suggest that it would be an effective treatment. Alongside treatment of blood pressure and lipids, individuals with prediabetes should be offered lifestyle interventions, and if they're unsuccessful, they should be supplemented by use of metformin. But to reduce the burden of cardiovascular disease related to hyperglycemia, a complementary approach is needed to shift the population distribution of underlying determinants of hyperglycemia. And my last comment refers to the prevention paradox. While those at the extreme end of the distribution for cholesterol, blood pressure and glucose are at highest risk, there are few of them. Consequently, the majority of heart attacks occur among people at moderate risk with moderately elevated blood pressure, cholesterol and glucose. So if we want to reduce the population burden of cardiovascular disease, the distribution needs to be shifted to the left. And this phenomenon was described by the late Geoffrey Rose. Unfortunately, the distribution in most of the world is moving to the right. So this slide shows rural and urban Cameroonians and Jamaicans in Jamaica and Jamaicans in Manchester. And you can see that the fasting plasma glucose is shifting in the wrong direction. So if we want to do something about that, then we need to target the underlying individual and collective level influences on hyperglycemia. And we need to do that at a generational level, as we heard this morning, because leaving it until people are at high risk is leaving it too late. So thank you very much for your attention, and I look forward to discussing your questions.
Thank you, as always, eloquent presentation, Simon. The floor is open for questions. While we're waiting, maybe I'll ask regarding metformin in people at high risk of diabetes. You mentioned that it could be offered. Is it offered? It'd be good to get your views whether it's offered that much in the UK compared to India.
Well, as I said in the relevant slide, I think that lifestyle interventions are what we should recommend. We should be much more aggressive at implementing them. We should be much more enabling of people to achieve them. And then if we're still not getting the results that we want, then we should revert to metformin. My philosophical position is that diabetes, in a sense, is not a disease. It's a societal phenomenon. And to treat a societal phenomenon with a pharmaceutical product may not be the most sensible strategy. But I'm also about harm reduction, harm prevention. And so if people can't move about more and eat less, then they should be offered metformin.
And what proportion in the UK, do you believe, what proportion of people at high risk would be on metformin?
Well, I would say, unfortunately, our behavioral interventions to achieve weight loss, sustained weight loss, are not very effective. We can achieve weight loss with behavioral weight management programs, but achieving sustained weight loss is more challenging. And so I would say if we were really going to overcome our therapeutic inertia, which I know you've written about, then probably a lot more people with so-called prediabetes should be offered metformin.
What proportion what portion in India would be on metformin if they've got prediabetes?
Almost 90%.
Yeah. But of course you did the trial here, you know, Ramachandran's Indian Diabetes Prevention Trial. And that's why perhaps if we'd had the trial in the UK, the GLINT trial that we tried to set up, then that might have promulgated much more prescribing of metformin.
But the trial by Ramachandran IDPP was actually it used much lower dose. It used 500 milligrams.
Yeah.
Okay. Any more questions at all in the panel? No.
So thank you for a brilliant presentation. So we come to the next speaker. It's my pleasure and honor to introduce Professor Michael Izquierdo. Hope my pronunciation is correct. Will do. And he's full professor of sports science in the Department of Health Science at Public University of Navarra. He's head of research unit of physical exercise, health and quality of life at Navarra Biomed, and has appointment as professor of sports biomechanics at the Center of Studies Spanish Olympic Committee. From 2005 to 2010, he was head of research studies and sports medicine center at Government of Navarra, and he has been part of some of the Olympics gold medalist teams
and he has won twice the European Championship medals along with the teams. He has published more than 470 original articles and supervised 30 PhD students. Over to you, Professor. Thank you.
Thank you. Thank you for the invitation to this fantastic country, India, and very nice to be here. So for the next few minutes, I will present the global consensus on optimal exercise recommendation for enhancing healthy longevity in older adults with sarcopenia. This consensus integrates decades of research to address a critical intersection between sarcopenia, diabetes, and aging. So let's explore how tailored exercise can transform outcomes in this vulnerable population. And I also hope that you enjoy my Spanish accent. So in the recent international exercise consensus just published 2 weeks ago, we provide an evidence-based rationale for using exercise and physical activity for health promotion and disease prevention and treatment in older adults. So exercise prescription in this case is discussed in terms of the specific modalities and doses that have been studied in randomized controlled trials for their effectiveness in attenuating physiological changes of aging, disease prevention, and or improvement of older adults with chronic disease and disability. Thus, this consensus aims to enhance the efficacy, applicability, and comprehensiveness of exercise programs to better meet the current health challenge of older individuals face. So the human aging process is universal, is ubiquitous, inevitable, and decremental. Every physiological function is being continually diminished, and at around 20-30 years of age, humans have acquired all the physiological development that they will attain. From that stage, the aging process commences, although the rate of change is very heterogeneous. This process will continue up to 6 or 7 decades, ending in death. Evidence shows that being physically active and having a healthy diet coupled with no smoking and moderate alcohol consumption are integral to the maintenance of health and well-being in old age. In this is the best karma to prevent disease. The left-hand side shows a probable pathway for non-exercisers. These individuals are susceptible to exercise associated and also disease not associated with physical activity. Various pathological processes can cause physiological disruption. Exercise as therapy can potentially reverse some declines, but issues related to low cardiorespiratory fitness, low VO2 peak, muscle strength, power mass, low muscle mass, and functional capacity values may persist. The right-hand sides illustrate the role of physical activity as preventive medicine, emphasizing the preservation of effective, albeit gradually diminishing physiological functions. They are partially protected from exercise-associated diseases, but are equally prone to disease related to exercise. Both cohorts are experiencing constant decremental changes because of the inherent aging process, but at different rate due to their physical activity engagement. Sarcopenia, everybody here knows that affects between 10 to 7% of adults over 60, rising to 50% of those over 80. It is not just muscle loss, it is a driver of fragility, disability, and mortality. In diabetic population, insulin resistance accelerates muscle wasting, creating a vicious cycle. Addressing sarcopenia is non-negotiable for healthy longevity. Sarcopenia in diabetes is fueled by chronic inflammation, mitochondrial dysfunction, and anabolic resistance. Hyperglycemia impairs muscle protein synthesis, while neuropathy and vascular damage exacerbate functional decline. Exercise disrupts this cascade by targeting molecular pathways like mTOR and mPCAR. Both structured exercise and overall physical activity play important roles as a preventive strategies for many chronic diseases, including cardiovascular disease, stroke, diabetes, osteoporosis, and obesity, improvement of mobility, mental health, and quality of life, as well as reduction of mortality among other benefits. Notably, exercise intervention programs improve the hallmarks of frailty: low body mass, strength, mobility, physical activity, and cognition, optimizing functional capacity during aging. Physical activity, also particularly exercise, can reduce the burden of comorbidity, disability, and premature health death caused by incident disease, and is valuable for primary, secondary, as well as tertiary preventions. The figure that we saw in the consensus shows the major disease and syndromes for which exercise could serve as a preventive strategy or aid in disease prevention, secondary and tertiary prevention. The WHO recommends actively addressing these issues to promote healthy aging. Although the specific mechanisms and ultimate modalities of physical activity health benefits are not fully understood, evidence to date suggests that engaging in physical activity can sustainably enhance domains of intrinsic capacity. This, in turn, reduces mortality, promotes functional ability, and also healthy aging. However, not all physical activity is equally effective, as dose-response relationships and exercise modality-specific adaptation exist. There are associations between intensity, volume, and modality of exercise and many health outcomes. In a recent study, it has been shown that intensity distribution of physical activity may be more important for mortality reduction than the volume, and integrating physical activity of higher intensity into daily routines may optimize health. The modality of physical activity performance is also critical for intending health outcomes beyond mortality, as many exercise adaptations are modality specific. For example, for over 3 decades, anabolic exercises, such as high resistance training, has been recognized vital for maintaining or enhancing functional capacity in older adults, particularly those who are frail or with conditions as sarcopenia and osteoporosis, mobility impairment, or those hospitalized in resident care. Indeed, we saw 20 years ago that the progressive strength training program may lead to recover 20 years of functional capacity. In a couple of recent studies that we have performed in our hospital, published in JAMA Internal Medicine, our research group explored the possibilities of modifying traditional models of hospitalization in acute care of older units, but goes a step further by adding the individualized and adapted prescription of multi-component exercise to each patient. Our studies show that an individualized multi-component exercise intervention, including high-intensity resistance training exercise, performed during only 5 to 7 days, provides a significant benefit over usual care and can help to reverse the functional decline associated with acute hospitalization in older adults. Also, an individualized multi-component exercise training program with a special emphasis on muscle power training was shown to be an effective therapy for improving lower extremity muscle power production at maximal loads and maximal strength in diabetic and oncology older patients during acute hospitalization. We have also shown in the mid-frail study, a cluster randomized multicenter clinical trial conducted in more than 70 trial sites across 7 European countries, that we recruit 964 participants, good results. We aimed to evaluate the effectiveness of a multimodal intervention on functional performance in frail and pre-frail participants aged more than 70 years with type 2 diabetes. We have demonstrated that a 12-month structural multimodal intervention program across several clinical settings in different European countries led to a clinically relevant and cost-effective improvement in the functional status of older frail and pre-frail participants with type 2 diabetes. Everybody knows already that skeletal muscle mass has been described as an endocrine organ that can produce and release myokines into the bloodstream, where they function locally or systemically to elicit a myriad of beneficial effects, including decreased inflammation and insulin resistance. The anti-inflammatory milieu created by exercise training is believed to be mediated largely by myokines, which protected arteries against the progression of atherosclerosis and stenosis, and also preserves the stable phenotype of pre-existing atherosclerosis plaques. In this context, low muscle strength in adults is associated with the development of cardiovascular disease and cardiovascular disease-related outcomes, including death. In turn, the strength of skeletal muscle largely depends on its mass, and low muscle mass is similarly associated with an increased risk of cardiovascular or related outcomes, especially in older individuals. Because skeletal muscle mass is the major site of dietary glucose utilization and myokine production, loss of this tissue contributes to dysglycemia and insulin resistance, as well as myokine dysregulation, which in turn are associated with mitochondrial and endothelial dysfunction and left ventricular hypertrophy. The good news that we have is that resistance training has a tremendous therapeutical potential, particularly in patients aged more than 60 years with cardiovascular disease, as it can counteract loss of skeletal muscle strength or mass while improving at the same time glycemia control and decreasing visceral fat. Indeed, increases in muscle strength resulting from resistance training might also prevent cardiovascular disease itself. Physical exercise training favors large and positive change in exercise concentrations in adults living with type 2 diabetes. Changes in those exercises are related to improvements in clinical metabolic parameters, as glycated hemoglobin, waist circumference, and body mass. We recently identified an optimal dose for exercise prescription in this clinical population. An optimal dose for exercise prescription, any form of exercise at moderate or vigorous intensity, with a program lasting longer than 24 weeks, with at least 3 sessions per week and more than 60 minutes per session, induce significant improvements in exercise in adults living with type 2 diabetes. In turn, these changes are associated with improvements in clinical metabolic parameters. In the recent international consensus statement, we provide an evidence-based rationale for using exercise and physical activity promotion and disease prevention and treatment in other adults. Actually, the utility is fivefold: to exploit its potential to prevent disease, but also to serve an adjunct to effective medical and surgical interventions, to substitute for hard-dose treatments, to counteract side effects, as well as to become the mainstream in the management of conditions for which there is no other effective treatment. Indeed, actually prescribing non-evidence intensity and volume should be similar to use the placebo and suboptimal medication dosage, especially concerning progressive resistance training, where often low intensity and non-progressive exercise is prescribed. This figure also compares the efficacy of exercise and pharmacological treatment across 4 healthy domains critical to aging populations. Exercise demonstrates superior effectiveness in managing sarcopenia, frailty, and functional decline, while pharmacotherapy excels in acute symptomatic conditions like hypertension. Integrating both strategies optimizes outcomes for chronic disease such as diabetes and osteoporosis. Indeed, we don't have medications that improve physical fitness, functional capacity, or alleviate fragility. In an aging population, polypharmacy and chronic disease management are also critical concerns that significantly impact health outcomes. The intersection of medication and the use of physical activity and exercise offer a promising approach to enhancing the well-being of the older adults. An integrated strategy combines exercise as well as pharmacotherapy can optimize the vitality and functionality of older people while minimizing adverse drug reactions. For example, we know that aerobic exercise can reduce the severity of depression and anxiety, often managed with psychotropics, while improving cardiovascular health. Also, resistance training can mitigate the muscle wasting effects of corticosteroids and enhance bone density, while simultaneously addressing primary and secondary health concerns. Metformin's blood aerobic gains and muscle mass gains, while compensating with high-intensity interval training, GLP-1 agonists aid weight loss but risk muscle wasting, counter with high protein diets and progressive resistance training. So exercise let us reduce insulin doses while improving glycemic control. The BB multi-component program that tomorrow we will give a short workshop on this topic is a good example, an excellent example of an evidence-based program. These multi-component programs include flexibility, resistance training, balance exercise, and cardiovascular activities that are customized to the individual's functional capacity. BB is an example of a program that meets this criteria and has been shown to be effective in promoting physical function and reducing falls and frailty in older adults. To summarize, a healthy lifestyle can add years to life and also life to the years, and it is in our hands. Exercise is not a single medication, but should be seen as a medical intervention with a myriad of modes and dose combinations, which have highly differentiated effects on the body's system. The treatment with physical exercise should be chronic, with an adequate dosage that is never just walking. We are not made for exercise to be a pastime. Indeed, it's something that we do to survive. Physical exercise as medicine is much more than just walking, which is not enough, and it shows a dose-response effect and can be individualized. So the lack of the adherence to evidence-based exercise intensities and volume is equivalent to the unacceptable practice of prescribing ineffective doses of medication. In pharmacology, the placebo effect is often avoided, but it seems to prevail in exercise prescription, especially concerning resistance training. Also, as a practical application of the consensus, I would like to give you some tips. Progressive resistance training is the primary approach. Start early and prioritize intensity training between 70 and 80% of 1RM for optimal benefits. Incorporate also aerobic resistance and balance exercise to enhance overall physical function. Evaluate for neuropathy and cardiovascular disease, adapting exercise to ensure safety. Leverage apps and wearable devices to monitor progress, improve compliance. Optimizing exercise in relation to pharmacotherapy is very important. Metformin, for example, may reduce aerobic capacity and adaptation to progressive resistance training, and consider high-intensity progressive resistance training or high-intensity interval training can be useful. Also, schedule exercise appropriately after meals to support glycemic balance is important. This is not optimal, it's just a standard care. So let's make exercise prescription as a routine as metformin, train clinicians, fund community programs, and advocate for policy change. Together, we can turn sarcopenia from a death sentence to a manageable condition. Thank you for your attention.
Thank you for a very informative and eye-opening presentation. So usually, we are talking of a moderate exercise for everyone to maintain a good health, which unfortunately India we have more of central obesity and more of sarcopenia. We have population which has so-called Asian Indian phenotype with less muscle mass and more, fat. So what kind of exercise you think would be optimum for
first of all,
Asian Indian population?
Thank you for your question. First of all, I would like to emphasize that exercise is not solo to prevent. Exercise, resistance training, aerobic capacity, cardiovascular training must be a part of the therapeutic intervention in the medical treatment. It's even much more important of the use of some drugs. This is important. So exercise has different areas of affection. Secondly, it's important to say that the physical activity, 30 minutes walking and 10,000 steps is not enough. Is not enough. This has been shown in the literature that this kind of intervention can reduce mortality, but nobody here is thinking in the mortality right now. So to reduce comorbidities, cardiovascular disease, obesity, we must increase and use a proper stimulus. The proper stimulus, I have been some tips there in the presentation, is resistance training between 70 and 80% of maximal RN, and also aerobic cardiovascular disease much more higher than just walking. I can tell you this in 1 minute. Tomorrow we will explore these possibilities more in depth in the workshop that we have planned here.
So what would be kind of a balance, exercise prescription for everybody, X amount of aerobic and Y amount of resistance training done on Z amount of days every week?
Yeah, actually we know that we have to make at least 5 days of cardiovascular training and 2-3 days of muscle strength all the week.
And how much time?
How much time? Actually, the progressive resistance training is not a question of time, it's a question of intensities, 4-5 exercise, 3-4 sets of 8 to 10 reps at intensities between 50 and 80% of 1 RMs. And regarding cardiovascular training, we know that in training about 5 to 7 meds, between 60 to 80% of the VO2 max, it's good, 20 to 30 minutes. Nowadays, we even know that in special populations, it's recommended to make high-intensity interval training that suppose short bursts of 2-3 minutes at high intensity. In doing so, I cannot promise a lot of things if you also not control the food, but I can tell you that you can get good results.
Thank you. We have a question from Professor Wasim Hani.
Oh, thank you, Bridge. Wasim Hani from UK. I think excellent talk. Thank you very much. Now, one of the challenges in terms of sarcopenia and muscle strengthening is, as you mentioned just now, is the diet. It is about diet, you're eating your diet, and about what we call high protein intake. Now, one of the challenges we have got in a kind of a South Asian Indian cohort is the quality of protein, because these diets are very rich in carbohydrates and very poor in protein, and the quality of the protein again is not very good. Now, along with muscle strengthening, do you think that we need to emphasize the importance of diet? And this is becoming more important because now we have got anti-obesity agents, the GIPs, and the rest, which are causing massive weight losses in our patients, and they're getting sarcopenic. So should the exercise be accompanied by dietary advice as well?
Not at all. Indeed, I not agree. Sorry for my Spanish. We are talking like that. With the first thing that you mentioned, there is no evidence in the literature that resistance training plus protein is much more better than resistance training alone. So, indeed, I present one paper, very nice paper of New England Journal of Medicine, 30 decades ago, probably you know, Maria Fiatarone, showing that exercise, resistance training is a very recommended intervention for older adults, and that if you include nutrition, in 1995 nutrition was not protein supplementation. Nutrition was normal protein, carbohydrate, and fat, increased a little bit more than enhanced. So, telling that and reviewing the literature, there is not much more effect if you include protein. Indeed, much more noise has been done about protein because the pharmacology companies want that you include protein with resistance training. But in the literature, 5-6 studies with several with acute patients have shown that. But I don't recommend a special protein supplementation. Of course, I recommend a good and balanced nutrition that has to incorporate 2.2 grams per kilo of body mass of proteins or so in other adults. I am not an expert in that also.
Thank you. Thank you.
Yeah, just one quick question we can have. How about walking the stairs instead of walking on the level ground? Climbing the stairs.
So, what is going to be, Professor, what is going to be more effective, climbing the stairs or walking on the level ground?
Going upstairs.
Depending on your physical fitness. For me, it's not good walking and it's not good climbing stairs. I have to run. Probably for you, I don't know, it's not working at all. Maybe you have to run because you are here, and maybe it's good climber stairs. Depend on the physical personal levels of each individual. So if for you climbing stairs is between 7 to let's say 8 meters, is good. For me, it's running at 13 kilometers per hour. So climber stairs is just nothing. I don't know if I can explain you that.
So basically, you know, what is your level of accustomization with the exercise? If you are with climbing stairs, your heart rate is not going up. You are so used to it. You need a more intense exercise.
Yeah.
I think that's
for an older adult, very older adult in the hospital. Maybe climber stairs is very high in stimulus, but for you and for me, there is very low stimulus.
Yeah. So it's the kind of activity you are used to. So thank you, sir, for a wonderful presentation.
Thank you.
And we move on to next session. I will give it to Professor Atul Kalan to invite the next speaker.
Good afternoon. I'm introducing Dr. Ketan Dhateria. If you're practicing in UK, he doesn't need any introduction. If you've been to any of the diabetes forums, conferences, Ketan either is chairing it or leading it. If I sum it up, he's currently the chair of Association of British Clinical Diabetologists, is also the immediate past chair of the joint British Diabetes Society Inpatient Care Group. We all have grown up reading his inpatient guidelines in all the hospitals we work in, and it's saved lives. You know, if ever in doubt about inpatient diabetes management, special group, go on the JBDS website. These are available online freely. He's also the chair of examining board for the UK Specialist Clinical Exam in Diabetes and Endocrinology, and was inaugural chair of the European Board Examination in Endocrinology, Diabetes and Metabolism. So I'm not taking more time, Ketan. I'm handing the baton to you.
Thank you so much. जब मैं बात करता हूं, आपको पता चलेगा कि मैं यहाँ का नहीं हूं. मैं इंग्लैंड में रहता हूं, लेकिन मेरी राजस्थान में पैदाइश हुई थी और मेरा दिल है हिंदुस्तानी. So, thank you. I'm going to talk to you today about another global consensus guideline, but this is on the global consensus on the management of hyperglycemic emergencies. These are my disclosures, none of which are relevant to anything I'm going to say today. I'm going to give you some history on the management of diabetic ketoacidosis before we start, so you understand where we're coming from. So as we all know, diabetes, type 1 diabetes, has been universally fatal, or was universally fatal for millennia. And it took some time. There was a chemist in Germany who identified acetone in the urine in the people who eventually died from what we now know as diabetic ketoacidosis. And in 1870, at the Royal College of Physicians in London, a gentleman described two different kinds of diabetes-related coma. The first one was in thin people who died very quickly, having lost a lot of weight and breathing very deeply. And we will all recognize that as the Kussmaul breathing. And the other kind of diabetic coma was those people who were very big, who gently just faded into a coma and died eventually. And we recognize that as HHS. But he didn't know that at the time, but he described both of those different kinds of coma. It was only after that did Kussmaul describe his characteristic breathing in people that we now know as having DKA. Of course, in 1921 and 1922, the whole world changed and insulin became available. And then there was an argument on how to treat people with DKA. And in the United States, we had Elliot Jocelyn in Boston, who started treating individuals and showing that their mortality went down very significantly, and he was saving lives. But he was giving very gentle fluid replacement. And then on the other side of the Atlantic, in London, in the United Kingdom, there was a gentleman called R.D. Lawrence, who himself had developed type 1 diabetes and survived because he developed it literally within a few months of insulin becoming available. But he was giving lots and lots and lots of fluid very aggressively. So there was an argument on how to do things and how to save lives. And then in the 1940s and 50s, different people were reporting how to do things differently. And there was a group that they were dividing between North America and the UK who were publishing the most. And they showed that and they were giving between 500 and 2,000 units every 24 hours to try and save their life. And depending on the likely prognosis, if this person was going to die within 6 hours, they'd give them 2,000 units. But if they were going to die in 24 hours, they'd give them 500 units. But still, that's a lot of insulin. And then in the British Medical Journal in 1977, 3 papers back to back were published showing that you could use low dose intravenous insulin to successfully bring down ketones and bring down glucose. And that's why we've moved on to the low dose intravenous insulin infusion. That was then confirmed by a paper in the New England Journal of Medicine by a chap called Abbas Kitabchi. And then around this time, there was this issue about cerebral edema. How much fluid do you give to somebody, and which fluid, and how fast? Because there was a suggestion that in children, if you gave a lot of normal saline, that they were at risk of developing osmotic demyelination and cerebral edema. In 2001, the American Diabetes Association published their first consensus document on the management of hyperglycemic crises, and then it was updated in 2006 and then in 2009. In 2011, I was involved in the first guideline published from the UK, which I'll talk to you about in just a moment. And that was different to the American guideline, and I'll show you why in just a second. Moving on into the early part of this century, we had the EMPA-REG published in 2012, and then the case reports and the case series and the dangers of SGLT2 inhibitor-induced DKA started becoming more prominent. I then wrote an editorial in the Lancet, and I'll talk to you about that, saying why the American Diabetes Association guideline was rubbish and needed to be changed, and I use that word truly as rubbish. Then we had the first randomized control trial in the use of fluids in children. You can see how old it was because it still says Lehman Brothers as the sponsor for this match. And when I was going to this rugby game, a colleague of mine who is an anaesthetist kept on asking me, why do diabetes doctors use normal saline, 0.9% sodium chloride solution to treat DKA? And I said, because that's what we always do. And he said, no, why? So he got me thinking. So I went away and read about why DKA is treated with normal saline. And I wrote an editorial, which was published in the British Medical Journal, saying normal saline should be the fluid resuscitation of choice in people with DKA. And this editorial is the single most, this paper is what has given me the most hate mail from all over the world, usually from anaesthetists saying, I have no idea what I'm talking about. But as a result of this, I got invited to join an organization called Joint British Diabetes Societies for Inpatient Care, and the writing group for writing the first guideline on the management of DKA. And what I wanted to do when that was published, and it was taken up very quickly all over the United Kingdom and in many parts of the world, but we didn't know whether it actually worked. So what I did is that we did a national survey in 2014, so 3 or 4 years after this was first launched. We surveyed the whole of the UK, and we looked at over 250 cases of DKA to find out whether it worked. And what it showed was there were problems. And using the guideline that I and others had written, that a large proportion of people developed hypoglycemia and hypokalemia. So that's why we changed the guideline at the time to say if your glucose dropped below 250 milligrams per deciliter, you add in dextrose and you reduce the rate of intravenous insulin infusion to 0.05 units per kilo per hour to help prevent the hypokalemia and hyperglycemia. But I want to come back to the ADA. So this is the 2001, 2006 and 2009 documents. And this is what they said. This is how you diagnose DKA according to the Americans. Now, the first thing I would say is this is rubbish. And the reason it's rubbish is because it says you've got glucose above 200. You've got or a history of diabetes. You've got to have the K and you've got to have the A. That's how you diagnose DKA. DKA. It's not difficult, but the Americans don't do ketones. So That's the problem. The Americans had not insisted on having D. So you have to have a glucose of 250. They had no idea about ketones. They didn't really use ketones because the Americans do not have bedside ketone monitoring. It's a laboratory test. And they use urine ketones, which is useless, essentially, unless you don't have anything else. And you've got to have the A. You've got to show that they've got an acidosis. And so they had lots of problems. And that's why I wrote this editorial in the Lancet Endocrinology saying that they needed to update it. And eventually, they agreed. And so what we did, we started getting together in 2022. It's a consensus guideline between the Americans, the Europeans, the UK, and the ACE and the Diabetes Technology Society. And these are the co-authors. And you may have seen these published on the same day in Diabetologia and Diabetes Care with Guillermo Amperes. If you're into inpatient diabetes, he's the global god of inpatient diabetes as the first author, and I'm the last author on this document. So what we wanted to do is just provide up-to-date guidance, the most up-to-date evidence-based information on how this condition should be managed, and also for everybody managing this condition, right from the front door in the emergency room all the way to discharge from the general wards. And the way the Americans write it is have to list a series of questions, and these are the questions, and I'm not going to go through all of these for lack of time, but there's just a few things that I'm going to go through. So pathophysiology, you'll be glad, has not changed in DKA. I'm not going to go through this in any detail. Essentially, this diagram is freely available to download from the Diabetes Care or the Diabetologia website. It's free. Even the guideline is absolutely free. Essentially, you have low levels of insulin. In DKA, you have so little insulin that you allow ketosis. The ketones form very quickly, so you develop ketoacidosis. In both HHS and in DKA, because of the decreased glucose utilization, you develop hyperglycemia. And with the hyperglycemia, you end up getting an osmotic diuresis. That leads to hypovolemia, decreased renal function, and that leads to problems. And so you have this balance between DKA and HHS. And how does it treat it? Well, again, this is where there's consensus and not consensus. So, of course, fluids. You have to determine the hydration status first of all. If you're somebody severely hypovolemic, you need lots of fluid. Mildly hypovolemic, you can decide how much you want to give. And of course, in HHS, if they've got cardiac compromise, you need to get them to an intensive care unit, ideally with a consideration of whether they need cardiac pressors. You give them a certain amount of fluid, depending on their hydration status, and we can say you can either give 0.9% normal saline, or you can give a balanced crystalloid, because there's data to show that balanced crystalloid may improve the outcomes a bit faster because you don't get the hyperchloremic metabolic acidosis that you get with giving lots and lots of normal saline. And then when you reach a glucose of less than 250 milligrams per deciliter, you add in dextrose to act as the substrate for the insulin that you're having to give if they're still ketotic. With insulin, you've got either mild DKA or moderate or severe or HHS. And if you've got mild DKA, you can treat it with subcutaneous insulin, because this is written for low resource environments and high resource environments where you can, if they're paying for their own care, it's cheaper for them to be treated in the emergency room. So you can give, but it's at the same dose. Of course, if you've got moderate or severe DKA, you want to give intravenous insulin. If you give a bolus, it's 0.1 units per kilo, and then followed by an infusion of 0.1 units per kilo per hour. Or if you're giving it subcutaneously, it's again 0.1 units per kilo per hour, or 0.2 units per kilo every 2 hours. And if you've got HHS, you have to give them fluids first. You only give people fluids when their glucose stops dropping. And the reason for that is because if somebody's got fluids going in, their osmolality comes down. If you've got insulin coming down, their osmolality comes down. If you reduce the osmolality too quickly, that then leads to central pontine demyelination. So to stop that from the risk, you give fluids first, only give the insulin when the glucose stops dropping, although some people, certainly in the United States, would give both. And the rate of insulin infusion is a little bit lower. It's 0.05 units per kilo per hour. And then when it starts dropping and when you get to resolution, you can change things. Now with potassium, you have to ensure they've got adequate renal output, and that's 0.5 mils per kilo per hour. If they've got a potassium which is low, do not give potassium, because the moment you give insulin, it's going to drop it further, increases the risk of cardiac arrhythmias. If it's high, then you can just give the fluids and the insulin, but don't give extra potassium. You want to aim for a potassium between 3 and 5, and then you can start adding the potassium into the replacement fluids. And there's advice on how frequently to check their electrolytes. It says do not use bicarbonate, you don't need to use it unless they've got a very profound renal failure, and you do not need to give phosphate at all, usually. So these are the new diagnostic criteria. This is very different from the old American guideline. It's a glucose above 200, it's a ketone above 3 millimoles per liter or more than 2 pluses in your urine, and it's a bicarbonate of less than 18 and or a pH of less than 7.3. So those are the changes. Just briefly, severity, we've talked about severity. I'm not going to go into that too much. This is the criteria for resolution: no ketones, pH of greater than 7.3, and glucose less than 200 milligrams per deciliter. Just in the last few seconds, I'll talk about HHS. It's an osmolality above, either calculated or total above 300 or 320. No acidosis, no ketosis. That's how you diagnosed HHS. What's the criteria for resolution? It's an osmolality of less than 300. Hypovolemia, so you've got a good renal output. Cognitive status, which is improved, and a glucose of less than 7.3. There remain lots and lots and lots of unanswered questions in inpatient diabetes. If you are doing any work in inpatient diabetes, feel free to publish it and ask me as a reviewer. I'm going to skip the next few slides, but if anybody is interested, this is the most comprehensive review in DKA that I've ever seen, because I wrote it, and I will leave it there. So I'll say thank you very much for your attention.
House is open for the questions now. Anyone? So, Ketan, what's your take on the euglycemic ketosis we keep on hearing? And I get lots of phone calls from my anesthetist colleagues asking me about guidelines related to it.
Yep.
And perioperative management, they are over-testing ketones?
No, you can't over-test for ketones. If you think you've got euglycemic decay, so that's why we said, it's either a glucose above 200 or a history of diabetes. So the most common reason why somebody gets is SGLT2s. Nowadays it's SGLT2s. Okay. So what is the indication for SGLT2s? It is diabetes. Of course, now it's indicated in renal impairment and in heart failure. But if you've got renal impairment or heart failure, your risk of having diabetes is actually already quite high. But euglycemic or normoglycemic ketoacidosis in people with renal failure and heart failure is reported, but it's uncommon because you have sufficiently high insulin levels to suppress ketones. But it is reported, there are a few case reports. But if you've got diabetes, checking for ketones every time. And the treatment, of course, is you give them saline, but at the same time you give them dextrose. And at the same time you give them a fixed rate intravenous insulin infusion. It depends. Now, you can either, depending on the degree of acidosis and ketosis, you can either use it at 0.1 units per kilo, treat them as DKA, but you're giving them dextrose to act as the substrate for the insulin that you're infusing, so they don't become hypoglycemic. But treat them with fluids, insulin, the same as you would do anybody, but you have to give them dextrose as the substrate for their insulin.
My question is, ketones are bound to appear if we are starving people in a perioperative period. So at what level we start to think that this is... And how do we attribute it to SGLT2 then?
So again, this is completely separate talk, okay? But perioperative management of GLP-1s and SGLT2. So I have just published with others a Delphi consensus document, and we strongly disagree with the Americans about stopping GLP-1s and stopping SGLT2s in the perioperative period. The Americans say you should stop it 3 or 4 days before because that's the half-life because that gets rid of them. We say no, you stop it on the day of an operation and the day before your operation. And the reason for that is because if you think the half-life of these drugs is about 12 or 13 hours, if you stopped it the day before, it's less than you've got almost nothing left in your system. If you stop it before, 3 or 4 days before, then your glucose concentrations go up, and therefore the risk of cancelling an operation because you've got preoperative hyperglycemia is very high. And nobody wants to cancel the elective operation. So we have said that, and of course, if you've got heart failure, then you get worsening heart disease and heart failure and so on. So in the UK, and this is free, it's online, it's in Anesthesia, the journal Anesthesia published a couple of weeks ago, saying you do not need to stop GLP-1s ever, and you do not need to stop SGLT2s except the day of and the day prior to an elective procedure.
I think the argument they were giving for stopping GLP was related to intestinal motility.
Yeah, but that's rubbish. And I'll give you an example why. Okay, if you're on semaglutide, top dose for diabetes is 1 milligram, and it's got a half-life of 1 week, and they say stop it 1 week before operation. If you stop it 1 week before, you'll have the same plasma concentration as somebody who has not stopped it, who's on 0.5. So what's the point of stopping it? That's just one example, but they're just wrong, and we've written, and there's lots of reasons why they're very wrong.
I'll get the details of the paper, so
No problem. No problem at all.
Thank you.
Thank you for that wonderful presentation. Let's have a big round of applause for all these speakers. And with that, we come to end of this session. Thank you for your patient listening. Over to the organizer for next session.
Please. And for the next session, can I please call our chairpersons, Dr. Sujoy Ghosh, who's a professor of endocrinology at IPGMENR Calcutta, Dr. Manilka Sumant Lekke, consultant endocrinologist at the National Hospital of Sri Lanka, and Dr. Mayur Agarwal, founder and director at Hormone India, and chief consultant endocrinologist at Apollo Bhopal. Over to you, chairpersons.
Good afternoon, friends. We move on to the next session, and the first talk will be by Dr. Wasim Hanif. He's going to talk on current goals of type 2 diabetes treatment. Is good glycemic control enough? And I'm not going to waste time in reading out his CV, because all of you have been introduced to him in previous sessions as well. The stage is all yours, sir.
Thank you very much, Mr. Chairman, for your kind words. This is a kind of a joint session of South Asian Health Foundation, UK, and Diabetes India. So I'm thankful to Diabetes India, Banshi, Manoj, Shashank, and the others for having this session. We had a similar session of Diabetes India at our annual conference in Birmingham in the UK last year. So it's good that we're working with our Indian colleagues on this issue. Now, the topic that I've been given is slightly bit confusing, because I would have not chosen this topic myself. It's current goals of type 2 diabetes treatment. Is good glycemic control is enough? My answer is very easy. Good glycemic control is enough for managing diabetes. And the reason I say that is because I trained to be a sugar doctor, and you know, whatever people talk, the primary issue is still the sugar. Although I'll talk about the cardiometabolic renal agenda, which is fine, it is being pushed, and we'll try and examine how it is, and especially because my area of research interest has been the South Asian populations in the UK. I will try to give a South Asian or an Indian angle to it. Now, you must have all seen this slide, which is used in multiple presentations. Rest in peace, died with a perfect HbA1c. And especially with SGLT2Is, this was promoted, I think by the ADA, I don't know, with known diabetes by heart. So let's see where it comes from. Now, this is very well known. This is that nearly 2/3 of deaths in diabetes are attributable to cardiovascular disease. All of this paper is from 2016, and the rates have come down. But still, most of our patients with diabetes will die from a cardiovascular event. Now, to understand diabetes, we just need to take a step backward and see where does the definition of diabetes comes from. And this is where there is an issue. So when Alberti went out to Tanzania and looked into the eyes and gave us diabetes, the definition of it, not the thing of that, it was just based on a single criteria. The glucose levels that causes background retinopathy. That was the criteria for diabetes. And since then, all the definitions, whether the ADA brings it down to 5.7 or the Brits get it to 6.5, Indians do postprandial, it is still based on the microvascular complications of retinopathy. So, if you're going to treat a disease whose endpoint is microvascular disease and expect a kind of a good macrovascular outcome, there is a bit of a paradox, and we all need to be aware of that. So let's examine the natural history of type 2 diabetes. We all know this. We are not going to really go through it. And we actually go from a phase of pre-diabetes, you can call it insulin resistance, obesity, to developing of microvascular, macrovascular complications. Now, this is a 20, 30-year journey of our patients. But the point that we are still not sure is at what point of intervention do we prevent macrovascular disease, specifically cardiovascular disease. We know the point for microvascular disease, but we still do not know the point for macrovascular disease. Now let us look at the Indian phenotype, which is very interesting. Now, one of the things when we look at the prevalence of diabetes in an Indian population, we talk it's 15%, 18%, 120 million. The way I look at it is, what is the lifetime risk of developing type 2 diabetes? And if you are an Indian, it is 64.6% for a woman. So nearly 2/3 of the people are going to develop diabetes in their lifetime, and nearly half women and nearly half of men are going to develop type 2 diabetes in their lifetime. So which means that just targeting sugar is not going to be enough. We will probably need a kind of a multi-pronged approach to really look into it. And this brings about the story of the two types of diabetes in the two Indians. One is the Western concept of diabetes, which we have got from the Pima Indians, and then is the Asian Indian phenotype. Again, I don't have to go into the detail, but this is a thin person. Perhaps the beta cells are not working in them. They have got low beta cells. We had an excellent talk by Ranjan, who's presently chatting to someone else, about the low beta cell mass in an Indian cohort. So their insulin level, so if you're going to measure C-peptide, is going to run low. So again, glucose becomes important. This is our early work which we did with the United Kingdom Asian Diabetes Study, which cohort we set up 20 years ago, and really confirmed this, that if you are a South Asian, your HbA1c will be higher at the time of diagnosis, and throughout the secular trend of 20 years they were followed up, there was a 1% difference between a white European and South Asian in terms of their diabetes, and their cardiovascular risk was they died 10 years younger. So before we talk about whether we need a glucose-centric approach or a glucose-centric target for managing type 2 diabetes, we need to ascertain which type of diabetes does a person have. And this is a paper which was published in this Lancet Diabetes Endocrine. There have been other papers published by Shashank and others from India. Again, talking about all of these are observational based on cohorts, really talking about various types of diabetes. So if you have got mild age-related diabetes, glycemic control doesn't matter. In obesity-related diabetes, it's more about managing weight, managing cardiovascular risks. Diabetes control does not matter. But if you have what we call severe insulin deficient diabetes, which we see in Indian cohort, then glycemic control is important, and you cannot forget the glucose levels. So now this is some very interesting data from the United States, which actually compares population with diabetes or without diabetes, and it actually shows when it comes to cardiovascular complications, they are coming down, and they're coming down pretty dramatically, both in people with diabetes and without diabetes, more so in people with diabetes. And this is probably not due to glucose management, it is due to better cholesterol management, less smoking, more exercise, and perhaps obesity. But if you look at conditions like end-stage renal disease or microvascular complications, they are pretty stagnant, and they're not really shifting. Now, this is again a very interesting data from the Swedish National Diabetes Register. and it actually shows, it looks at, which has been a big population followed for nearly 6 years, and it actually shows that if you manage all the risk factors for diabetes by whatever medications, you actually improve the lifespan of people with diabetes more than people without diabetes. So that is an important tool that we have got now, that we have got enough tools in terms of blood pressure, cardiovascular, and other management that we can improve. So what do the cardiovascular outcome trials say about people with diabetes, both in terms of glucose and the others? Now, most of the drive for managing or looking at a cardiovascular outcome approach for managing diabetes rather than glucose-centric came from the GLP-1 trials, although the SGLT2 trials actually started it. If you actually look at all the SGLT2 trials except EMPA-REG, there are very few clinical trials that actually showed a cardiovascular benefit in terms of cardiovascular outcomes. I'm talking about myocardial infarction, cardiovascular death was only seen in EMPA-REG. But if you look at the GLP-1 CVOTs, they actually show a trend. This is a meta-analysis showing that they may have a cardiovascular benefit. Now, what happens when we look at the index of glycemic control? Now, if you look at the index of glycemic control, this is a meta-analysis of all the known glucocentric trials in terms of cardiovascular outcomes. And you could see that actually they slightly point towards better glycemic control, improving cardiovascular outcome. Now, if you look into this more closely, definitely the effect is the effect size is much more stronger for microvascular complication, but even macrovascular complications or mortality, you start seeing a positive effect in terms of good glycemic control, in terms of reducing the risk. So how do these trials fit into the whole cycle of diabetes? So here, if you look at the UK PDS trial, it clearly shows a benefit both in terms of microvascular and macrovascular complications. As we know, in the UK PDS, these were newly diagnosed people with diabetes who had intensive control. In ADVANCE, which was a trial in patients who already had established cardiovascular disease and over 10 years of diabetes, you see microvascular but no macrovascular benefit. In ACCORD, in which people had advanced cardiovascular disease along with advanced diabetes, you see a microvascular benefit but see a macrovascular harm. VADT was unequivocal. So what you are trying to see is whether the glucose-centric approach works or not depends not only on the type of the patients, the type of the diabetes, but the history of diabetes when you are intervening. And this is very obvious from the treat to target approach, intensive to begin with, and then you do it. But to the proponents who say the glucose-centric approach is not for diabetes, you need to go back. So this is a very interesting, the DASG study, which actually was one of the first studies that shows it was possible to prevent diabetes, and you could prevent diabetes by intervening in the pre-diabetes. And this is the a post-hoc analysis, so which is 10 years after the cohort. And what it actually shows that in the patients who managed to lose weight or reverse diabetes, they were getting a cardiovascular benefit even 20 years down the line. Just showing that early intervention, even if it was for a short period of time, that delays the diabetes, which is a glucocentric intervention, has a positive effect for a long period of time. We also know from the UK PDS that as the time passes, the glycemic control tends to deteriorate. And this is across the board, it doesn't matter which treatments do you use. Now in India and across the globe, the biggest challenge that we have got is the young type 2 diabetes. We had the Ahmedabad declaration earlier this morning, and this is looking at people. So young type 2 is defined as anybody who develops type 2 diabetes at the age of less than 50 years. And these are the big cohort populations. And there was this meta-analysis which actually showed that if you have got young type 2 diabetes, you do worse than people with type 1 diabetes, be it in terms of your renal outcomes, be it in terms of your end-stage renal disease, retinopathy, and all-cause mortality. So again, suggesting that this is a group of patients which needs to be intensive, both in terms of cardiovascular as well as glucocentric management. So what do we have for diabetes? How much is glucose important, or can we completely ignore the glucose? Now this approach, which has been part of the ADASD, and you must have all seen it, does make sense. It does talk about glucose, but at the same time, it is important to look at other cardiovascular profile and manage it. At the same time, things like diet, lifestyle, physical activity, sleep, is all important. Also, it's important as to which medication we use, how we use the medication, and again, this depends upon not only the type of person who has got diabetes, the type of diabetes, the duration of the diabetes, and the complications. So the whole point of one size fits all is no longer there, and we will have to tailor what we call patient-centered approach. Although we've been using individualized treatment, we did not know who that individual was, and this really helps us to find that individual. Now, this is the ADA standard for medical care. I think Kamlesh was part of this, and this does make sense in holistic approach, which talks about the evidence that for heart failure, SGLT2 inhibitors have got the strongest evidence. For CKD plus albuminuria, again, SGLT2 inhibitors, although there is evidence emerging with GLP-1s. For ASCVD, GLP-1s definitely have got a much stronger evidence than the SGLT2 inhibitors. So what are we really looking at? So the chairperson, so this is what my kind of a thing is when it comes to diabetes or type 2 diabetes and management. The diabetes, cardiorenal, and heart failure is a continuum. So if you're looking at a primary prevention, which is be it at the pre-diabetes level or even earlier, at that stage you are looking at programs that are going to prevent diabetes, be it stop obesity, or even when you're identifying pre-diabetes like NHS diabetes prevention program, you're trying to do everything to prevent that single person developing diabetes. And even if they develop diabetes, if you can postpone it by 2 or 3 years, you will be reducing complications. So I think that is where you get the biggest buck for money, both in terms of glucose management. Then you move into secondary prevention. So secondary prevention is when somebody has already been diagnosed with diabetes, and again, you're trying to control the diabetes or the glucose levels much more rigorously so they don't develop any complications. If you fail, and most of us fail in that, you get into what I call the atherothrombotic continuum. So here you've got risk factors, which is dyslipidemia, hypertension, inflammation, stroke. So you get into the cardiovascular management. So this is about 5-8 years of diabetes. Here we are talking about management. So your cholesterol, blood pressure, healthy advice, making people quit smoking, doing comes in. If still the patient is not caught and he still continues, he gets into a renal continuum. In the renal continuum, you've got to measure things like ACR, follow the EGFR, and then you start looking at albuminuria, EGFR, ESRD, and treat them appropriately with ACE inhibitors, SGLT2 inhibitors, finerenone, etc. And then you finally get into the heart failure continuum, which actually can happen anytime during there. And here we have got the role of SGLT2 and other lot of medications that come in. So if you're going to explain the findings, should we even attempt to explain what I would call the unexpected. So glycemic control, it is time to onset too rapid, glycemic differential too small. Inconsistent with previous trial, volume depletion, perhaps there is an explanation. Risk factors probably have got the strongest evidence, and weight loss, again, there is a lot of evidence emerging. So what's new in diabetes world? I always say it's the same thing: patient-centered approach, patient-centered approach, patient-centered approach. So this is some work I did with NICE few moons ago, and this basically look at the whole intervention strategy to prevent diabetes and prevent diabetes complications, and that starts outside the medical consulting room. It starts with what we call an upstream prevention. It is a good advice, be it managing diet, lifestyle in schools, having enough playgrounds for the kids to play, having enough social housing, and as Kamlesh mentioned, social determinants of health to stop getting people, and especially in a population like India, where the risk of developing diabetes in women is about 65% and men is 50%, you need these measures to get on. And then only it's going to possible. And this is a document freely available. If you get a chance, just read it. Type 2 diabetes prevention, population and community level intervention. And finally, if you're not able to do that, now we have got the medications. These are going to cost you a lot of money. So this is a publication from New England Journal of Medicine, published quite recently on tirzepatide, showing when you use tirzepatide, either in pre-diabetes or diabetes, it actually reverses diabetes and makes the HbA1c normal. But this is going to cost you money. Thank you.
Thank you very much, Dr. Hani, for that very interesting lecture. And the floor is open for questions because the other lectures are not connected. So we would like to allow the questions on this topic. The floor is open. Anybody?
Yeah, if we don't have any question, I'll ask one.
Sure.
Yeah. So obviously you said about all those drugs, and that is for the diabetic. What is your take on the pre-diabetes? Because we know they are at increased risk of neuropathy, nephropathy, and even cardiovascular risk.
So if you look at the evidence, the strongest evidence for pre-diabetes, as we call it, is for lifestyle. So if you have got a lifestyle intervention, and this has been shown in all the populations, be it Chinese, be it Indians, be it Afro-Caribbeans, be it Hispanics, be it in a white population. So lifestyle, which includes, a 600 kilocalorie diet and 150 minutes of exercise, if you're able to lose 5% of the body weight, you decrease the risk of progression to diabetes by about 60%. So the strong evidence of lifestyle. What about medication in this population? So the earliest evidence, it came from DPP along with the Indian Diabetes Prevention Study by Ramchandran. It actually showed in an Indian population, the risk reduction with metformin is about 30-39, which is the same as lifestyle. We can look as to what's the reason. Again, it points to a lower beta cell mass. So there is definitely a role for metformin. Even NICE in the UK recognizes that if lifestyle is not working, and especially in South Asian, you can use metformin. If you're looking at other drugs that have evidence, there is, although people don't talk about it, there is evidence with pioglitazone in the DREAM study about decreasing protection, but there are issues with glitazone. It was with rosiglitazone, but with pio also is there. But if you look at the GLP-1 analogs and the tirzepatide, GLP, GIP, again, at a higher doses, especially in the weight management trials, they again showing evidence that if you use the drug early, there is evidence. So some of these drugs have got a role, but it depends upon, again, on the individual patient.
This was regarding like conversion of pre-diabetes to diabetes.
Yeah. So this will stop the conversion from pre-diabetes.
The other part of the question directly affecting the cardiovascular mortality in pre-diabetes.
Yeah.
That is, do we have any data on that?
Do we have the, if you actually look at some of the old clinical trials and stuff like that, we are waiting for the cardiovascular outcome trials, because some of the cardiovascular outcome trials that have come with the GLP, especially around the weight management, they did have a pre-diabetes population. But do using these drugs in pre-diabetes prevents cardiovascular outcomes? I think still we don't know.
Just a quick one, if I may ask you about the advanced trial.
Yeah.
You remember there was a concern about increased mortality among the tightly controlled, which is against what you are saying. I mean, some
No,
task.
No, advanced trial, I did say advanced
Sorry,
trial.
Accord trial.
Accord. I did show there was an increased mortality with macrovascular. But this was a very different population. So this was a population that had advanced heart disease, that had hypoglycemia, they had weight gain. So this cohort is there. But if you look at the UK PDS cohort, there was definitely a benefit.
I think we can close the session because we are already running 20 minutes late. Thank you for that insight, sir. For the next talk, we have Dr. Kamlesh Punti, sir. He will be speaking on are the current strategies delivering the holistic treatment approach for people living with type 2 DM. And everybody of us know, just a brief introduction about Dr. Kamlesh, sir. He is Professor of Primary Care Diabetes and Vascular Medicine at the University of Leicester, UK, and Director at NIHR. Over to you, sir.
Thank you very much. I've seen, just noticed that 3 of the speakers are from the UK for this, and there's a British flag. I think we should have an Indian flag here as well, because all of us have dil that's in Hindustan. So thank you again for the invitation. These are my disclosures. So over the next few minutes, I'm going to go through background to holistic care, evidence for early interventions, guideline recommendations, this is what we call efficacy to effectiveness gap, and potential solutions. So in terms of the background, we know that diabetes is a multi-system disease. There's multiple defects that contribute to development of hypoglycemia and then eventually diabetes. And that's why a single intervention is never going to be enough to control hypoglycemia and prevent people from getting not only hypoglycemia but also complications as well. These are data from Sweden, similar data in US as well, that we are improving outcomes for people with diabetes. So as you can see, over 20 years, there's been reduction in death from any cause, death from cardiovascular disease, death from coronary heart disease, and hospitalization for cardiovascular disease. In the red is the matched control population with diabetes, and blue is the people with type 2 diabetes. So although there's reductions, the gap still remains between people with diabetes compared to the matched control population without diabetes. Over the last 10 years or so, we've been putting a lot of emphasis on cardiovascular outcomes and preventing cardiovascular outcomes because of the cardiovascular outcome trials. So this is, I think, probably one of the largest observational prospective studies. We conducted this as a part of the Discover program. 33 countries, we had about 15,000 patients, participants. Here we're just showing data for 33 countries because of data issues, getting data from the other countries. But what we see on the right-hand side is the cardiovascular disease risk is improving. As you can see, there isn't a huge increase over the 3-year period. Starts at around 13%, it's at 15% over a 3-year period. On the left-hand side is the cumulative risk for microvascular complications. As you can see, there we see still steep rises. And the main reason, I think, is because we've been putting too much emphasis on cardiovascular outcomes and not so much on glycemic control. That was talked about eloquently by Wasim. So what's the evidence for the interventions? Well, we have the UK PDS Accord Advanced VADT. We see that if we go early enough, we get reductions in microvascular complications. And if we start very early from diagnosis, like UK PDS has shown, we will get associations with reduced complications for cardiovascular disease and possibly mortality as well. All the others, people had diabetes for about 10 to 12 years. And so we didn't see any benefits in terms of cardiovascular outcomes, but we did see benefits for microvascular outcomes. We now have excellent data for the organ protective therapies. So this is Seto Knutzer, who did this from our group, looking at 20 randomized control trials for SGLT2 inhibitors. And we see 3-point MACE reductions of around 12%, significant reductions for 3-point MACE. We see around 40% reductions for microvascular disease, and combined micro and macrovascular, we see about a 14% relative risk reduction. Similarly, we have GLP-1 receptor agonists at our armament, and again, we see microvascular benefits, 3-point MACE reductions around 15%. Microvascular benefits about 14% relative risk reduction, which was significant again. And so we have excellent data from randomized control trials, not only for glucose control, but for organ protective therapies as well. And then we have data from lots of other studies looking at legacy benefits for risk factor control. Most of the time we talk about legacy benefits for glucose, but there are legacy benefits for blood pressure. Glucose, as you know from the UK PDS, 44 years from when the trial started, so 24 years from when the trial finished. For blood pressure, we have 10-year legacy benefit data, lipid lowering 18 years of benefit data. And for multiple risk factor control from the Steno trial, we have 21 years of data of legacy benefits there. What do the guidelines tell us? Well, guidelines are now very well evidence-based for the first time. Previously, we could do anything we wanted. But now on the left-hand side, if they've got cardiovascular disease or very high cardiovascular risk, we start on organ protective therapies, GLP-1 receptor agonists and SGLT2 inhibitors. And that's about 30% of the population. For the 70% on the right-hand side who don't have those cardiovascular disease, then we can opt for any therapy depending on various characteristics of that person who's in front of us, including cost as well. I always ask this at every meeting. How many people have seen this? Well, everyone's seen this at a diabetes meeting. Yeah. How many can tell me what that blue circle is on the right-hand side? No one can tell me what that blue circle is. So we'll come to that. You've seen this hundreds of times, but you can't tell me what the blue circle is. We'll come to that shortly. So the key goals are cardiorenal risk, as we've heard from the previous talk, because there are multiple risk factors that we need to manage, including HbA1c, blood pressure, lipids, BMI, smoking, etc. So in terms of therapies, we have a huge number of therapies at our armament. Metformin, obviously the first line. And then we've got the sulfonylureas, TZDs, DPP4 inhibitors, SGLT2 inhibitors, and incretin receptor agonists. And now we're seeing dual receptor agonists and triples are on their way. And there are 70 molecules in development at the moment with the GLP-1 receptor class. So lots more coming in as well. So we can't say we haven't got enough therapies there. All of them have benefits in terms of glycemic control, some more than others. Hypoglycemia risk with some, such as sulfonylureas and insulin. Weight gain with some. So lots of options depending on what we're looking for that person who is in front of us. So despite this, despite all the evidence base, we still are not translating this into clinical practice. And this is what we call the evidence to effectiveness gap. Efficacy to effectiveness gap. Efficacy is what we see in a randomized controlled trial, get huge benefits, but they don't translate into the real world practice that you and I will be looking after the patients in. And there are a number of reasons for evidence to effectiveness gap, and one of them is therapeutic inertia. We used to be called clinical inertia, but we now call it therapeutic inertia, and that's where the blue circle comes from. The blue circle is on most of the guidelines now, not just for diabetes, for other guidelines as well. To avoid clinical inertia, reassess and modify treatment regularly every 3 to 6 months. And that's exactly what we are not doing for our patients. Therapeutic inertia is failure to advance therapy or to de-intensify therapy when appropriate to do so. So when we don't intensify that therapeutic inertia, but at the same time, if patients are elderly, frail, they're on therapies that cause hypoglycemia or hypotension, we don't stop that. That's also termed therapeutic inertia. And this is the evidence, and there's lots of this evidence around. So this is from US 20-year data. As you can see, despite all of these fantastic therapies, glycemic control is a flat line. About 50% of people are achieving a target of less than 7%. Blood pressure targets improved, but again now, if you look at tight targets, it's about 50%. Lipid targets improved, but now again showing we're stagnant. And when we look at all three risk factors, we said multiple risk factors are important. About 22 to 30% of people are achieving all three risk factors, and we see this in the UK as well. And one of the reasons it says therapeutic inertia, just to show this from the Discover study, this is data now I'm showing from 6 regions, 37 countries. This patients, the participants were recruited when they initiated second-line therapy. And as you can see, they had diabetes for about 5 to 6 years on one therapy. They'd been on one therapy for 5 to 6 years before the second-line therapy was initiated. The HbA1c when second-line therapy was initiated was around 8.3 to 8.6%. And they'd already got microvascular complications, about 20%, and 15% had already got macrovascular complications. So despite all of these complications, we were waiting too long to initiate the second-line therapy. And estimations are that we wait when persons on one oral therapy and their HbA1c is above 7.5%, we wait a median of about 7 years. If they are on 2 oral therapies and we're going into third therapy, we wait 6 years. And patients going forward to insulin, we wait about 6 years. So constantly we are waiting. And this is a global phenomenon. This is a systematic review we conducted over 50 studies showing that whether we're starting the first therapy, second therapy, third therapy, going on insulin, we are waiting far too long before we manage that patient. And this is why now we're seeing this in the new organ protective therapies as well. This is data from US, 1 million patients, routine database, my friend of Mikhail Kossi borrowed. As you can see, use of GLP-1 receptor agonists or SGLT2 inhibitors very low among cardiologists, endocrinologists, and primary care physicians, worse in primary care physicians and cardiologists. If you look at endocrinologists, about 40% are using SGLT2 inhibitors or GLP-1 receptor agonists. And there was this paradox in that people who needed it were less likely to get it. So when we're using it, we may be using it for inappropriate patients. So what are the consequences of therapeutic inertia? Well, you can't do a randomized controlled trial because that would be unethical. So the only way you can do this is by routine database studies. This is a study from the US where they looked at participants who had retinopathy and they classed people into having inertia or no inertia. And those who had inertia, they had greater progression, 5 times greater progression to retinopathy progression compared to those who didn't have inertia. This is a study, we did it with Sanjoy Paul. Sanjoy Paul, the name may not ring a bell, but he's the person who did the UK PDS analysis. He's a very good friend and we still continue working together. And what we did here was trying to emulate the UK PDS study using routine data. So we looked at a population whose HbA1c came down from diagnosis below 7% within 12 months. And compared it to those who didn't get their HbA1c below 7% within the first 12 months. That was 26% of the population. And over a 5-year period in this retrospective study, we saw that there was an increased risk of myocardial infarction, stroke, heart failure, and composite cardiovascular events in those who had inertia compared to those who didn't. And we call this the dysglycemic legacy. That's driving the complications in the longer term. And finally, this is from letter Neda Latpong in US, again showing every year you wait, you get increased risk of mortality. So for example, if the HbA1c is high and you wait 6 years before initiating therapy, there's a 54% association with increased mortality, and every year increases mortality risk. So data showing inertia leads to microvascular complications, macrovascular complications, and mortality as well. The other big reason is adherence, and we know from data for the proportion of people who are classed as adherent between 3 to 36 months in these studies. For OADs, it's about 44 to 90%. For GLP-1 receptor agonists, it's 30 to 54%. And for insulin, the estimations are about 19 to 54% are adherent. What does non-adherence do? Not only does it not lead to improved risk factor control, but also is associated with increased mortality and hospitalization. This is a systematic review of 8 observational studies. Non-adherence in this study was 37%, and what we found was that good adherence was associated with reduced risk of hospitalization, so around a 28% relative risk reduction in hospitalization and about a 10% reduction in all-cause mortality. So non-adherence not only worsens risk factors but leads to hospitalization and mortality as well. So what are the solutions to improve outcomes? This could be a talk in itself. These are the barriers that people find. Sorry, it's not come off well. It's therapeutic inertia, patient and physician barriers. And there's lots of barriers. You and I know about this risk of hypoglycemia. We think it may impair quality of life. There's financial restrictions, beliefs that patients may not be competent. There's resource issues. There's complex regimes. So adherence is poor. We worry about excess weight gain, lack of education in certain populations. And these are all things that are manageable by us with the appropriate tools in our armament. One of them is having combination therapy from the start. This is a verified study. I think most of you know about this, where early combination therapy from diagnosis showed that people were more likely to stay in control of the HbA1c. The HbA1c control here was classed as 7%. And we saw that at the bottom in the blue is the stepwise approach that we do currently. In the top in the red is people who had, in the bottom is combination therapy, metformin and vildagliptin. In the top is metformin plus placebo. And we got more people to target with early combination therapy. We also know that combination therapy with metformin is associated with reduced risk of proportion not failing with HbA1c control. So meta-analysis has shown that if we have combination therapy compared to just metformin, there's a reduction in HbA1c of about 0.43% and about 40% more likely to reach a target of less than 7%. And fixed dose combination therapies, very few studies, interestingly, but they do show positive reductions in terms of 0.5% reduction in HbA1c if we use fixed dose compared to co-administration of the dual therapy. There's lots of interventions to try and improve adherence, dose simplification, patient education programs, reduce the cost of the therapies, improve shared decision making, interventions delivered by nurses and pharmacists, and these have all got good evidence base for them. Finally, interventions to overcome inertia. This is the only systematic review American Diabetes Association commissioned us to do this because there weren't any systematic reviews of overcoming inertia. So what we see here is that, first of all, doctors are the worst at overcoming inertia. Interventions that uses doctors don't lead to improvements in outcomes, and that's as you can see here, physicians in the second from the bottom. The people who do best is the top, that's pharmacists, and at the bottom, nurse educators. They lead to better improvements in HbA1c compared to doctors or anyone else. And that's why the model of care in the UK is that we're using more and more nurses and pharmacists for managing our people with diabetes. Education programs we don't put as much emphasis on. Just imagine if there was a drug that reduced HbA1c, that reduced fasting plasma glucose, that improved diabetes knowledge on our patient with diabetes, that improved self-management skills, that improved weight, that improved treatment satisfaction, that improved adherence, that improved smoking cessation. We would snap at that drug. Well, there is such a drug, and that's called self-management education program, and it's very, very cheap. In the UK, we've estimated from the trials that we've done, it's about £80 a year. And we don't emphasize enough for our patients to get self-management education programs, but we are easily willing to write a prescription, £100 prescription for a GLP-1 receptor agonist every month. So we should emphasize self-management education programs. So in summary, type 2 diabetes is a progressive disease. It's going to need lifelong treatment. There's strong evidence to support the early interventions in tight glycemic control as well as other risk factor control leads to better outcomes. Despite all the amazing evidence we have, it doesn't get implemented into clinical practice. And we really need to be starting early, just like the UK PDS did, to improve the beta cell function. And combination therapies with complementary modes of action is something we should be thinking about. And we were talking earlier from the UK group that India is really good. We see combination therapy with triple therapies. We just don't have those there at the moment. And even when we do have dual therapies, we don't tend to use them as much. And there are many other interventions that I've talked about that and improve risk factor control. But it's really, we need to individualize our plans for that person in front of us to have a better length of life for those patients. Thank you very much for listening.
Thank you, sir, for that great talk. We have some 2 minutes left. The house is open for question. Anybody would like to ask any question? We don't have any question. I'll ask one. So your talk was on the current strategies for the holistic treatment. I would like to know what drugs or what other treatment would be available, are in pipeline in next, say, 5 years, which will address something else or extra thing which are still missing out.
So the drugs on development at the moment, especially for the GLP-1 groups, we know GLP-1 receptor agonists, you lose weight. So there are agonists that are coming which preserve your muscle mass particularly. So they're coming. So we're going to see huge. There's 70 in the development at the moment. We will see more and more drugs coming that have kidney protection there in trial, and those that help heart failure as well. Those are the areas that we're concentrating on, because we know diabetes will affect those. More people with diabetes get heart failure, more people with diabetes get kidney disease, and we now say that they have multiple long-term conditions. So multiple targets, we're not only improving diabetes, but the other targets, and that's, I think, where the development program will go. If you talk to me now, I say, well, when we go to the big meetings, we get asked to talk to lots of CEOs of the large companies, and they say, where should we be going next? And I said to them, we've got enough here at the moment. We've got so many drugs, but we're just not using them.
So can you just name few of the drugs which are still in pipeline, and maybe there are some advantages?
They've got numbers. They haven't got names.
Okay. Okay.
Gentleman.
Hi, Kamlesh. So the title was about holistic care. So I wondered what you thought about your role as a family doctor and physician in creating an enabling, empowering environment for people to have a healthier diet and healthier physical activity.
So that's a long question, we can talk about that all day. But I always say, Simon's a good friend, we're both general practitioners. We're probably the only two proper doctors here. We're general practitioners, we're not diabetologists. And I think you do need to look at the person holistically, and in terms of they don't have just one disease, they have lots of diseases. And I think care coordination of that whole person, because we may be managing their depression now, but not, managing their diabetes, but they're depressed. If we don't identify that and manage that as well, we're not going to get the right outcomes for that patient. So a whole person approach is what I would be thinking about holistic management.
So I think we will thank you very much, Dr. Kunti, for that interesting lecture. Next lecture is going to be by Dr. Partha Kha. He's a well-known world authority, I think, when it comes to diabetes technology. He'll be talking about innovative treatment strategies. Will they make a difference? More of the same. He's a national specialty advisor on diabetes for the NHS UK, among many of his achievements, and he's a multifaceted personality, I would say, looking at, apart from all his academic achievements, he's involved in the digital self-management platform, The Language Matters, and type 1 diabetes comic in UK, and he received the OBE for services to diabetes care in 2021. Over to you, Dr. Kha.
Thank you very much. You've heard two fantastic talks which sets the scene and the challenges which Kamlesh mentioned too. So I'm just going to give an overview as to how much things have changed for all of us in just a decade. And I think that's quite important for us to sort of go forward. So if you think of it, I remember those slides when they said if you had diabetes, that was it. Your beta cells just went down. And we've changed that thought. We now talk about reversal. We have debates whether it should be called remission. That's been new because of the research done by Roy Taylor and his group. There is forever a debate about what's the best diet ever. Is it low carbs? Is it low calories? Everything. And as we continue saying, and the best diet in the world is the one you can realistically afford. And that's always the challenge. How can you get affordability in the picture? Metformin is being challenged. In fact, our cardiology colleagues say that it shouldn't be first line. The European Society of Cardiology said if you have type 2 diabetes, it shouldn't be metformin. It should be the other drugs, which was unthinkable, at least when I was in training. There's a new classes of drugs which you've heard about, outcomes. And for the first time, we've got drugs that get genuine outcomes. We've got drugs that disease modify or outcome modify. And then finally, in England or in the UK, we have this organization called NICE, which simply answers a simple question, which is, or works on a simple principle, which is think like a patient, but act like a taxpayer. And thereby comes $1 billion question, what can the taxpayer afford? That's the conversation which always goes around. So this is the big thing. Let's be very honest. You know, I remember, and this is not even a joke, when I was training, the reason I did diabetes, because I thought type 2 diabetes, and my consultant told me this. He said, do you know what? This is easy. Tell people to eat properly, exercise, bit of metformin, bit of sulfonylurea, and give them some insulin. And I said, is that it? And they said, that's it. That's all you need to do. And I said, I can do this for the rest of my life. Then if you see what's happened is this fundamental shift of weight, which has suddenly changed the dynamics as to where we are. And that's a revolution in pharmacotherapy happening today. We're all having discussions around it, and we haven't even had the other drugs come out, and, you know, there's some other molecules coming out. So, as Kamlesh beautifully said, it's not a lack of drugs, it's a lack of drugs in people's lives, which is the bigger challenge. But you can see what's happened, the sales, and you talk about weight gain or weight loss, sorry, in this context, nearly getting up to bariatric surgery. This has been a fundamental game changer in the world of type 2 diabetes and now obesity. And this is the other one. For the first time, we could turn around and actually show data that certain drug classes made a difference to your long-term outcomes. Again, not something we had with metformin. Definitely we didn't have it with the SUs. We had studies which looked at all risk factors like STENO2 and UKPDS, but nothing specific classes. So now you've got SGLT2s, you've got GLP-1s, all talking about definite disease-modifying outcomes. And then you've seen this chart, which is a big chart, and the blue box. Kamlesh took my sort of thunder away with the blue box comment, but it's always quite fascinating. Do you know what is even more fascinating? I always say this, is because all guidelines come out and they have a little bit of a what we call a bit of an escape clause. Do you know what the escape clause is? Is that at the end, which is if the cost is a major issue, can you just use metformin and sulfonylurea? Well, cost is a major issue for everybody, unless you can afford to pay it out of your own pocket. So the problem happens when you sort of always, there's evidence and there's a finance balance that you go with innovative treatment. This is happening all around us. Connected insulin pens, digital systems, EHR, electronic health records, all designed to try and make life easier, right? That's the whole point. So I always give this example, and those of you who heard my last talk will have heard this. Is there anybody in the audience who remembers going to a bank and putting in money by hand, cash? Who remembers doing that? Okay. There's a lot of people in this audience who are basically saying, what do you mean money by hand? Because they never have seen money by cash. A lot of people are saying, what do you mean banks? Like beyond an app, there's like a physical building? That's the change. There are people in this audience who will remember, I remember buying a plane ticket. You had to go to a proper place. And they used to give this ticket with lots of papers on it. Right? So technology has changed our lives, and in healthcare, that's inevitable, that will happen. So, and those of you will also be long enough to remember there was a time when you had to dip your, urine to find out about the glucose. We then moved to glucose strips. Now we are moving into non-invasive. So it's all an advancement of science to make life better. It's a quality of life metric that's changing as regards technology goes. There's this we talk about, we want to do all this, and this is innovation, this is coming forward. This is, I don't classify this sort of thing as innovation. I always say this is progression. This is just progression because in all spheres of life, for us, technology has come through. Banks, movies, as I said. How many of you, I remember growing up in India, right? And nowadays people talk about all these new movie stars about having aura and, lots of people. You haven't seen anything. We used to go and watch Amitabh Bachchan movies. That was something. We didn't have anything like Netflix and Amazon and videos and YouTube. You had to go up and line up. and you never got a ticket for the first few weeks. That's the change that's happened in our lives. You can sit, you can watch, you can decide, and you can go and watch it at your home, at your own leisure, by pausing it as many. Technology has happened everywhere. Technology is happening in health. Papers to look at, I always say, so this is the big thing. And me and Sir Professor Yagnik at the back was talking about it. What is the big thing people talk about? Artificial intelligence. Everybody. So what has artificial intelligence done? Where is the evidence base? You might want to have a read of these two papers. They're two actually good papers which summarizes the issues with artificial intelligence. But it also opens up other areas. Does artificial intelligence and ChatGPT open up to, for example, compromising proper research? Probably does, right? Because you're writing now theses and papers based on ChatGPT. It's not proper science. So where does technology innovation fall in? Where does it actually try and deregularize science? Is a very important discussion that needs to be had going forwards. Does it have a role, for example, and we talk about this in the UK, retinal screening? With all the retinal images that we have, can artificial intelligence help predict who is going to have a retinal issue so we can target it? Can artificial intelligence look at who might develop a problem? Precision medicine. Shivani Misra talks a lot about that piece of work. Can those things look at it? And these two papers do tackle this and talk about it. They're interesting concepts of innovation, but if you think about it, a lot of it is designed to do what? A, improve the quality of life, but lessen the burden on us. How many of you have ever seen a movie called Minority Report? Anybody seen Minority Report? Excellent. Tom Cruise. I'll tell you what the movie was about. You could predict the future, who was going to create a crime, and you can go and arrest them before. That's what you're trying to do with a disease, right? You're trying to predict who might be the best chance of picking up a kidney problem or a heart problem. Will science help us? Do we have innovation to do that? So that's a good piece. And from that paper, this summarizes some of the areas of artificial intelligence people are talking about now, the areas where it may work. And I stress the word may because evidence is very important. And I don't think we should forget in our zeal to adopt science the importance of evidence base and science. As I remember going to a talk where a gentleman talked a lot about artificial intelligence, and I always said, how have you validated that? What is the science? So we always get requests, and as mentioned, I do a national role in technology. We get approached by different companies saying, here we have a device, which is amazing. I said, how is it amazing? So if you put your finger on the app, your blood glucose comes up. And I go, that is amazing. That is amazing. Have you done any testing? No. And I was like, well, have you validated it against blood sugar readings? No, we haven't. So how do you know it works? But we think it's a really good idea. I said, yeah, well, of course it's a good idea, but does it work? And I think we need to be very aware of innovation, that question is asked regularly. The thing needs to work. The thing needs to change lives. The thing just doesn't need to exist, and I think that's an important thing. So this particular chart, I always ask people to look at. This paper talks about where in the world of diabetes, any types, could artificial intelligence have a bearing? And this is a lovely paper which just talks about where the possibility may sit. So technology, I'll tell you where we are in the UK. In type 1 diabetes, the role is established. We've got 98% pickup rates. It's a standard of care. We have worked hard to get it there, okay? It's in type 2 diabetes, it's been put at a cost-effective model for certain cases. The pickup rate, even in that cost-effective zone, is very patchy. And I'll come to that why. There's a potential high in all cases of type 2 diabetes, but the evidence base is sketchy. Would it work in pre-diabetes? Possibly. Would it work in tablet-controlled diet if you used it intermittently to give ideas about diet changes, impacts of medication? Possibly. Is there any evidence base to support that? Not really. So you see the sort of discussion that goes on, and quality of metric, and I always talk about technology as saying it's got a progression of science and inevitability around it. These are all the challenges that we have, and Kamlesh touched upon this, which is very important to remember, is that just giving out technology and going for the next big thing widens your existing gaps even more, okay? But we need to work together to do that. This is data from 2019, 20 and thereabouts in the NHS, where you can see a black child having half the chance of a white child. Asian as well, lower than white child. Same system. Okay, just to bear in mind. And that's what we need to challenge going forwards. This is where we are now, and that's after 7 years of work where it's all flat. So that's the important piece of work that we need to make sure that we're not jumping from one innovation to another without closing the gaps. So these are the ethnicity gaps I talked about, where there's white, Asian, and black. They're all quite close to each other. That's pumps. But it takes a humongous amount of effort and time. What we always see, as soon as you launch an innovation, the gaps open. The rich will get it first, right? So I'll give you an example. So I obviously worked with Dr. Sujoy Ghosh on a lot of issues around India. We're talking to governments, and we met some chief ministers and everybody. The conversation, and I've said this in my last talk, there's an India of two types, right? There's an India which watches Shah Rukh Khan movies in multiplexes, which puts a rocket on the moon, right? And can afford anything in diabetes care. There is also something called Bharat, whereby the kids need their insulin and their supplies on a regular basis to be stored in villages so they don't die. That's the dichotomy you're having, and that's not just here, it's everywhere around the planet. So what we're trying to do is, how can you try and narrow that? Does bringing more innovation widen that, or can you get it to more people? So the challenge for type 2 diabetes in my book is the competing issues. It's about, and here's the question, and nobody has to answer this, is that if you have somebody with type 2 diabetes, and I'll ask this question because I've asked in my last session, so I'll do it again. Who in the audience has got a sports car? Anybody got a sports car? Kamlesh? Not yet. Anybody got a sports car? Okay. Who would want a sports car? Yeah? Those of you who want a sports car, why haven't you got a sports car? You want it, why haven't you got it? Right, that's pretty much it in type 2 diabetes. Because when it comes down to it, you've only got one pot of money. The reason you haven't got a sports car, because you go, well, I've got to pay my house and my fees and my son's tuition and maybe get my wife a Valentine's Day gift or something. That's a bigger priority than getting a sports car. The problem with type 2 diabetes exactly sits with that. In a pot where you're tight, you've got 4 choices on your plate. Do you want to promote lifestyle and remission? Do you want to give an SGLT2 inhibitor, which reduces renal complications and is a disease-modifying drug? Do you want to give a GLP-1 analog, which is a cardiovascular-modifying drug? Or do you want to give a continuous glucose monitor, which could improve your quality of life and thereby your HbA1c? That's your challenge. If CGM was free, everybody would be on it. And there's the challenge. In type 1 diabetes, the challenge is less. You got type 1 diabetes, okay, the next thing is CGM and then hybrid closed loop. So it's quite straightforward. That's the only game in town, if you have money. So that's the problem that you have in type 2 diabetes about access and innovation going forwards. But let's also consider the other bits. What is the best diet? As I said, the best diet in the world is the one you can afford. Everything else is chat. That's all it is. Those of people who are maintaining diet and extremely well, do you know what they have? Fantastic willpower, backed by some amazing privilege in life. If you're not worried about putting food on your table for your children, you can do lots of maneuvers to have low carb all the time. Right? You can make sure you're making the changes, and etc. So that's the important thing to remember. But how much is behavioral change sustained? How long can you, who's tried a diet? Anybody tried a diet? You tried that? Did it work? It looks like it's worked. No? Nobody's going to commit to that. And nobody knows how to answer this. Shall I say yes or no? What is he going to say? Everybody tries a diet and then you stop. Because it's so difficult to sustain. That's the problem with diets. So evidence-based creation is important to try and help things going along. So important to say that these are the other bits that we need to bear in mind, and I just wanted to flag them. Increasing age with frailty. Age should not be a biomarker of whether you have the most modern treatments. What should be a biomarker is your quality of life and frailty. You might have somebody who's 84, fit and well, dancing, doing, so why not give them everything you can? You might have somebody with 69 with severe Parkinson's with a very poor quality of life. You don't know how long they'll survive. So these are different things to look at. The challenge is this paper which came out, which I love this paper which made me smile, and it crystallizes beautifully the challenge around the globe. paper which came out which says population health impact of new drugs recommended by NICE in England for 20 years across everything, not just diabetes, everything. What it's done is actually made population health go the other way. The authors, that's a view from the authors, their view is that if we had invested the money in better social structures, tackling deprivation, you would have had better outcomes. And that's a really tough place to be in, because NICE is also trying to bring in all these new drugs. So this is across cardiology, cancer, everything. It's a fascinating paper which makes us think as to, where are we and what are we trying to do and where we are. But it makes you think about, is innovation doing the thing that it needs to do, or are we, by doing innovation, inviting more people with privilege to go do better? Is that all we are doing? So to summarize, I would say the world is widening hugely. So as part of my work, I don't just work in India, I also have the opportunity to go to South Africa, Kenya, etc. I'll give you a little story about how the privilege and the differences we have. I remember coming back from India after having a meeting in Calcutta, etc. We're talking about what shall we do about the kids who need the education. Sujoy is doing great work, etc. I remember coming up the plane and getting an email in my role from a particular person with type 1 diabetes. No, sorry, not with type 1 diabetes, a clinician who looks after people with type 1 diabetes, was really annoyed that they hadn't got the exact type of hybrid closed loop. Not that they hadn't got hybrid closed loop, but the exact type of hybrid closed loop. And that to me is interesting, because you come off a plane in 7 hours and you dialogue, and because it's just two different words. In one world, I'm talking about how do I get these kids their proper insulin so they don't have stunted growth because they are being given very low carbs because there's not enough insulin in the fridge, which is what we have seen. And on the other hand, having a debate 6 hours later with somebody about why can't I get the tubeless pump again? Different worlds. So type 1 diabetes is seeing it in real time globally, right? And we talked a lot about, so there is a paper coming out which says every person with type 1 diabetes should have a hybrid closed loop. And I'm going like, well, we haven't sorted insulin out yet, let alone CGM, and we're trying to do hybrid closed loop. It's a big debate which needs to happen. And it comes to a decision point, which is what I wanted to say. I think the global health is actually moving in these two spaces. And I love the question that came from Simon, because I think if I had and I say this not because Kamlesh is here, I've always said this, if you had one magic wand to change diabetes care, you invest more in primary care and the settings around it. Everybody knows it. Everybody knows it. But what we do is we never give primary care anything. We always do the other way around. Because that's where it happens. Everybody knows you want to improve amputation, which is the biggest cost for the system. You top load primary care about prevention. That's how it changes things, not by having more foot teams. Everybody knows it, and I know it. I do a national work. But those are the two choices that's coming to governments and places everywhere. You either increase your healthcare spending, whether it's tax-based or insurance-based from the governments, state funding, or you think about, okay, the state will only fund people who are deprived, or you go into generics regarding affordability. Production's done in local places. India do their own pumps and CGM at their own cost. Or you have to decide on priorities. You have to decide, because you don't have the money to everything. Nobody's got the money to everything. That's the problem. And you can choose some, not all. So I think I wanted to finish with that. The benefits in diabetes care is rarely instantaneous. If you look at the papers being done by Wasim and Kamlesh and all that, you see it takes 7, 8, 9 years to get outcomes. That's the problem in diabetes. So I'll finish with that, just to say that innovation is great, but there is a reason why we're not being able to get into people's lives. And this is the decision points that we are all going to come to, not very far away, as to where people sit. I'll finish there just ahead of time. Thank you very much.
Thank you very much, Partha, and could stay here. If there are any questions, it's open to the floor. While they ask, it's very interesting, very thought-provoking speech, I would say, especially for us working in Southeast Asia. What is your take now, since you are up to date with all the AI? I thought in UK they are actively using the retinal screening with AI, or what's the situation? I thought.
I think you guys hear too much about the UK. Most of it is not true. I think they're started to try and look at it in certain centers. King's are certainly looking at it. Google have been trying to work with the NHS on the retina, but there's an issue around safety because it's not been validated yet. So I think there's a lot of interest in it. And some areas are doing it very much at a research mode. It's definitely not at high-end speed within the NHS, unless you guys have heard anything. But I think that's probably right. Yeah, Moorfield, yeah, with the eyes. Not across the board, no. Yeah. So very much in inception stage. So yes.
Thank you very much, Bart. That was great as always. I'm just wondering, where would you put age as a priority with the upcoming trend of longevity that we hear about nowadays?
Okay, so that's a fantastic question because I've got a view which is incredibly controversial, right? So you need to dissociate, and it's very difficult to do this, in a policy space. So I do policy. When people say to me, what is the biggest return of your investment? Because you're investing. It's children in type 1 diabetes. Other way around, okay? Because if I give everybody artificial pancreas, you've taken away complications from them for the next, 20, 30, 40 years. I think with age, that's the definition we need to, and that's why I said about priorities. That's not to say we say, so if the answer is, for example, forget age, should we prioritize people without complications? Now it sounds incredibly harsh, doesn't it? Straight away people go, what do you mean? It's the complications one you need to do first. So if you look at the Lancet Commission on obesity, that's what they say. My view is, it should be the other way around. Simply, not talking from a clinical point of view, not talking from a humanitarian point of view. Investing money is a very tricky space. So to your question, it's not the age. I would say, flip it around. If you want to give the biggest return for the money, unless people are putting it from their own pocket, it has to be people without complications earlier on to get your benefit. Now, that's incredibly controversial to put into place because the human aspect of it, I think as clinicians, myself, you struggle with that. But that's the way I would put it. Not age, other flip. That's where I would put my money.
Sounds like music to my ears. I'm a pediatrician, so I would love that. Thank you.
Pleasure.
Okay. Thank you very much. We would like to thank all three speakers for very interesting 3 lectures, and let us show them the appreciation the usual way.